Perseverance is that there is initial hair fall. This occurs within a week of initiation. It is not a complication, but it may point towards its effectiveness. So one should not be deterrent to use or defer its use seeing hair fall because there is a decrease in telogen phase duration. Hence, the patient must be counseled well. Next comes is finasteride. So finasteride also it was redundantly associated with low testosterone and low prevalence of androgenetic alopecia when castrated men or those with BPH who were using finasteride, they had good hair quality or low levels of low prevalence of alopecia. So the main villain over here is it is thought that dihydrotestosterone, that is DHT, acts as a acts in the miniaturization and follicular transformation to atrophic follicles. So testosterone by this enzyme 5-alpha reductase is converted to dihydrotestosterone, which acts systemically as well as locally on the hair follicles to cause their atrophy and follicular transformation. Finasteride by blocking this enzyme may decrease this effect. So once the follicle is atrophied, there is no use. It should be started early. Finasteride use. So ideal dosing is 1 milligram orally daily. It causes increase in duration of the anagen phase. It is most effective in vertex and mid-scalp health loss. Results are seen after 6 to 12 months of sustained and continuous use. Like purported or like any uncommon notion that it decreases the testosterone levels. It is not so. It does not have any estrogenic or anti-estrogenic, androgenic or anti-androgenic effect. Topical finasteride is an off-label use of finasteride for especially female pattern hair loss. It is available as a combination of finasteride and minoxidil. It is said that it has the same therapeutic efficacy, minimizing side effects, but long-term results are still awaited. Adverse effects of finasteride. There is a controversy surrounding the adverse effects of finasteride. Adverse effects can be sexual, that is decreased libido or erectile dysfunction, can be non-sexual, that is causing gynecomastia, depression, post-finasteride syndrome, and hypersensitivity. But meta-analysis of data regarding finasteride adverse effects in male pattern hair loss is not associated with statistically significant incidence. This could probably be due to lower dosage used and a younger population in which it is being used compared to BPH where higher dose is being used. The psychogenic component of erectile dysfunction, which may be related with sexual adverse effects, can be because of the nocebo effect. Because of the nocebo effect, there can be increased reportings of erectile dysfunction problems. Here, most important point is with counseling and sharing of patient experience may mitigate these problems. There's a concept of post-finasteride syndrome, which is a collection of adverse effects causing sexual, neuropsychiatric, and physical symptoms which develop with the use of finasteride for male pattern hair loss or in BPH patients. But this is not a documented and not so frequently reported complication. It may affect fertility, especially when used in 5 milligram dosage. It negatively affects semen morphology. So it should be used or it should not be used in young men who are planning to start a family. It is also that it affects the PSA level, hence correction of PSA levels to detect prostatic cancer is required. It has been shown, initially it was thought that it causes high-grade prostate cancer, but it has been now proved that it does not, and it also does not cause any breast cancer. Okay. So these are other pharmacological options which we use, that is dutasteride, anti-androgens, adjuncts like ketoconazole, prostaglandin analogs like bimetatoprost, and saw palmetto, which is a extract from the berry of Serenia repens. Nutritional supplements are also present, but they have limited role unless deficiency is proven. So coming to what routinely is done, what we do is using a combination of topical minoxidil and oral finasteride as an adjunct to hair transplant to tackle both the dynamic and static aspects of pattern hair loss. When used preoperatively, at least 12 to 16 weeks, it helps to improve yield by prolonging anagen and helps to reduce postoperative telogen effluent. When used preoperatively, it improves the villous hair present. This causes stabilization of hair loss progression, but also augments hair transplant outcomes. It also optimizes donor supply over the patient's lifetime and hence decreases the duration or interval between two transplant surgeries. Sorry. So to summarize, the success of medical treatment is largely controlled by patient compliance, and this should be ensured. The benefits and adverse effects should be explained to the patient, but without unnecessarily highlighting them. Periodic photographic documentation is, of course, important, especially for the patient to show that the results are still being seen. And currently, there are only two approved medications, like we discussed, and nutritional supplement has been used empirically. Thank you.
Just to add, I think a very good presentation, but the very important home taking point is counseling of the patient. That is very, very important. How to use the minoxidil. You give him 1 ml twice a day, he will invariably do it wrong. So you have to get 1 ml only. A bottle of 60 ml will last you 1 month, 1 ml morning, 1 ml night. On the scalp, not the hair. On dry scalp after a bath, dry your hair well. Nothing use after 4 hours. These are very important tips. Use one of two fingers to spread it on the skin. Don't use all the fingers. The medicine is taken up by the fingers. Also, finasteride, a lot of wrong myth and feeling there, and you have to explain to the patient that this is going to be very beneficial to you. It's your choice whether you have it or not. Many patients will ask you that I have heard that is dependent. If I take minoxidil, use minoxidil and stop, the hair will fall off again. Then you have to explain to the patient, like suppose you have hypertension, blood pressure. You take medicine, the blood pressure comes down. If you stop the medicine, blood pressure will go up again. Similarly, this is a problem which is not your fault, it's genetic, and you have to continue using it. This counseling is very, very important to get good patient compliance.
Thank you, sir.
Yeah. Sir, I do have a question. What concentration of minoxidil should be used? There are different concentrations available. In the presentation, it was stated that 5%, but can various other concentration can be tried to begin with?
I think 5% is the universal dose. Even nowadays, women say 5%. 10%, there's no advantage except that the label looks 10, which is more than 5, but the effectivity is nothing different.
Sir, I have a question. Local finasteride and oral finasteride. Is the side effects being taken off, or
So people who don't want to take oral finasteride, a good way is say, okay, take local finasteride. The results are not really known. It's still a dicey place. There's no evidence yet. But then something is better than nothing.
thank you, sir.
Thank you, sir.
Yeah, one thing you need to understand the complaints of the patient. All patient comes to you with the hair loss. Every hair loss doesn't hair fall and hair loss and hair thinning. These three things are very important. Every hair fall is not a loss because it can be a routine hair loss, which is 25 to 50 threads a day. It can be seasonal, which is like mostly the rainy season. So the patient gets worried. And the patient who says that I'm losing the bade bade baal ja rahe hain aur jad sahit ja rahe hain, means the white dot is there, means that is the either the telogen hair or the hair has grown, the old hair has fallen. So tell them कि इसकी आपको चिंता नहीं करनी है, जितना हेयर फॉल हो रहा है आपकी बिल्कुल चिंता मत करो, वो वापस आएगा। और जिसके नीचे व्हाइट डॉट है इसका मतलब नया बाल आ चुका है, पुराने बाल को धक्का दे दिया। ये सबसे इंपॉर्टेंट है। मेरा बाथरूम भर जाता है, चौक हो जाता है दिन भर। Patient is very much worried about that. That needs a counseling. You need to target. Another important thing is hair thinning. Loss of volume. Yes. Decrease in the growth. Yes. These are the sign of endogenetic alopecia miniaturization or excessive hair loss like the COVID or telogen effluvium. They explain excessive hair loss more than 150 threads a day, mostly after any triggering effect. And you need to explain of how long I need to take medicine. You need to explain that hair loss is a natural process. जैसे पानी का बहना नॉर्मल है वैसे यदि आपको एंडोजेनेटिक एलोपेशिया है तो बाल जाएंगे ही जाएंगे। यदि आपको बाल रोकने हैं तो आपको दवा लेनी है। सबसे बड़ा साइड इफेक्ट जो मैं यूजुअली बोलता हूँ, मैंने आपके खाने का सबसे बड़ा साइड इफेक्ट क्या है? उससे कम दवा का है। बोले क्या मतलब? अरे भाई तुम दिन में 3 बार खाना खाते हो, पूरी जिंदगी खाना खाते हो ना, नहीं खाओगे तो क्या होगा? भूख लगेगी। Similarly, when you stop taking the medicine, advantage of the medicine will be stopped, not the disadvantage. So these are the 4 important points you must learn while counseling a patient. But well explained.
So one more question about minoxidil. Plain minoxidil or the additives which come for the transcutaneous delivery of the drug? Does it really adds?
There is no scientific evidence, as he said, except minoxidil finasteride. There is no real scientific evidence that anything works. Some of them are a little attractive. They may be making applying a little easier, a little softer, but really, what really happens is not proved yet.
Yes. One last question. Sir, is there any role of iodine-based shampoos?
No, not fine.
You mean betadine?
No, no, sir.
I don't know. I don't know. So you see, any patient who comes for hair loss, first line treatment is medicine. This is a very, very important talk in the whole meeting because first line is going to be medicine. Whether you do hair transplant or not, you should give medication and a trial for medication to the patient, give him a chance to recover for 6 months and then think of surgery. I don't know what I mean, sir. Sorry.
Thank you, everyone. Now we move to the next speaker. He is a dermatologist, so maybe he'll add to these queries. Dr. Nitin Berde. His talk is OPD to OT, Operation Theatre. I think Dr. Berde has written a book on you have written a book. Yesterday you were talking. So till this thing you will just
No,
say
no,
a few
sir.
lines.
I was actually a deputy editor for IED textbook of trichology.
Okay.
So I thought few chapters in that book, but not written a book myself.
So what
So
was the
at the
chapter?
outset, I would like to thank Suresh Savra sir for giving me opportunity to present here. And also I'm grateful to Anil Garg sir and Khanna sir for being teachers all the over years to teach us hair restoration surgery. So my talk is like on OPD to OT journey. So it seems it's a simple word, but the successful outcome of a hair restoration surgery depends on the what exactly is counseled and how the journey is for a patient. So there are certain steps when we are looking at OPD to OT journey. So first is the OPD consultation. Whenever a patient comes, we do the consultation, we finalize the diagnosis, and then we, depending upon his requirement and whatever we feel we either opt for a medical line or for a surgery. Then on the day of OT, we require certain pre-op preparations, which we'll discuss. Then photography, which is also very much important to for further follow-up and for making patient aware what exactly we are done. We also need to be aware about the consent and other preparation. Then hairline design is an important part which is done before the start of OT and hair trimming and other areas. So when we are looking at the OPD consultation, the first is point of contact. We try to evaluate what exactly is the cause for the alopecia. So it can be a simple pattern alopecia, or as we discussed, the causes like simple telogen effluent also. So sometimes we need to evaluate first what exactly why patient is here for you. Is it for him simple thinning or simple telogen effluent or a pattern hair loss? So once we know that what kind of alopecia we are looking at, we need to know whether patient is eligible for hair restoration or not. Sometimes patient come with unrealistic expectation and then he is looking whether I should go for hair transplant or not. They are not aware where to go for a transplant. Even simple bald patch or simple grade 2 alopecia, they'll be saying they want a hair transplant. So first we need to ascertain the diagnosis, and once diagnosis is ascertained, then we can know the eligibility, whether age criteria is fitting or not, patient is uh, into like proper age group, and also we need to deal with the expectations. The important part for the hair restoration surgery is to assess the donor area. We should know the donor area density that we can assess with the help of trichoscopy, and also whether the donor area is sufficient for the recipient area or not. Sometimes what happens ki donor area is less and patient has full expectation to cover the entire scalp. A patient of grade 7, grade 6 says ki he was entire head full of hair, but the donor area is less. Then in that case, we can look for other areas like beard areas or chest or back areas where we can assess their hair quality, and we can go for that body hair transplant also. And also the important pattern which we forget is the DUPA pattern, that is diffuse unpatterned alopecia, which is exactly a miniaturization of hair, the same way it happens in the frontal area to the occipital area also. So that pattern need to be ruled out beforehand, because if you take the patient for hair restoration, then this pattern is going to affect, and the results of your transplant is not going to last longer. It will wither away very soon. And also we need to counsel them, for them hair transplant is a no, and they only need to go with the medical line. And also we need to discuss the patient regarding what the medical line management is. In spite of doing surgery, if the patient of grade 2 comes and we just put the corners, and if he is not sticking to the medication as sir has pointed out, and he is not able to ready to use minoxidil or finasteride, and then he might have only the two horns left. Another entire scalp might bald soon. So the importance of medical line is to be discussed in the first consultation itself, and then when he is ready, then we can take patient for a transplant. Now, when he's going for a transplant, we need to give some preoperative instructions, like we need to ask patient to do shampoo on the day of surgery. He need to be wearing shirt rather than wearing t-shirt, because he need to pull over after the surgery. Then he also, we need to discuss fine point, like he should not drive the vehicle. He should ask some driver to bring or take a cab. An important point is to dye your hair before surgery. What happens ki patient comes on the day of surgery and he is having a white hair, and it's very difficult for us, so we need to advise them to dye your hair a day prior. Also, if your since the surgery is day long, either you can provide the food or snacks from your own, or ask the patient to have your own, because some patients feel that they should not have outside food. So we can ask them to bring your own food if they want. Then we need to go for a blood test. Blood test like routine viral markers, and the routine tests like liver function test, kidney function test before the start of surgery. And once that is done, we can obtain a physician fitness. I ensure that physician fitness is always there with us. What happens sometimes, we just do the blood test, and I have observed that certain patient have come to be like, when we do the ECG, they have AV blocks, or certain having tachycardia, bradycardia, that need to be taken care of. One incident I remember ki, in spite of taking fitness, the patient was having a second degree AV block on the day of surgery. When we put the pulse oximeter, the heart rate was jumping from 39 to 110. So I was wondering what is exactly happening, whether my pulse oximeter is at fault or what. Then we did take out some graft, and then I sent that ECG to my one of my cardiologist friend. He told that there is a AV block, and the MD medicine doctor has mentioned he's fit for surgery. So that was one incident. Then we have to abandon the surgery because the heart rate was dropping too low. So that's why it's important to have a physician witness. Then pre-op antibiotics, some doctors prefer to give it for a day, or some prefer to continue for another 5 days. Also, in my setup, I usually send pre-op and post-operative instruction sheet to the patient a day prior or on the day of consultation, so that they should be aware what exactly they need to go for pre and post-operative instructions. Also, I sent copy of consent form beforehand. Now, coming to the photography, why exactly it is done? It is done for the medical record, also for the comparison, because it also assess or give us a feedback how much work we had done, and how beautifully you have done that work. Also, we need to take at different angles, maybe from the frontal view, then chin down position, 45-degree angles, even vertex area and with the next extension, so that we can compare it over a period of time. And patient sometimes ask and it also sets as a record, because we have um, done it pictorially. We can tell the patient. Now, coming to the consent form, the consent form signing should be, usually we send a copy, and then he should be signing the form. In consent, we should include every possible side effects, and also we should mention the approximate number of graft we are planning to do, and he should do it with a witness or some person who is bring along. Also, we do skin sensitivity test with for any of the patient, even who is taking surgery for second time or that, because it's mandatory, and to record the sensitivity to xylocaine or lignocaine beforehand. This skin sensitivity test shows uh, sometimes with different fluid. One of my patient was having allergy to it, and maybe it was to the preservative, but usually then we repeat with the lignocaine, like xylocard, which has no preservative agent, and then we can check whether it's they are really linked to the lignocaine or not. or in that case we can have a standby anesthetist to be with you for the, if in case there is a some sensitivity test. We also do the vital checks on the day of surgery, and we check all the BP and other thing. The next important part is the hairline design. So hairline design is very important part, and we should take in the patient into consideration what exactly he is asking for. So when we are taking a hair restoration surgery, he might have a idea of his own hairline. He might show his own picture, old picture, 10 years back, that he was having hairline like this. But being a surgeon, and then you should know exactly how to, at what point the hairline should start. We have to see the both the things, where how is his donor area, what is his occupation, and what exactly is demanding. So if he is demanding a very low hairline, we should advise him that if we are having a low hairline, that we are not have enough graft to cover the entire grade 6, grade 7 alopecia, we can, in that case, we can start a hairline little higher, but we should have a fuller, natural looking hairline. So, characteristic of hairline, I think Manoj Khanna sir is going to discuss further. But to just brief, it should be a very natural, irregular, wavy hairline. There should be some sentinel follicles to show that this is just a withering, and also have a good transition zone, which is like little less, and then gradually progress into have a coarser hairs. Now, the another important aspect is the hair trimming. So, in case of FUT, like we usually not required to trim, or we just trim to the window kind of stuff. But if we are planning FUE, which mostly I do right nowadays, so in FUE we should trim it with a trimmer, and the length of hair should be apt. It should not be too long. If you are having a too long hairs, like 2 mm like hair, then it will be, surgeon will be at difficulty putting the hair in through the cylindrical punch all the time. And it should not be too less, because once we put bitumescent, it should not get hidden inside the skin. So it should be roughly around 1 mm. And once the trimming is there, this is also one point where we can check whether hairs are white or gray hairs or black hairs. And in that case, if you see a gray hair, we can apply a dye, shampoo based dye, immediately, so as for a comfort of extraction. Now the anesthesia preparation and other thing, I think my next speaker and next colleague is going to cover it. So this is how the OT journey starts, from the OPD till the OT part. Now, in anesthesia, usually we prepare tumescence and the plain solution. I prefer to use lignocaine with sensoricane as a combination, because the anesthesia duration will last for long hours, like 6 to 8 hours. And for tumescent, I prefer to use normal saline with lignocaine and adrenaline to certain extent. In female, usually I avoid adrenaline. For males, I prefer to use adrenaline. So thank you. Any questions? So the question sir was asking of whether to use 10% minoxidil or not. So what is the minoxidil is dose dependent, but 10% causes a lot of irritation. So when you use 10%, there are more chances of irritation to the scalp, and patient prefer to use. So what I advise them is, if you are using only once a day, you can use a little higher ml, like 1.5 ml at night time, rather than using for a day for 10%. But certainly at certain point of time where you're having very thin vellus hair, 10% will also act, and it will give a better result as compared to 5%.
Hello, good afternoon, good morning, sir. Very good explanation. So my question is regarding the use of sensoricane. Can we use ropivacaine, which is more cardioprotective? Your experience with ropivacaine?
Ropivacaine.
Yes.
I prefer to use bupivacaine. I think sir is using
Yeah,
ropivacaine.
I've been using extensively the ropivacaine. You rightly said it's a cardioprotective, as well as it is sensory. Especially when you are doing the beard, your muscles are protected. Say, don't get the deformity or in the speech problem. So ropivacaine is certainly safer than it. And you, once you start using it, Nitin, I tell you, start using ropivacaine. It's a very nice and safe drug. Even sometime by mistake it goes intravenous. It's not going to harm immediately, because it is cardioprotective. Same as use the same dose, 0.5.
Okay, sir.
Yeah, it's the
I'll
same
try it,
dose.
sir.
Yeah,
I've
yeah.
not tried it.
Start using it.
Thank you, sir.
So we need to understand why we are doing the hair transplant. There are a lot of limitation of hair transplant. Don't think that hair transplant is the whole soul treatment of hair restoration. You are not replacing the same number of hair which has been lost because that much donor is not there. There is a big discrepancy between the demand and the supply. So there is a lot of importance of the medical treatment. And you need to explain how many hairs were there, how many donor hair you have, and tell him right from beginning, I'm not going to totally decrease your or scalp show. It is going to be there when you'll go to swimming pool, when you'll apply oil, when your hair is wet, then the scalp show will be there because if the density of the normal density reduces less than 50, then the scalp show will be there. So right at the 0 hours, he should be explained कि तुम्हारा scalp दिखेगा. फिर क्वेश्चन आता भैया मैं क्यों करा रहा हूँ? Yes, here's why hair transplant is done. Hair transplant is done to restore the aesthetics, which I'll tell you. Facial framing, number one. Number two, we are not going to give the density. We are going to give you the coverage. How coverage? You need to keep little longer. If you keep a hair little long, it's going to cover the three area. Number three is the volume of the hair depends on number of hair, length of hair, and pi r square. So if there are the 20,000 hair on the top of your head and you keep a little 1 centimeter long, then how much volume has increased? 20,000 centimeter hair strand volume has increased. If you give this explanation, you will face less problem on the follow-up.
Mhm. Anil, hello. Yes, just a general question actually. Do you routinely do the skin test, sensitivity test for lignocaine?
Yeah, it's the right good question also, sir. Yes, we must do it. There's a lot of debate on this. In Western world, they do not do, and you are from you are doing practicing there. Even they don't put intracat. Even they do not use sterile gloves. They are taking the coffee in the OT and they are operating. Don't follow that. They don't remove their shoes. Don't follow that. So whatever condition in which we are. And legally, whenever you'll be in the trouble, first question will be asked in the court, did you do the sensitivity test? Even for me, I use the same vial for which the sensitivity test was done. So that's you are right, sir. Absolutely right.
Okay, just question because
It's a good question,
in
sir.
UK, like you end up doing local anesthetic cases in very remote places.
Yeah.
And in my life also, I have never done a skin sensitivity test, never seen anaphylactic reactions. Yes, we know about overdose toxicity and other things, but vasovagal attack I have seen, but I have now never experienced anaphylactic reaction. I don't do skin
And
sensitivity
you do a
test.
lot of local
So it is an external
liposuction.
experience. I don't know how many of you
Yeah.
do it as a routine, but
But it's technically in our country, you will not be saved if you don't do it. But sir is
Sir, I
right
have
also.
one case wherein I have like there was a erythema and the itching was there. So then I called the anesthetist. He asked to test with different vial, but still it was there. So like we did it with standby anesthesia. It doesn't happen anything to the patient, but the test was positive. The
yeah,
reading was positive actually.
yeah. The thing is, you can't have small cases. You end up doing so many minor things under local, and you can't keep anesthetics all the time. And
But the
as I said, I'm talking of the anaphylactic reactions. Means we do end up seeing cases, and if you take a lot of care, like overdose of toxicity is well known, so that care has to be taken. And intravenous injection should not be given, if by mistake. So there are techniques, where you can avoid all these things. But I don't know. I know many senior guys, who have never done the skin sensitivity test and never ended up seeing the cases
but
with
medically
anaphylactic
it is
reaction.
advisable better to go for it rather
I don't
than
know. Is it given in literature that it has to be done? I don't know. Means the patients.
even dentist doesn't do. Then they end up having the patient
Vasovagal is
ICU.
very common, very common.
But not with
Vasovagal.
vascular.
Yeah, I mean, you have to counsel properly. One thing is very sure that whatever you do under local, do it in an atmosphere where you have all the
Setup on
facility
level.
there. I
Yes.
mean, I always do it in my main OT where you have everything available if need be. Thank you.
Thank you.
May I know,
So I'm Amol Kumar Patel. I have a question. When to stop hair growth medication before hair transplant? Is there any need to stop the medication, or we can continue hair growth medication treatment, finasteride, etc.?
My protocol is stop 7 days because the minoxidil increases the vascularity. So that can cause the more bleeding. And that's the only one indication. Otherwise, they can continue with the other and another few multivitamins, lot of other homeopathic medicine, Ayurvedic medicine. You don't know how, so they may increase bleeding time. So for the safer and sometimes the drug interaction also. So these things. So it's better to tell them to stop 7 days before starting. What Nitin? What you advise? You?
I stopped minoxidil 3 days before. 3 days after the first shampoo, and you start minoxidil.
So we move on to the next speaker, Dr. Parikshit Janai. He is going to speak on anesthesia in hair history. Present.
Good morning, everybody. I welcome you all again on behalf of CIIPS. It is an honor to speak in front of such an eminent speakers and a terrific audience. So let us review the classic methods and the recent advances in the field of anesthesia in hair restoration process. Hair transplantation requires a reliable anesthesia and its technique, procedures, its technique. The procedures are prolonged, and the anesthesia must fit in for a longer duration. The technique of anesthesia is not only limited to pain-free experience, but also a bleeding-free environment and a good hemostasis. The goal is to have a conscious, communicable patient who can follow instructions as changing positions, etc., during the procedure. Creating tumescence in the operative field could be instrumental in the success of both harvesting and implanting the follicles. Although various modalities of anesthesia technique are utilized in these surgeries, most common type of anesthesia for hair restoration process is local anesthesia. The method is of the gold standard because it effectively numbs the scalp while the patient remains awake, which is ideal for this procedure, which can last for a pretty long time. Sedation is often used in conjunction with local anesthesia. Sedation is an option for the patients who feel anxious or nervous about the procedure. It is likely to make prolonged procedures comfortable. General anesthesia, which renders the patients completely unconscious, is rarely used for hair transplant surgery. The vast majority of hair transplants are minimally invasive and do not require the risk of longer recovery time associated with general anesthesia. While less common, the general anesthesia may be used in very complex cases, such as those involving large flaps or tissue expanders. So, it is the local anesthesia which is most commonly utilized to conduct hair transplant procedures. This method is standard because it lasts for a longer time, which is ideal for such procedures which are going on for a longer time. The agents which are used in local anesthesia are lidocaine. It is a preferred local anesthetic in contemporary medical practice. It is a short-acting amide agent with an onset of approximately 2 minutes after the injection. The effect of lidocaine persists for 1 to 2 hours, but the concomitant administration of adrenaline can extend its duration to up to 4 hours. The typical hair transplantation procedure may necessitate 2 to 3 injections of lidocaine with the intervals of 2 to 3 hours between each injection. In contrast, bupivacaine and ropicaine, which we just discussed, are long-acting local anesthetics. While they may be are more expensive and exhibit little greater cardiotoxicity compared to lidocaine, they remain viable options for maintaining anesthetic effect for an extended period, even beyond the completion of the procedure. Notably, some surgeons inject bupivacaine and ropivacaine at the conclusion of the procedure for post-operative analgesia. Addition of adrenaline to lidocaine is a usual practice for hemostasis. Epinephrine acts both on alpha and beta receptors. Beta effects predominate in the long run. It increases the systolic blood pressure, cardiac output, heart rate, and coronary perfusion. It also increases myocardial consumption of oxygen. It may induce ventricular fibrillation. The dilution of adrenaline is expressed in the ratio 1:1000. Concentration means that there is 1 gram per liter or 1 milligram per ml. The standard concentrations of 1:1 lakh are equal to 0.01 milligram per ml. When using combination of 2% lidocaine with 1 in 1000 adrenaline, the maximal dose of lidocaine will be achieved long before reaching the maximal dose of adrenaline. So the side effects of adrenaline toxicity may appear little late. These include palpitations, sweating, tachycardia, increase in systolic blood pressure, even up to 70 millimeters above its basal line. It is worth to bring to mind that most local anesthetic agents act as a vasodilators, which increases their absorption area and and the diffusion in the circulatory system may increase. Therefore, so addition of local vasoconstriction with epinephrine results in decreased risk of toxicity and longer duration of effect of the chosen anesthetic agents. The contraindications to the utilization of vasoconstrictions include untreated hypertension, episodes of anger, recent myocardial infarction, severe bradycardia, auriculoventricular blocks, accelerated idioventricular rhythm, and untreated arrhythmias. Hyperthyroidism warrants the presence of a trained anesthetist during the intervention, and patient taking tricyclic antidepressant should never receive noradrenaline or adrenaline. The maximum doses of local anesthetic agents are tabulated and literally means in a 60 kg individual, maximum dose of lidocaine is about 420 milligrams. That means not more than 21 ml of 2% lidocaine to be injected within a span of 3 to 4 hours. Early signs of toxicity of ester anesthetics includes metallic paste, sensation in the mouth, numbness of the tongue, muscle trembling, visual alterations, and shivering. Later, signs are loss of consciousness, convulsions, coma, respiratory arrest, metabolic acidosis, hypoxia, and hypercarbia that may be triggered by convulsions before the respiratory arrest occurs. So, if last, that is, local anesthetic systemic toxicity is suspected, following steps should be undertaken. Stop injection. When any sign of intravascular injection occurs, call for help and manage the airway. Suppress the seizures. Benzodiazepines, propofol could be a useful medicines. Manage arrhythmias. Provide cardiovascular support. Be prepared for a CPR to be performed for a longer time. Administer amiodarone as the first antiarrhythmic usual dose, first antiarrhythmic drug. Avoid xylocaine, obviously. Lipid emulsion rescue, which is um, uh, the bolus dose of epinephrine. Um, okay, sorry. Avoid calcium channel blockers as well. Administer lipid rescue, that is IV lipid emulsions. Infuse about 75 to 100 cc of 20% lipid emulsions along with ACLS or when neurotoxicity occurs at as a bolus over 2 to 3 minutes and continue its infusion for at least 10 minutes. It is an antidote for lignocaine or bupivacaine toxicity. Transfer the patients to monitored setting. And trust me, this is an important slide, though it may appear slightly boring. Anaphylaxis, we just talked about a life-threatening allergic reaction with rapid onset, and it involves cardiorespiratory destabilization. Cutaneous signs such as rash, eruptions are primary indications. Sudden wheezing, coughing, throat tightness, or voice changes suggest respiratory involvement. Many a times we have just heard of anaphylactic reaction, but many a times we don't realize what needs to be done. So, apart from the ABCD of the shock, the management involves injecting zero point 0.5 milligram or half ml of adrenaline intramuscularly if we don't have an IV line. And if we have an IV line, dilute 1 ml of adrenaline in 10 cc of normal saline and inject 1 cc intravenously. So other precautions in local anesthesia involves pre-medication, which entails that the patient must attend the premise 30 to 40 minutes before entering the operation room. Oral diazepam in doses of 5 to 20 mg is usual choice. Verbal contact should be maintained and the patient is always instructed to unambiguously verbalize the painful sensations and bizarre feelings during the procedure. Monitoring of pulse oximetry in BP is essential part of any procedure. It is a safer practice to secure IV lines before starting any pre-medication. So after certain these warning slides, let's begin with the techniques in local anesthesia. Technically, local anesthesia in scalp can be viewed under three broad headings: nerve blocks, field blocks, and tumescence. Wise combination of all above is used by most of the practitioners, and no any single method can guarantee complete pain-free experience. As we all know, the scalp is supplied by these five nerves, one on each side. Surface areas that corresponds to sensitive territories of lesser occipital and retroauricular nerves are shown in green, the greater occipital nerve in pink, and the three divisions of trigeminal, that is ophthalmic in violet, maxillary in yellow, and mandibular in red. The supraorbital nerve emerges through a foramen on the middle of the orbital rim. The foramen is palpable as a clear step in osseous continuity. The foramen supraorbitalis is easily palpated following the orbital rim 2 centimeters from the midline, and it is and in adults it is loosely corresponds to the same sagittal plane as that of a pupil. The needle is introduced around 0.5 centimeter under the inferior edge of the eyebrow. Some people will inject it slightly above the eyebrow as well. Once the needle tip is near the supraorbital notch, after the test aspiration, a local anesthetic solution, which is generally 0.5 to 1 ml, can be injected. The supratrochlear nerve emerges medial to the supraorbital notch and it lies in the medial third of the upper orbital rim. So, for a supratrochlear block, um, the main landmark lies on the top of the angle formed by the eyebrow and the nasal spine. At this point, the nerve is in contact with the bone, and the supratrochlear nerve can be traced at around 3 mm medial to the vertical line drawn from the apex of the lacrimal caruncle along the supraorbital margin. After the injection of around 0.5 to 1 ml, firm pressure is applied for a better anesthetic spread and prevent ecchymosis, also to prevent the drug passing into the orbit. One of the two branches of zygomatic nerve, the branch of maxillary division of the trigeminal nerve, is zygomatic-temporal nerve. It innervates the temporal area and small portion of the forehead. The nerve is located just lateral to the just lateral and superior to the junction of zygomatic bone and the zygomatic arch. An obliquely placed needle can block this nerve with 0.5 ml of the drug. The auriculotemporal nerve receives innervations from the posterior area of the temple and the part of the pinna. It is just anterior to the auditory canal and it accompanies the superficial temporal artery. The nerve is blocked by injecting above the posterior portion of the zygomatic arch, the anterior superior and the slightly anterior to the and superior to the tragus and behind the superior superficial temporal artery. 1 ml of drug is injected after negative aspiration. That does the job. The lesser occipital nerve, a small branch from the ventral primary lami of the second and third cervical roots. It innervates the lateral occipital zone and the upper earlobe. It runs posteriorly at 45 degrees angle to the vertical and parallel to the posterior border of the sternomastoid. A subcutaneous injection along the hairline behind the ear is the way to block both lesser occipital and posterior greater auricular nerves. The greater occipital nerve provides cutaneous innervation to the major portion of the posterior scalp from inion, that is occipital protuberance, to the vertex. Typically, it lies 4 centimeter lateral to the inion and medial to the occipital artery. The pulsations of the occipital artery are sometimes palpable, and there is a considerable variation in the position, and we advocate use of ultrasound probes for the safe localization. This is a short video. That is how generally I give a local block. That is, um, we mark for the lesser and greater occipital nerves by marking the line between occipital protuberance and the mastoids and divide it into equal thirds. We confirm the positions by using a handheld Doppler for both lesser and occipital nerves with their accompanying blood vessels. It is generally a centimeter here and there, and we finally mark where these um, blood vessels are. And then we inject the markings with approximately 1 cc volume uh, around these marked points after multiple aspirations at a depth of around 1 centimeter. Field block involves injecting multiple small deposits of local anesthetic drugs at the periphery of the field at regular intervals. Many surgeons advocate use of only field block over the nerve blocks. Obviously, it demands better pain tolerance from the patient who has to receive more number of pricks compared to nerve blocks. Most common practice is to use combination of nerve blocks and field block for certain skipped areas. As seen in the video, small deposits of local anesthetic drugs are injected at a regular interval. The tumescence. Everyone uses different combinations of tumescence fluid. Here is a combo which we use as a routine. The tumescence is injection. Tumescent injection causes dissection of the subcutaneous layer, providing hemostasis and a firm, stable working plane. However, the onset of effect is longer uh, than the blocks, and it may take around 10 to 15 to 20 minutes to begin. Have you heard of this word? Trypanophobia. It is the fear of needles and pricks. Most of our patients are phobic of pricks, which are plenty in our procedure. Various methods are employed to reduce the phobia. We are Few are summarized here, but let me tell you, nothing can be rewarding as clear-cut communication with your patients. Apart from keeping uh, patients informed, using a warm injectable fluids, buffer it with soda bicarbs, using very small needles as 26 gauge or 30 gauge, even nowadays 32 gauge needles are available. Piercing the needle perpendicular to the skin initially and raising a wheel before manipulating its angles. Slower injection speeds and using minimum capacity syringes such as 1 ml or 2 ml can help in minimizing tissue expansion pain. Ice numbing devices like this, which can be applied for around 5 to 20 seconds before the injection can be of some use. And distractors like pinching or vibrators can be a wise option to reduce the anxiety and prick pain. That brings us to see this illustration of needle-free injection. The core principle is to use pressure to create an ultra-fine stream of drug that can pierce the skin. This process typically involves a power source that generates enough force to propel the medication through a small orifice in the nozzle. The drug penetrates through the skin and gets distributed in the cobweb pattern in a subcutaneous tissue like needle injection, which, unlike a needle injection, which generates a blob of localized fluid. The power sources used in this can be divided into spring loaded, gas loaded, or electromagnetic or a laser powered ones. The devices not only eliminate the patient's anxiety but also avoid needle stick injuries to the medical workers. Well, nevertheless, these devices are still associated with variable pain or short sensations, mild to moderate bruising, and higher cost and extended time needed to load and unload these devices. Intravenous sedation, as I said, sometimes it is used. It creates a twilight state, allowing them to be slightly semi conscious but responsive. This method can help to regulate blood pressure, reduce bleeding, and prevent popping of grafts, ultimately contributing to more comfortable and effective hair transplant. Inhalation and general anesthesia, as I said, rarely used in very complex patients, complex procedures. Sometimes it is cumbersome, but some clinics use nitrous oxide sedation or inhalation, which are patient regulated. So, to conclude, explain the patient what local anesthesia is all about in a clear words to reduce sorry explain the patient what local anesthesia is all about um, in clear words to reduce the patient anxiety and identify the risk factors by taking detailed history and anticipate problems than facing complications during the procedure. Keep the blueprint of the plans ready. If you have to face any anesthesia related complication, try not to exceed the pharmacological limits of medication used. Use gentle and minimally invasive techniques like blocks, small needles, and know what works best for you.
Thank you, Parikshit, for a very detailed and beautiful explanation of anesthesia. Since we are running short of time,
Yes.
I'll request our next speaker, Dr. Manoj Khanna, to talk on a very interesting topic of science and art of natural hairline design. Dr. Manoj Khanna, please.
Excellent, Parikshit. Just two small point. Drug interaction you shouldn't forget. There are few drug interaction. You go and read it. This is very very important. Another thing is the delayed anaphylaxis. If sometimes a mild reaction you notice, you give some steroid, evil sort of thing, but they may have the delayed anaphylaxis. These are the 2 points you must read.
A very good morning to all of you once again, and thank you for being with us. Before I start, I would like to know how many in the audience are plastic surgeons? Quite a few. How many dermatologists? I learned my hair transplant mostly from dermatologists. It's a confession. So, your take home lesson for you. The hairline is the face of a hair transplant. The aim is to get an absolutely natural looking, undetectable, full hairline. And of course, the plan will vary according to the degree of baldness, the expectation of the patient, the availability of donor area, the age of the patient, etc. There are a number of factors involved. And you can have patients with different grades of baldness, different shapes of the face, all demand a little different hairline. The hairline has some basic patterns. You see, there are usually mounds. There may be only one mound on the right side. There may be two mounds on either side. There may be one mound and the widow's peak, or there may be just a galvic pattern, on either side. So different hairlines are there. The aim is to get a natural looking hairline, and you have to understand the basics of a hairline to get to that point. See, the large pattern of a hairline, there's some obvious mounds I mentioned, and there will be two or three mounds with the bat wing appearance at times, and but 55% of the hairline do not exhibit any significant or anterior mound. The important point here to remember, which is probably the most important slide in the whole talk, that after you made the hairline in the front, you've got to distribute hair irregularly in small clusters of hair, of gaps between each other, about a couple of 2, 3, or 4, 5 millimeters, which make it look natural. And these clusters may be random shaped single hair, they may be linear clusters, they may be round clusters, they may be triangular clusters, quadrilateral clusters. These clusters placed all along is going to give you the look of a natural hairline. Of course, as everybody knows, the hairline is which has only single hair in front of which, and behind which there is the defined zone and the central area, which has got even 2, 3, or 4 hair follicle units. But the hairline actually is more is larger than what we see. It's about 2 to 3 centimeter deep. The hairline right in front is a transitional zone, behind which is the defined zone, and behind that, of course, the important thing in the middle is the frontal tuft, which is so very important to get good density. The initial 0.5 centimeter of the hairline, the width and density will depend upon the severity of the hair loss. It has to be irregular, it has to be ill defined, very, very important. And these micro irregularities that I mentioned, those clusters and mounds with the macro irregularity, we give it a very natural look. And of course, remember, they have to be only single hair. There are a lot of people who make a mistake of doing 2, 3 hairs in the hairline, which is absolutely incorrect. It has to be only single hair. Behind that, you come to 2 hair. And of course, there will be some sentinel hair scattered here and there, which are present, which give it a natural look. The posterior zone just behind has got to be a little wider. There will be more density there. There will be 2 or 3 hair follicles across this area to give it a fuller hairline. And the central tuft, the frontal tuft, is important to be packed of good 2, 3 hair follicular units so that it gives good density and give you a natural look. The designing of a hairline again is important. It might be slightly bell-shaped normally, but don't place the hairline too low. Many younger patients will come to you and they want the hairline too low, and you tell them that you look like a female. You have to really work on them and dissuade them mentally to make them understand that the hairline does not become slow low. And if they're little recession, they're so obsessed about it. Don't do that. There are a few ways of doing it. Forefinger breadth above the glabella, 8 to 10 centimeter above the glabella, or you draw a line uh, according to the curve of the forehead with the patient looking straight, and it should be parallel to the horizontal plane. For the temporal hair, the area, the frontotemporal area, well, you draw a line from the lateral epicus and so the ear straight back, and where it meets the temporal line is the place where the temporal point, maybe a couple of centimeters behind that, and this is very important to give you a natural look also. For people who are extensively bald, they don't have any hair at all, and you have to draw a hairline. Well, it's a really difficult situation, and it's very important. Here, if you draw this small mound above just above the maximum area of recession laterally, and you draw a vertical line from the lateral epicanthus, and then join this with the line vertically from the anterior border of the ear. This is the point usually where the temporal point will be. It can vary from patient to patient, but these points are very important to make you look good and natural. A good hair transplant with a lot of hair, but an unnatural hairline looks very, very anesthetic, and the patient will never be happy. Also, remember the donor area and the hairline have to be finer. If you're doing a strip, take it only from the just above the ears, the lateralmost spot, or the nape of the neck, which hair are thinner, which give you a more natural look rather than coarser hair, which can give away. And the angulation of hair is very, very important as well. It is usually 10 to 15 degrees in the center, and the more you go laterally, the more you go towards the temporal areas, it becomes 0 to 5. And there's a special technique of making your slits to be able to get that angulation right, which I'll show you in a video shortly. So one of the good easy ways is you put your 4 fingers, and that is the point where the hairline should begin. But the best method I've learned, which I learned long donkey years ago from Dr. Vasa, a well-known plastic surgeon, is ask the patient to wrinkle the forehead upwards. When the patient wrinkles the forehead upwards, there are wrinkles on the forehead, but none in the scalp. That's a very good giveaway. And also there's a pigmentation in the forehead, which is not in the scalp. And that is the real place where you could place a hairline and give it very, very natural look and effectivity. I use the 19G blade needle, sometimes 20G to make a hairline. And what I'm doing is, you'll see there are different clusters, 7, 8, 9, 10 pricks in every cluster, which can be linear, triangular, quadrilateral, semicircular, different patterns. There's nothing fixed. Some surgeons will draw zigzag, zigzag, and follow that pattern is wrong, because that will give you a more uh, pre-planned look, which does not look very natural. So these clusters of 6, 7, 8, 9 at the gap of 1, 2, or maybe 1 centimeter, 0.123 millimeter to 1 centimeter is very, very important to give you a natural look. And this must merge with the hairline behind. The hair behind, these clusters have to merge with that to make it look totally natural and normal and give you a very, very good natural look. See, on the right side, it's much easier. No. hold on, this is important. For a right-handed surgeon, on the right temporal area is easy because you can get your hand to be manipulated and get the right angle, which may be 0 to 5, as you see here, when you're making this area just below the frontotemporal point. But on the left side, it becomes more difficult for a right-handed surgeon because the angle becomes very acute. And a good trick here is to use the needle and double bend it. If you double bend it, you will get the advantage of getting an angle 0 to 5 when you're doing on the left side of a patient when you're right-handed surgeon. As you can see here, the angulation becomes very, very little. 0 to 5 is what you're aiming at when you're doing the slitting on the left side for a right-handed surgeon, and oppositely from the right side for a left-handed surgeon, like Dr. Anil Garg will show you some tricks to be able to get that angulation very correct. So another trick for youngsters or beginning new, you can put a few drops of gentian violet and methylene blue into that area after you've cleaned it well, and wait for a few minutes and then shampoo that area. What it basically does, it stains all the entry points you've made, and that thereby makes the identification of these gaps much easier. And then you can put in the hair follicular units, whatever you've done, without missing any, and being able to visualize them very clearly. So let's see what a good hairline looks like. A young guy who's just 27, 28 is very bothered about the temporal recession. He wants something done immediately, and medicines will not work in this area. And here is he after about 9 months with a result which is pretty, pretty good. You can see the same patient bending downwards, a very full hairline. And the ability to get a natural hairline, you see here, when you comb, you cannot make out it's your own hair or it's a transplant hair. On any side, the front, the middle, or the left or right side, you'll see that the hairline looks very natural, which is a hallmark of a good hair transplant result and will make the patient happy in days to come. Another patient, 45, and he looks so much younger after a hair transplant. In fact, you get comments on Facebook. He says, I look about 10 years younger than what I am, and friends are asking what I've done. Similarly, this guy, darker patient, a little more difficult, but getting a natural full hairline is very, very important to get a good aesthetic, nice looking result, which will make these patients very happy. Other patient, another young guy. Younger guys come in more for a hair transplant now, and if it's the frontal and temporal area as well, there's no way medicine will work, and you'll have to oblige them at some point of time. Patient who's 45, patient who's another in the 40s, you can see a very natural looking hairline. Somebody who's is about 28, 29. And this gentleman is 33, 34. Temporal recession, doesn't like it at all, but can get a very natural looking hairline if you could this. And here's somebody extensively bald. I did 2 sittings for him, but the first sitting was a hairline. And this itself is the cause why I came back for a second sitting wanting more hair at the back, which was still empty. And in case you don't have a big area of baldness and you don't have enough hair, there are many people who use a wig. The problem with wig is the moment you look at it, it gives way. It's false hair. It's too thick. It's too density is too much, and the hairline doesn't move. Here I have done a very, very good natural hairline. This patient, he was extensively bald. I've just done this, and he's put a wig behind this, and that gives a very, very nice full look, and does magic of covering the entire head, which looks very natural just because of the hairline being done naturally. Here's he. Nobody will say he's wearing a wig because the hairline is so natural. And behind that, he's got a wig. He's covered everything without too much of hair being available for a hair transplant, and got of it. My thanks for the invitation. Very nice to have you this morning. Thank you very much.
Uh, now request chairperson.
Questions first. Sir has finished before time, so we have got 2 minutes.
So I have a question. You are making slit by needle. So is there any advantage for needle? We can use SP90 blade, or uh, I have seen many person using the topaz blade. They break that blade and make the. Uh,
You see,
so
there was no instrument initially for making slits. When I started
yes.
doing hair transplant in 95, there were no instruments available in India. We would get the Mindy knife from the United States, A to Z needles or no-con needles. And then I made an instrument called the Kolkata slit, which I patented, which is very good for those mini grafts. Now that the grafts have become follicular units, there are a number of instruments available. The blades are available, the topaz blades are available. You can have your own cut to shape blades, and of course, a needle. The big advantage of needle is it's easily available, it's inexpensive, disposable, make 50, 70, 100 slits and throw it away. And the follicular units for Indian hair fit in very easily with the slit made of the needle. I usually use the 18G needle for the back, the 19G and sometimes 20G if the hair are very fine to make the hairline or the eyebrow, etc. They're very comfortable with that, and you can put it on a 2 cc syringe, which is a good handle for you, and work comfortably. It's your choice what type of instrument you want to use, but needles do very well. I'm very happy.
Thank you, sir. And what is the distance between two slit? Is there any criteria for?
That's another lecture altogether.
Thank you.
Well, you see, okay, we can talk about it. Thank you.
So may I now request chairperson for this session, Dr. Patil sir and Janay sir, to felicitate our speakers. May I now request all the speakers, Dr. Shweta Karmakar, Dr. Pallavi, Dr. Fidvi sir, Dr. Nitin Badwe sir, Barde sir, Dr. Janay sir, and Dr. Manoj Khanna sir, please come on the stage. Speakers, sir. Janay sir. श्वेता कर्माकर जा जा सगळ्यांचे घेऊन जाईल डॉक्टर पल्लवी फाटक डॉक्टर फिदवी सर डॉक्टर नितिन बर्डे सर डॉक्टर जनई सर and now I would request Dr. Chaure sir to felicitate our chairpersons for this session. The next session में हाँ I now request Dr. Sudhanshu Kote sir and Dr. Jitendra Mehta sir to chair our third session.
Good morning. Next talk is from Dr. Anil Garg, Recent Advances in UNFIT.
We heard the great lectures. I really appreciate the residents and youngster who presented their topic very nicely, very beautifully. I really appreciate FUE. You will be ready with your mobile camera. I'll say many times to click because few things are, everything cannot be. So this is the you can scan this QR code to have the tutorials detail, like 5 tutorials on recipient area planning, just 5 tutorials. So these all video you can get, and whatever I make presentation in various national international conferences, most of them I upload them. So they are for you all, my dear friends. So you'll have, so this is, let's start with, I've been told to show more of the videos, but in between, I'll stop and then explain you what and how we are doing. This is not a small surgery. Use OT, you have to have defibrillator, monitor, pulse oximeter, all emergency equipments, everything you should be done in a well sliced condition. It's a micro surgery and it has all advantages and disadvantages. This what we are doing is the chest. Just to come to the FUE era, I'm starting my talk with this video. This is the chest. See how delicately you need to remove them. Now let's start with the topic. The FU is follicle extraction. No, it is excision because it is a surgery. There's something you are cutting it. Method of isolating and harvesting. They are the two things. Isolating. Isolation means you are cutting from the surrounding, so it's excision, so it's a surgery. Then harvesting means you are removing those has been isolated. That defines the FUE. It can be done using the manual punch, can be done to the advanced the robotic, and become popular as it was thought to be, and still unfortunately many people say less invasive, scarless, painless. But this is wrong. No surgery can be done without scar. All cut wound healed by scarring. Of course, it is sutureless. So various devices, manual, motorized, vacuum, robotic. This is the manual. This is the safer system, which was expensive when I entered in 2009 and 10 and had the conference. And it was very expensive, 5 lakh at that time. I thought I'm a plastic surgeon. I can't buy it. प्लास्टिक सर्जन usually don't have that much money. बेचारे माइक्रो सर्जरी करते रहते ओटी में बैठे बैठे बाकी कमाते रहते. So I thought, let me have. So I thought there is one instrument. I am doing maxillofacial surgery. Why it can't be used? And in 2011 in Mumbai conference, I presented, and there was a big voice against this because all done expensive. They were against it. But I remember still my boss, my guru, Dr. Manoj Khanna, he was the person who supported and said, don't think that all expensive instruments are expensive. And since then, this is available on with everyone. So this is a very good instrument. Then PCI, then this safer system. I have this and the Stavillani Mamba and then the robotic. Various punches are there. Two types of punch, dull and sharp. Then the smaller punch means zero point 0.7 to 0.75, 0.8 mm to zero point 0.9 to 1 mm. Microsurgery means less than 1 mm, so you should use more than 1 mm size of the punch. It depends on your experience and all that. Then there are many advanced punches, which has come like flared punch, then the hybrid punch, then the many punches are the so there are many types of punch. The advice is you must practice one machine, one technique. Start with that, get expertise of that, and then go to the second. Don't jump every day. You go to the conference, you see another good machine, he shows you very fascinating result, and you start with that. Then you go to the another conference. No, just practice with one. And I tell you, simplest is safer to start with. And as I said, surgery doesn't come with complication always. Always the surgeon, if you're doing it, you may face some complication. So these are my instrument. This is a very robust machine. This is available in India also, and this is the simple or maxillofacial, and this is the advanced Mamba machine I'm using. This is also. So any machine, it depends. As we know, what is most important for a cardiologist, it is not the stethoscope, it is something in between two earpiece. The same, it is more important in the hand, not the machine. This is a very good thing, thigh massage chair, and it helps you. I'll explain you how it's going to. Now let's start with. I'll stop in between and show you. There's so many things to learn in this. Two fingers are here, angle is this, then my one finger is here, this finger is resting on the scalp, and then this is holding pen holding position. By these two fingers, I am pulling it up. Pulling it up means when the hair is at more acute, when I pull it, it comes up. This helps you. So every action I'll explain you. So these two fingers I am stretching up. Another thing is stretching means I am stretching skin in between index and the thumb. Another is them stretching down. So when you are stretching, you are 0.75 or zero point 0.8 mm hole. When you leave it, it becomes smaller. And stabilization of the skin also takes place. So this action. Then one finger is here, resting on the scalp. Means I'm giving extra stability to this by hand piece. So many things are there in this one step. We'll go ahead. Engagement going parallel to the hair, then the removal. Now understood, I'll explain you. Now let's understand what I'm doing here. I'm using two forceps. One forceps, first forceps, I catch hold the hair. Then second forceps, I'm just catching the epidermis and dermis. This is most important. If most often the second forceps is applied on the shaft or in the bulge area or in the bulb, you are crushing it. You shouldn't. You should not apply second forceps below the bulge area or over the sebaceous glands even. So this is important. Third step is to understand is now again I'll go it. Sorry. Ah, how the pulling of the graft. You understand this. This is the punch hole and this is the graft isolated. If you are removing it like this, understand this means you are causing the avulsion injury with the edge of the hole to the follicle. So you shouldn't do it because you are standing. So it's easy to pull it like that. No, you go parallel to the skin, parallel to the skin. Once you go it, then the edge of the hole is not injuring your follicle. So this is again important. So always pick it and just do it like this over the skin, not like this, not like this. These all things are very important in your final result. Watch points which I explained you. Now, again, stop. Now you see the length, you see the quality, you examine the entire follicle as a big human. Hair follicle, it's like a full human body examination, head to tail. So you see here skin, epidermis, sebaceous gland, bulge area, the perifollicular tissue, then the shaft, then the bulb. Is there any crushing? Is there any fracture? Did you rupture the sebaceous gland? Did you rupture this? You have to see all this as a big thing, not a small just follicle. It's a organ. Hair follicle is an organ. So you see the length. Why do we need to then? Because we need to decide about the depth for the slit. We need to decide about the guard of the punch. I'll show you that also. So go to next. So now let's understand the training module. I have developed this when I started doing I had no chance to going and to learn. So I developed my own technique of learning it. And the question was when you're done it extracted, you're done the transected. And being a plastic surgeon, a microvascular surgeon, when you injure a follicle, it hurts. एकदम ऐसा लगता है यार तो दिल पे चोट कर दी क्योंकि आपने कुछ काट डाला. तो आई थॉट कि यार मैं कुछ ऐसा करूं कि मेरे को काटने से पहले पता लग जाए कि कटने वाला था. तो हाउ टू डेवलप इट? देन आई डेवलप दिस स्कोरिंग टेक्निक. This paper has been published and also firm pen holding position. Those who are surgeon, they don't have to learn it. They already know it. So it's a pen holding position. You must practice. Those who are not from the surgical hand, they should practice to hold it gently. Apply too much of the pressure. If they apply too much of pressure, then they'll. Now the scoring technique. Now see, I'm just scoring. And these are my score. Okay. Now how to analyze these score? Let's see here. One is eccentric here. Means यदि मैं अंदर गया होता तो क्या होता? I would have transected it. So I know it. Another thing, upper border and the lower border. Now you see here, it is in the center. lower border is deeper, upper border is a superficial, means I was parallel. I was parallel to the hair shaft. Now see, next. This is my scoring sheet analyzing A point, B point. If you follow this, A will be deeper than the B will be deeper than the A parallel. If you deviate, then you are going to cut it. That's how this was a scoring sheet. Then the stability, firm, land, rotate, go in, stop, and come out. These are the steps. Now understand this. This is the actual what I was learning. At that time, it was short. Shaking hand, ये पकड़ूं मैं, ये वाला बाल करूं, नीचे वाला नहीं, ये ज्यादा अच्छा लग रहा है, नहीं इसमें ज्यादा फॉलिकल. No, target. Fix your mind which you are going to target. These are the starting process. This is the guard which I was talking about. To know the length of the follicle, you need to adjust the guard length. See, you can see the shaking hand because in real time this was. So you get the shake. ये पकड़ूं, इधर जाऊं, नहीं. That you have to overcome with that. So the advanced FE machines are the rotation, micromotors, dental motors, oscillation means going to and forth motion, vibration for more dissection enhancement. This is what Mamba I use for non-shaving hair or long hair without shaving. Those who have come up and joined the field of my now hair transplant, they should do this and learn it and practice it, because in the coming area, many of may not like to go for the head shaving. So you must practice it, non-shaven or long hair transplant. For that, you need to have the advanced punch. This is non-shaven hair, long hair. Another thing is those who are non-surgical side, how to paint is more important. Just with the pressure, if you are doing it, paint means you are not leaving some betadine. You must leave some betadine over the surface, leave it for some time. So every step in the surgery is important. From center to periphery, we all plastic surgeon, we know that. You don't spoil your OT drapes every day. So I keep this disposable. This is thigh massage, my two machines, all set up here. And now doing it. Two-person, me and Dr. Seema, my wife, we both are doing it. We divide the scalp into two half. There is a one line of control in between, and sometimes always the female overrule you. And she'll start from my boundary and then she'll go. So that is a fight we always have in OT. And again, you see every step, stretching. I'm stretching in between. See here, stretching here and pulling it up, stretching and pulling it up. And the angle, you have to maintain it angle. And there's a equidistance we are maintaining. 1 out of 4 or 1 out of 3. And then the removal. Dr. Seema does with one hand. So you see when she does she pulls skin up. One thing, understand. When you are doing the extraction, dissected graft, you just pull the skin up. When you make it up, you are increasing the interstitial pressure. So it pushes it out and it opens your whole of the follicle. I don't do this practice. I use two forceps technique. So both can be done, but the best thing is you push the skin up, then pull it down parallel to the skin. It will not cause any injury to your delicate follicle. How fast she removes? Females can always do better surgery than a male. They are more concerned. Doesn't mean we don't do good surgery. We also do good surgery. From where we are catching the follicle? See, only hair or skin or epidermis. 2. Second forceps, where I am applying the second forceps? Where I am keeping it? Then they should be irrigated. Either they should be in the blood or irrigation should be done at that time. Irrigation is very important. बीच में कोई क्वेश्चन आए तो जरूर पूछ लेना है, डोंट हेजिटेट. वी आर डूइंग इट इज अ क्लोज मीटिंग, लाइक ए फैमिली मीटिंग. Irrigation, again, shortening, check for the quality, how they are. Do the total detail examination, what we call it when the patient comes to you, do the detail heart, lung, liver, brain from top to bottom. So similarly, you examine your whole follicle from top to bottom. Then I keep it in the plasma. Temperature around 9 to 12 in between. So this is what we do it. This is the entire scenario. Same time excision and same time implantation. This is possible only this. Notice to root technique of implantation. It is very, very important to prevent micro trauma during all the step. And the most important instrument is the magnification. Magnification and magnification. You should have the best quality of loop. So healthy harvesting, prevent transection, prevent injury to graft while scoring the removal of the graft. Now it is advisable to engage the epidermal blush. Ab ye hai how important is, shall I, there are two things, when uh, when any pencil you put in the water, then there is an angle distraction. It doesn't follow the same angle. Similarly, the when the hair exit, it has little different angle when it is intradermal. So you do not focus the point of exit, you focus the epidermal blush, because epidermal blush gives you the exact angle of the hair inside the skin. So epidermal blush, another advantage is epidermal blush is there, means that hair is in the anagen phase. So these are the two advantages you get it. So this is a real good point. Another thing is the punch. Many times we know to centralize the epidermal blush or the exit angle of the hair, but we forget the handle. Let's see. Hair is coming like this, and this is my handle. I centralize here, but I can keep here, I can keep here, and I can keep here. What is going to make the difference? I'll show you. If your handpiece and hair shaft are in the same alignment, you are not going to transect it. No transection. But if it is deviated away, then it is going to transect. When it goes inside, it will go in the different angle, it will follow the different angle. So if you follow these 2 points, my dear friend, you will not really come across the transection. Again, check. What I explain, you check here. Remember all the point. Sorry, my teaching is like a student and teacher. So those who are senior, please don't mind. Gentle. I tell my team always, these are not follicles. These are your baby. And tell them every time, shout in the OT. I used to, when I was starting, I used to shout in the OT, this is your baby, this is your baby. दिमाग में घुसा दो कि जब फॉलिकल दिखे तो उनको लगे मेरा बच्चा है, तो उसी हिसाब से उसको हैंडल करेंगे. See, so many hands are working together. 2 persons are doing excision, 2 persons are doing extraction. Such a beautiful follicles are there, no injury, no transaction. All. So concept of safe donor harvesting, Unger and Bernstein Rasman has given this. Hair follicle on the back of the head are permanent. They are not endogenous sensitive, and when you implant them anywhere, they remains permanent because of the donor dominance. And it has been found up many time the question is asked why these hairs are permanent. The hair is the hair. But because they grow from the different zone during abiogenesis, they have different nerve supply, and they do not have the receptors which comes through the genetic programming. 25% of the scalp area is permanent, and total 50% of this can be taken. On an average, 5,000 to 6,500 grafts can be extracted, and safe coal area is around 200 square centimeter. I'll go in the detail. SD is really permanent. It is not permanent. It has been found up to 80 years. Many times you will get come to question that how long these hair are going to last. I usually they say up to 70 years because less than 80 years, most of the 80% people's men aged between 7 to 79 years manifested baldness that is less than Norwood create type 7. So that is going to be relatively permanent. I know what question is going to come in the mind of my boss, Dr. Manoj Khanna. I'll answer that. The width of soft donor area, family history of baldness, age, severity of baldness, patient compliance, local examination, see for the anagen, telogen, retrograde baldness, progressive thinning, and calculation of the superior border 6 centimeter below the center of wall is another point. You examine this for the retrograde baldness. You see for the diffuse pattern. This is senile alopecia. These all are the important points to consider. And this is the advantage of FUT or FUE because in FUT you are excising the most permanent, most loyal hair which are going to remain with you up to 9 years or 90 years of the age. If you have seen a person of the 90 years, his width decreases to 3 centimeter or 4 centimeter. But when a person is of uh, 30 years of the age, his saved donor area seems to be saved 7, 8 centimeter, and the surgeon removes from all that area. And that is less permanent, so you may lose with the time. But FUT graft, if you are excising from the central most prominent area, that is the biggest advantage of the FUT or the FUE. Now the safe donor area boundary, occipital protuberance, this point. Then second point is the meatal line, 2 centimeter above this area. Then 6 centimeter above is the point C. Repeat on the opposite side. Then you need a center point. You need a this is mid occipital vertical line. You put it. Then a transverse line joining your 2 points where the transection is there. That is your border. Then you join upper border and the lower border. This is your major zone of the scalp. And if you don't see any miniaturization and there is no retrograde, then 1 centimeter, 2 centimeter below this can even be harvested. This is many times surgeon has temptation to cut and to remove. So he may exceed the limit and he forget. And I am also notorious on that part. So you don't shave that area or you can put the micropore. So you limit yourself. This is what I'm showing here. I have not shaved the entire scalp. I shaved only the donor area, safe donor area. Me, my wife. See the distance at which we are doing it. Two surgeon, 2 person removing. Goes very smoothly in this Thai massage chair. But मजा आता है मतलब you are doing it so joy and pleasure you get. हर दिन लगता है कि ये तो सेम सर्जरी है लेकिन जब आप इसमें घुस जाते हैं इसकी गहराई में जाते हैं तो आपको हर फॉलिकल अलग लगता है जैसे किसी को लगता है इस दुनिया के सारे बच्चे सेम हैं लेकिन जब आप उनको देखते हो हर बच्चा अलग है सिमिलर है सेम नहीं है ऐसे ही हर फॉलिकल इज डिफरेंट provided you have the sight to see them so you'll enjoy now the punch size if you use pointed कितना टाइम हो गया अब मैं आई एम ए वेरी नोटोरियस ऑन दैट बिकॉज मैं खो जाता हूं तो आप मेरे को रोक देना जहां जब भी रोकना हो 0.8 से 0.1 mm लेते हैं तो 1 mm punch will create 60% larger hole than the 0.8 so the suitable size then the pattern of excision if you excise too close then you are going to cause the necrosis. If you put them in a linear fashion, then you are going to give cut. So randomly, as I've shown you, it should be excised in a fashion. And it is better to divide in small zones so you don't get the moth-eaten appearance or irregular. Another, these are the points what I have given is do not excise all multifollicle node from one area, because there is always a temptation ki bade bade graph nikal lu. So do not excise, there will be thinning. Do not excise all members of the family also, and do not excise all multifollicular unit, and do not excise all family member of the family unit. This is what we are doing at the chest excision. Me and Dr. Seema both, and same time I'm supplying. इधर निकला उधर लग गया, इधर निकला उधर लग गया. Supplying it at the same time. So almost there is no ischemia, no auto. This is the mamba I'm using is the mamba. Mamba has got negative pressure, so it pulls the graft. Again, you see stretching here, pulling it up, sliding, gliding skin over the rib. One tip here on the scalp, it's going like this, and then this. So you are supporting it, giving extra stability. Then the two finger forceps removal, two forceps removal. These are very delicate. You are just sometimes you are pushing only the forcep, one forcep with another forcep. It looks like you are holding. No, I'm just pushing first forcep with second forcep, just extra force देने के लिए. And irrigation, remove parallel to the skin. अब वो रुक गया तो थोड़ा सा धक्का दे दिया. It's like that. Just push it. Then examine all your follicle. Every time the surgeon should examine his follicle, how he is doing. He should ask his assistant regularly, graft ठीक आ रहे हैं क्या, PT तो नहीं है, fracture तो नहीं है, because it's a blind procedure. Graft injuries, you must know these graft injuries. Otherwise, you won't be able to examine them. Again, stretching. This from the chin, beard. Again to surgeon. See, one forceps should be ready, another forceps. If graft got stuck up, then take immediately help. It's not that you are put on the instrument table and you won't do it. So it should be ready. See how gently I'm showing in slow motion. So components of safe donor harvesting. This is a beautiful paper. I'll show you. Stay permanently means harvest from safe donor area. Grow naturally means implant healthier follicle. Do not compromise the donor aesthetic. This is a beautiful paper, and this has been given in by the second edition of the book also. This is the safe donor area concept. And thigh massage chair is a beautiful chair. I explained you. They mention the donor aesthetic, cosmetics, overshooting of the safe excision limit, the use of relatively large size punches. This is like, this is, if they are harvested, I call it you are burning the scalp of someone. I'm showing why. Because the surgeon should remember the picture. If I do harvesting means what crime you are burning. I'm burning the scalp. So don't do it. So don't do it. And if you are doing the too close, means you are destroying the house of someone. That's what I want to create an impression on the mind of the surgeon. Ki what crime you are doing it if you do it. Now the tumescence injection, this is important. Balloon out, bunch, then pop out. You should see here, and it should not be below the galea. If you do it, the vessel will be pushed more superficially. And this is the guard, because this guard is needed to control the depth, and you also need to know how much the depth of your slit should be. So this is always important. So you must take few test graph, and then you decide the needle or your length of your blade. I'm showing it in slow motion to demonstrate. Then again. This I'm using is the blade. Methylene blue. Methylene blue, I tell you, you get from the market is very diluted. I always order for the powder, dissolve them immediately in the saline, and then I use it. So you get more concentrated. And shaving. Important point here. When I make the slit, I keep my hair little long. Why? The reason during making the slit, I know the direction and the angle. Precisely, I know the direction and the angle while making. So once I have done with my all slit, then again one more shaving is done. Why surgeon does over harvesting? The lack of knowledge, safe action density to meet the unrealistic demand of the patient to compensate the high transaction rate and poor result. Now see the implantation. Again, the concept is from where I'm touching it. Goes so smoothly, popping. Just 2 days before, a fellow came to me in the evening. They always come in the evening and tell me what they have learned and what they are going to learn tomorrow. So he said, "Sir, I learned कि वो popping कैसे prevent करनी." मैंने, "What did you learn?" बोले, "जब हम डालते हैं तो अड़ोसी पड़ोसी को कुछ पता नहीं लगना चाहिए." Such a beautiful answer. Means when you are going in your slit, don't disturb other follicle. Means go gently, silently, coolly. If you don't do that, means your pressure will not be transmitted to the near follicle and they won't. So be gentle, stick to that particular slit only, don't disturb the nearby. So this is the beautiful answer he gave me. Various donor defects because of harvesting. This was my case. Strip and FE, both I did it. This is not my case. Over harvesting. This is somebody else's case. He came to me for, then I did not do from here. I did from this area. This is large size, poor quality punch. This is over the neck. Many times think that yes, harvest from the neck. Neck can be dangerous if you don't have good quality of punches, and they look very, very bad. Over excision, moth-eaten appearance, irregular hours. No, the surgeon shall make a balance between the donor supply, recipient area, and the demand of the patient. That's there the role of the surgeon is. How to avoid overharvesting? Surgeon should know safe action limit, residual density, donor area evaluation, hair mass concept, optimum punch size, how to minimize transaction, how to produce optimum results of the hair transplant. This is from the thigh. I am removing from the thigh. Now let's understand this. You can see when you don't shave it, you see the lot of hairs and you see multifollicular unit, but they are not. These hairs are quite close, and a surgeon gets temptation to take both there together, but no, you will transact both of them. So you need to understand how width, how diameter of your punch is, and at how much distance. So it's take better one. Even in multifollicular unit, I do not excise all. I leave one there and take the nearby. Again, angle, go gently, remove them gently, irrigate with the saline. So important factors for the graft excision. I'll omit the theoretical aspect, you can read them. Safe excision density is number of the graft harvested without compromising the cosmetic density. It is mostly 20 to 25, depends upon the thickness. Residual density, yes. How much you are left is more important than how much you have harvested. That is the biggest problem with the FUE. And FUT surgeon makes a lot of voice on this issue. It is the technique fault. It is the surgeon's fault, not the technique fault. My boss is sitting here. So donor density less than 30 to 40 graph will give you the visible density. So you should be very careful in removing. Let's see by picture. Coverage value. You must read this coverage value. The scalp area covered by the hair mass unit, hair density into hair thickness, hair density. This is important thing. This is the formula for it. I have published a paper on this. I did the comparison because I go to Istanbul. Dr. Erdogan has made this keyboard very beautiful system, but that is expensive and not available everywhere. So I did the manual one. So how to do it manual? Let's understand the safe excision is 96 density. If you remove 25%, then residual density is 74. Further, you remove more 50%. Still, you can see the scalp is covered. But if you remove 75%, then you see the scalp. That is the importance of your safe action. All uses loop, good quality. This concept given by me many times. Surgeons is tempted to remove single solitary hair. I call it orphan hair. सब देखते हैं ना अकेले को तो सब मारते हैं यार ग्रुप वाले में डर लगता है तो ऐसा होता है बिकॉज वेरी इजी टू एंगेज दिस बट इफ यू रिमूव इट व्हाट इज गोइंग टू हैपन इट्स गोइंग टू क्रिएट a large alopecia patch. So I call it orphan hair. Do not excise the orphan hair. Then another is shadow hair. Excise shadow hair. Is shadow covered by another hair? If you remove that, you are not going to create the alopecia patch because there is a one hair to cover that area. So if you follow all these concepts, even after excision of 3000 graph, you have the same donor area. If you excise 3000 again, then again 2000 around same donor area, no thinning is there. Thank you. So I hope I could show you the technique, detail point. If you have any question on the technical aspect, but theory you need to read it in detail. And every point has been given in the book. And the lots of videos has been given. And what QR code I shown you, you will get my all these video. तो यहाँ पूरी चीज को ध्यान से सुनो बिल्कुल you will have everything at home to go and see them.
Thank you, Dr. Garg. What was on demonstration was not only hair transplant techniques, but your passion for your work.
हाँ
I
मैं
think that must also be learned.
या मैं खो जाता हूँ मैं सच बता रहा हूँ और मेरे असिस्टेंट बोलो को दूसरे दिन आते हो तुमने किस सपने में क्या देखा सपने में जड़ दिखी ही नहीं दी साले कुछ और देखा तो मार डालूंगा तेरे को मतलब इतना खो जाओ आपको कि सब तरफ मैं जब ग्यूबिश के पास गया टेल यू राइनोप्लास्टी के लिए तो आई सा हिज रूम आई सा व्हाट्स देयर पूरा रूम भरा हुआ था पेंटिंग्स और उसके सारे सिर्फ नोज एवरीवेयर नोज दैट्स व्हाट यू शुड लिव यू शुड ब्रीथ you should breathe and you should sleep in the work which you are doing it जब आप वो करने लगते हो तो उस काम की आत्मा से आप जुड़ जाते हो तो आपको फॉलिकल अंदर नहीं होती वो दिखती है फॉलिकल छोड़ो छोड़ो मैं
Any questions? Okay, we proceed to the next talk. It's by Dr. Manoj Khanna. He'll be speaking on FUT technique recent advances. It's a video-based talk.
Sir, sorry to disturb. We have Dr. Nainish Patel, President, Academy of Medical Sciences, here in the. So I request Dr. Suresh Chaure sir and Dr. Samir Jagida sir to felicitate Dr. Nainish Patel sir. Sir, you can proceed.
Welcome, Dr. Nimesh, and thank you for coming. Affectionately, I call Anil Garg Professor. And actually, I play a lot of cricket and tennis. And when I go to play tennis in Indore in the ITF tournament, I spend some time with him whenever possible to watch him and talk to him and discuss with him. And anybody who wants to learn hair transplant, believe me, the best book in the world for Indian surgeons especially is the book by Anil Garg. Please buy it. It's not expensive. You will learn everything about hair transplant. And actually, if you ask me, I've gone to meetings all over the world, different types, but the best hair meeting in the world, I've gone to international meetings, I've gone to Asian meetings of hair, is again the Indian Society of Hair Surgery, which if you can become a member and attend, you will definitely master hair transplant. I'm going to talk about FUT, and I'm not going to criticize FUE, although there are points which will be there, and then he'll might disagree. But I think for a plastic surgeon, if you know how to do FUT, you can rule the world. And no hair transplant surgery can be done only by FUT or only by FUE. I have a few chapters in a book, in number of books, and I would like to start by dedicating my talk to my good friend, my senior, Dr. Wes Pays, the father of Leander Pays. Today is exactly 1 month that he's passed away. Wes Pays was my senior in college. And the great thing about Wes is that there are many doctors who played for their country in different sports and have done international accolades like Roger Bannister, Socrates, Rick Charles. But Dr. Pays was the first doctor in the world, he was also a surgeon, to have got an Olympic medal and a World Cup medal. He played for India in the Olympics in 1972 in Munich and before that in Barcelona in 1971. And they got a medal in both these times. Of course, he gave birth to a great son, Leander Paes, who's probably one of the best tennis players India has ever had. And I really remember him, miss him. Today is exactly 1 month that he passed away. And actually, he was my first celebrity hair transplant in 2006. And here is he. He was caught at the airport and not let to go in Singapore because people thought that the photograph of his in the passport and him, he looked very different with that hair. There's a huge craze for learning hair transplant. There are two techniques, FUT and FUE. FUT, of course, needs surgical skills, and plastic surgeons have great surgical skills. And there's a demand. My oldest patient, 82-year-old, he had 2 sittings of a hair transplant. Well-known people who've been in the world of sports and now into the media need a hair transplant. Well-known politicians want a hair transplant, want to look better. And if there's a youngster who comes to you at 28, 29, this grade of baldness, and he wants the whole head covered, it's difficult to do it in one sitting. If you did only one technique, so I did a strip on the first day of 6,000 follicles, and FUE on the second day from the scalp and the beard, transplant another 3,600 follicles to give him a head, which looks so very different. And he writes to me after about a year that thank you for getting into this life transforming journey and freedom from anxiety of wigs and glues. Covered everything in one shot in 2 days, but when you combine FUT and FUE, there's a lot of clamor about FUE nowadays, but remember, FUE is also very dangerous, and the reason it's popular is because people are untrained at doing it. It's so easy. See, 22 people died who had gone from Britain to Turkey for hair transplant, other cosmetic procedures in 2022, and why there? Even recently, in August this year, somebody died. And you're looking for cheap work, remember? Arun Lal, my good friend, said if you want to buy something good for nothing, you'll definitely get something which is good for nothing. If you look at the background of people who are doing hair transplant, even in the ISTRs, only 46%, 25% dermatologists and 20% plastic surgeons are there who actually are eligible in our country to do hair transplant. The others are not supposed to be doing hair transplant. And that's why I've been arranging a free workshop. All plastics are welcome. You can come. I did one in last year, 2020, or plastics were there. And this year we had 42 in 2 days to do a hair transplant workshop where you get everything to do hands-on and learn the technique which we of both FUT and FUE, which is very useful for you. The reason for this craze of hair transplant is the ability to get natural looking results and the big boom that is there. See, the cosmetic surgery market is projected to be 61.9 billion in 2026. But the hair transplant market has also had a big boom. And it's going to be 31 billion US dollars in 2025, which is about half of what all cosmetic surgery procedures, be it surgical or non-surgical, are going to be. And if you can get natural looking results, it's the reason why people are attracted to this procedure. There's not a myth. Many of you think plastic surgeon very difficult to head transplant. Well, like at the time, it takes so much time. It's absolutely wrong. The best head transplant surgeons in the world are all plastic surgeons from Bobel, Epstein, Barrera, Lim. And why I looked at that in India? 6 of the board of our members of governors are 8 of the 13 are plastic surgeons. And Ramchandran, Sunit Soni, Viral Desai, Mayank Singh are all plastic surgeons. And so is Anil Garg, who also is a plastic surgeon. So if I look at my work in plastic surgery in 2022, you see I don't work on Sundays, and of the 281 days I worked, I did 336 head transplant surgeries and 228 general cosmetic. But my revenue, my time taken was 40% head transplant, 60% in cosmetic, but my revenue was 80% from head transplant, 20% cosmetic. That's the reason why plastic surgeons who can do really good head transplant should take up this facility. I've done more than 8,000, mainly FUTs, or I've done a lot of FUE as well. But remember that Rome was not built in a day. It took time, and it'll take time for you also. Give it some time and you will definitely excel. Two techniques are there, everybody knows about that. In India, nobody wants to shave. Shaving is a sign of bereavement in the family. Even the most well-known people, you can see politicians, film stars, if they have little hair left, they'll still maintain at the back. Nobody wants to shave as it's required in FUE. But the most important thing, which Anil very, very rightly stressed, is to doing an FUE from the right place, because you want a transplant head that will never fall and remain. And that is a safe donor area is the area right in the middle, which you guys should restrict yourself to getting good hair. For anything beyond that, there's a possibility of falling, as you see in this 45-year-old male with grade 4 baldness. If you did a hair transplant for him, the first sitting when they strip, I would take all the permanent hair. And even if I went back after a year and did a second strip, I would still remain and get all that permanent hair. But if I did a big area of FUE, I would get 1/3 from that area, but much more beyond, and that hair may not survive. Transplanted hair in FUT, of course, are much chubbier and thicker, and so their withstanding power of time is more, and they do better. Unlike FUE hair, which are thinner and skinnier. The important thing is the diameter of the punch that you use, as Dr. Anil was saying. The stem cell is very important because the stem cell is located here in the shaft of the hair. In FUT, usually that chubbier grafts, you take more amount of tissue around it, don't damage the stem cell. But in FUE, if you're using thinner punches, you might transect the stem cell. And you'll see many patients in FUE who've done a hair transplant, look good for 2, 3, 4 years, and the hair falls off and never comes back because of this damage to the stem cell. And remember, the transplants should never fall. And in FUE, sometimes they do fall, especially if you're using a thinner punch. And a big example of this is these two gentlemen, Sehwag and Harsha Bog, got a hair transplant done in 2007. Harsha did an FUT, Sehwag did an FUE. Both look great, but the greatness of Sehwag lasted not too long. For 2011, he took off his cap. He found that 80% of his hair had gone in just 3 years after hair transplant surgery FUE. Unlike Harsha Bogle, who still has a crop of mane of hair in the top. Wayne Rooney, the footballer from England, did a hair transplant FUE. He looked very good in a while, but after some time again had thinning and to get result to go back to do another FUE to fill that area. And there's he in the end. Anup Jalota was wearing a wig, wanted a hair transplant, got a hair transplant done. Looked very nice. Looked very nice after a year. After 3 years, he was in Calcutta, and you see a lot of the hair has fallen after an FUE, large FUE, because of various reasons. And similarly, Aloknath, the well-known film star, got an FUE. Looked very good for a while, but in 3 years' time, again, has lost a lot of its hair because of technique. Principle of surgery is to see and cut, and not cut and see. And in case you're doing a second sitting or third sitting, a good idea may be to massage the scalp before the surgical procedure for a month, where you move the hand, scalp clasp to the back and donor above and below, and hold it for 10 seconds every time you do that. And when you do this technique, and you're moving the scalp above and below, you'll be able to mobilize the scalp more and thereby have a better yield and less tension on the closure of the graft of the donor area. I mentioned about this hairline already to you. To mark the safe zone, axial prudence, I usually use a scale to mark it out in a linear fashion. We'll get a better control. And as Dr. Anil showed the area on the top, of course, the anesthetic solution, Xalokin, 100 cc, 30 cc of Xalokin and 100 cc of saline, 1 cc adrenaline and Xaloc, and this Sensocaine. But importantly, I want to mention I do not use any adrenaline from 2003 when I saw Jeffrey Epstein in the recipient area or the donor area. I do not use any adrenaline in the recipient donor area. I only inject below the donor area and below the recipient area when I make the slits. Let's see the surgery, which is all for you to all to learn. So I use a double bladed knife and I make two parallel slits, two parallel lines, so that the closure will be better, better opposition with the parallel line. And once I've made this line, I will then round it off with a number 15 blade, making it electrical on either side, and I can close the entire excise strip which I have taken. Once I have done this in both the lower border and the upper border with the number 15 blade, remember, look at this. My incision at this point is only through the epidermis dermis, and I have not put any solution whatsoever here. It's only the skin. I've only infused the local anesthesia below the donor area, and now use the blade and make a parallel incision about a couple of millimeters away from either superior or inferior border for the trichophytic incision. All these incisions are only in the epidermis, superficial dermis. And this is very important, trichophytic incision, because it'll get hair to go through the scar and make it look better, as you'll see later on. Now I infuse the whole area with a lot of saline. I use only normal saline in this area, infuse the whole area to make it nice and turgid, and wait for 10 to 20 minutes before I do my incision. In the incision, I use a scalpel blade and score just into the dermis, just below the dermis into the fatty layer, but nowhere near the hair follicle throughout my incision. You see, I'm incising just into the dermis and below, but nowhere near the hair follicle, so I'm not damaging anything. And I do the same thing in the upper border and lower border, and usually divide the donor into three parts. Here's one incision on the right side of the patient, on the left side, as I choose, to make it in three different zones. Now, I don't use my scalpel blade too much. I take two double hooks and just retract the two sides apart. I'm not using a scalpel blade. There were no danger at all to the hair follicles. This easily opens out. You can see this easily opens out and gives me a plane where I can separate the two sides without using my scalpel blade at all to make an incision. In case it's too tight and the dermis is hard, you can see you're using a loop, you're using magnification, and make a nick just here to make a cut and release the dermis so that the two parts open out. And this method you continue as you make progress and separate the two edges so that the whole thing opens out in the lower border and also in the upper border till you get this floating piece of tissue which is there above the dermis. And now that this is easily visible, I will now use my scalpel blade again well below the hair follicles. I'm not touching any hair follicle, and separate this donor strip which I've taken without using my scalpel blade too much to be near the hair follicle. Actually, if you're in the right plane, you will be able to just strip it off. Here you see I'm finishing the strip on one side, but if you're on the right plane, you will see many times you're able to strip, especially a female. You don't need to use scalpel blade to be able to harvest the entire strip from the base and separate the available donor strip which will be used for dissecting the hair. I've done a few things. The advantage of this technique is that you don't damage the neurovascular bundle. And because you don't damage the neurovascular bundle, there'll be hardly any anesthesia or paresthesia in the postoperative period, which makes healing much quicker. The other innovation which I made, the next one, besides this double hook technique, is now I temporarily close the incision with 2-0 nylon. Just deep bites, and I will close this incision throughout the length with this 2-0 nylon. And this does something very interesting because it does two things. Being a plastic surgeon, you will know there's some rapid tissue expansion, and the upper and lower borders both become a little more lax, which will help easier closure. And of course, the edema goes down, and thereby also will help in my closure when I come back closing it in the deeper layer and the superficial layer. Now, I've closed the whole area with my 2-0 nylon, and once this is done, I go back later on after I've removed the entire strip to open and make the deeper closure. And what do I see? That big gap which was there when I finished taking the strip, now after I removed the stitches, is about 1/3 the size. It's 1/3 the size because the edema has settled down. There's some rapid tissue expansion, and this will make my closure much, much easier. It's very important to close in 2 layers, and I use either PDS 20 or 20 nylon if the skin is thick enough or the derm is thick enough to close. I take a bite below the hair follicles, well below the hair follicle, and then finish the bite on the superior border again, well below the hair follicle. So I can oppose the 2 layers together. Now my assistant slips in a mosquito forceps below to depress the tissue down, and I take a nice strong reef knot. This reef knot will oppose the 2 ends together as my assistant pulls with the dissecting forceps the 2 edges together. So they almost kiss one another. I get a good firm knot, which again is held safely, securely by mosquito forceps. I give my second knot. I give my third knot. And after I put my third knot, my assistant retracts the border, has a good look at where the knot is, and cuts it short, especially if I'm using nylon so it doesn't poke through the incision line. So here it is, you see, at the end of the procedure, if I've done the whole thing right, the 2 edges almost kissing one another. And this naturally should give you a good scar. The important thing next, if you can see the whole thing is almost opposed to one another very nicely, is the trichophytic excision. You can do later, you can do earlier. Here just to demonstrate, I'm doing it earlier. You excise the skin, epidermis and superficial dermis, in the border, which may be the lower border or the upper border, to leave the hair follicles behind, which will grow through, the hair will grow through the scar and camouflage it, make it look better. I used either 40 Proline or 40 Vicryl Rapid in case the patient cannot come for stitch removal to close the entire strip. And what I do, interestingly here again is the innovation, I give 20-25 bites in one shot. As you can see, a number of bites have been given. And now I use a specially designed mosquito forceps, I'll show you, and just pull them one by one together. The advantage of this is, whilst putting in the bites, I don't have to pull all the time, so that the bites are more accurately placed, they're more cohesively done. There's less tension. There's a special mosquito forceps I've designed, very thin. And what it does, that equidistant, there's no tissue of washing, there's well controlled, good apposition, and naturally, as you can see at the end of this closure, it will be a good symmetrical closure, and hopefully without too much of tension will give you a good scar. The slitting part I've shown, I use 18G, 19G needles. I've been doing it here. An important thing while making the slits is that you have a grid pattern. A grid pattern where the slits of the previous row, the next row are in between these 4 slits, and that continues, so there's no see-through effect. And of course, 19G I make, and the double-angled needle which I showed for the left-hand side of a right-side hand surgeon. So you see this, after staining, there's a grid pattern all across, if you notice it, where in between 2 slits, the next row is something in between them, and similarly the next row, so there's hardly any see-through. And the density can be good. Somebody asked me about density. You see, in the transverse axis, there's about 1 slit per millimeter, which means about 10 slits per centimeter. And in the long axis, it is about 5 to 6 slits per centimeter, which means you can get a density of 50 to 60. Not in every area, but in the areas you want to get good density and thereby cover the entire zone. It's important to keep the entire strip in chilled line all the time and keep the grafts moist so that there's no desiccation. You can use a stockinette, you can use a petri dish, and I leave a couple of millimeters of fat below the hair roots so that they can be held properly when I'm inserted them. And see the strip I've taken. All the hair follicles are intact. Because I did not use the scalpel blade too much near the hair follicles, all of them are intact from the strip I've taken, and this will give me a maximum yield. It's very important for the slivering part, and there's no scope of doing hair transplant without magnification. We do it using a 10x or 20x microscope, and of course everybody who's in the operating room using loops. And you cut slivers, which usually have 1 follicular unit everywhere, right across the harvested strip which you have made into pieces, so that the next cutters who want to cut out the grafts, the follicular units, find it very convenient to remove the follicular units, maybe 1, 2, or 3 hair. So this is sliver that we made, and this thin sliver now can easily be dissected by the next cutters. You must use sharp blades. The moment they are blunt, change them, take them off, and you can make nice simple parallel cuts only 2 or 3 times every time you handle a graft to make nice grafts which can be 1 hair, 2 hair and 3 hair. All these, remember, are done by technicians. It's not the plastic doing anything. I have taken the strip, I've done the closure, the cutting is done by the technicians. I will make the pattern, the design, the density, the direction of the hair follicles which are going to be transplanted. And again, the implantation is done by the technicians. So here we are dissecting 1, 2, or 3 hair follicle units. Nice sharp scalpel blade, whatever blade you want to use, number you want to use. Some people even use shaving blades, but then it has to be a nice straight bite with a good sharpness and minimal tissue handling so that you don't damage too much of the tissue around the hair follicular units and get a good result. So here they are lying in a stockinette with 1 hair, 2 hair, and 3 hair grafts, as you can see. About FUE, I will not talk. Anil will show you exactly what to do and how to do. It's a very, very easier procedure actually for any plastic surgeon. It needs some good hand-eye coordination, that's it. And you'll harvest good number of grafts. The beard is, of course, a great area. And the grafts here are much thinner, but then the beard hair are thicker, coarser, and cover more area. The implantation also very important. There's difference in implantation FUE and FUT. You see, implantation again should be minimal handling. There are 2 people working at the same time. And the one on the right, if you see, is the right hand, which is just pushing the graft in by 1 or 2 strokes only, not too much. The size of the slit is such that the graft just sits in. And you just put it in, if required, maybe directly, but only 1 or 2 movements are enough to put the graft. And this automatic approach is very, very important. On the left hand side, the story is totally different. The left hand pushes the graft, right hand takes the graft, while the left hand has dilated the hole, and the left hand just pushes the graft in. And what do you see? Again, 1 or 2 movements only. Good enough to put in the graft, minimal trauma, and thereby good amount of take, and we will get a good result. If we will do in the same time, if you did in real time, you'd find out that they are putting in about 8, 9, or 10 grafts per minute, which means they are something or 600 or more grafts per hour. And 2 people together, 1200 grafts an hour, in 2 hours, you will do a 2500 graft case quite comfortably. FUE, the grafts have to be held the other way. They have to be held from the skin part. They're not the root because they're very friable and fragile. And you see they're holding it from the top and just putting it in. You can use again your forceps. You can use needles, as Dr. Anil Garg was showing, put in the grafts, but you have to be very, very atraumatic because these are much more fragile grafts. Of course, there are also grafts that can put in by the implanters are there, which is like a ballpoint pen. You load it and just push it in and it stays there. Very good, especially for the eyebrow, for fine areas, but need to have training and a good technician team to do that. I discharge the patient without a bandage. I just give a headband for a couple of days. I give them steroids for 3 days to get the swelling to come down. They start shampooing on the 3rd day. You should avoid contact using t-shirts or hair oil or combing carefully for 3 weeks. I give minoxidil from the 3rd day, twice a day for 12 months, and also give them finasteride as and when required. And here is the advantage of an FUT, you see. You've done an FUT and you have no telltale sign of a surgery being done after 10 days because there's now no gap at the donor area and the hair in the front are so nice and clean and hardly made out. And here's somebody extensive. Actually, in a normal case, I got huge amount of hair in one shot. But the donor's area was so good, entire head covered only in one sitting by only an FUT. The back has little less density. The front is nice and thick, and he's very, very happy. And the interesting thing, I've done a good trichophytic closure, and you cannot see the scar, hardly see the scar over about a year because of the technique used of good deep closure and a good trichophytic closure to close the skin. Another great area, big area of baldness, grade 7, combined an FUT, strip, and FU on the 2nd day from the scalp and the beard as well. And here is he, and what he says, he's actually vice president of bank. It's a social rebirth for me. The amount of change it is. I asked him, does it make a problem for you to be recognized in public? I said, it's a social rebirth. That's big, how big a head transplant can be. A few other cases, a doctor from Varanasi, another young guy of 28, another guy you can see here, sailor, 45. Somebody from abroad and a big change after sitting of a head transplant, good natural hairline and good coverage, as you can see here. A guy from outside, you can see good hairline, good coverage. And my friend Arun Lal, with a good hairline, later on lost at the back and he put in a patch, but it looks very full because of the good hairline. Of course, our brand ambassador Harsha Bogle. Women also can be benefit extensively. Usually they have the hairline intact and they are thinning all through and you can get them covered. And somebody from alopecia areata, fibrosing alopecia, after we did 2 sittings and her smile tells you all how happy she is. But the important thing in a hair transplant FUT is to have a good team. You have to develop a team. I'm fortunate to have people working with me for the last 28 years, 25 years, 22 years. And the team is so very important to get good results in a head transplant. For the surgeon doesn't do everything. The surgeon does the surgical part, but the rest is by the technicians. And I remember a dialogue I heard from Greg Chappell. I'm actually a cricket buff. I play a lot of cricket and tennis even now. He said success is not by chance, but a matter of choice. Success is not by chance. It is a matter of choice. Suresh Chavre knows that you have to make a choice to be a good hair transplant surgeon. Work at it, and then you will have patients which will give you this smile. You will be satisfied yourself. Your team will be satisfied. The message to everybody: an FUT surgeon should know how to do FU. Very, very important to add to the yield. But an FUE surgeon, and only an FUE surgeon, must know how to do FUT if you want to survive. My thanks to my gurus, my teachers from whom I learned various steps of plastic surgery and hair transplant, and of course to all of you for the patient listening and inviting me. Thank you very much, ladies and gentlemen. Just over time.
Any questions?
Hold this. Please hold on.
So, no questions? Thank you, Dr. Khanna. We proceed to the next talk by Dr. Anil Garg, Preparation of the Recipient Area, Recent Advances.
So you heard the great talk. I really appreciate always my guru, Dr. Manoj Khanna, and he's my boss also. I learned a lot from him. So FUT, you must do it. If you want to make wonder, then FUT and FU join both. So let's start with, I'll try to be finishing in 25 minutes. I'll try to do that. So it is more important to know the topical zone of the scalp. Again, I'll tell you, scalp, treat it as a whole body. It's not just like a hand width structure. It's the whole big structure. So it has various zones, various points, various fringes. And unless and until you know them precisely how you are going to reconstruct them, that is the idea. So I classified in the point, midfrontal point, temporal peak point, transition point. I'll explain you. Then the zone, frontal, midiscalp, and the vertex. And fringes are the temporal, parietal, occipital. Triangles are frontotemporal triangle, parietal, parieto-occipital, and the edges. You must know the boundaries and detail of these zones. Now, midfrontal point is the entrymost central point of the hairline. It is important aesthetic point and landmark which plays an important role in designing. And Dr. Khanna has also shown you the anterior temporal point or temporal peak point. These are the sharp.
Sir,
क्या हुआ ये चल नहीं रहा है? It's not moving. Oh yeah, let's start. Sorry. For better understanding, you all, as I said, tropical zone, these all are the points I explained. The midfrontal point, this is the most central point of the hairline. It is an important aesthetic point and landmark which plays an important role in designing the hairline. This is the midfrontal point. And the location of midfrontal point, I'll explain you how one way Dr. Manoj Khanna has already explained about the superior frown line. Then the temporal anterior temporal point, these are the sharp angled entrymost point of the temporal fringe situated in the front of the ear, again important in framing of the face. Then the frontotemporal, this is typically becomes deeper and more receded as a part of male pattern baldness. These are alopecia areas situated anterolaterally between the entry hairline and the temporal fringe. This is the angle in between the entry hairline and temporal fringe is your frontotemporal point, and where the line meets is the point. Then the vertex transition point where the horizontal scalp starts sloping down, that is your transition point. This is the boundary from where the vertexes start. So this is that. Then the frontal area, most frontal area. This is how a line joining the two meatus is the entry front to this is the frontal area. Then the mid scalp area line across the transition point is your mid scalp, and the area behind is your vertex. This is the vertex in between the transition point and the superior border, the occipital fringe is your vertex. This is how you make the vertex as well. These are important because we plastic surgeon, we know if you want to reconstruct, you must reconstruct the aesthetic units. So these are the three major aesthetic units of the scalp. Then the entry hairline, this is the entry hairline are again divided, defined zone and the transition zone, then the forelock area and the remaining frontal area. That's your frontal area. It is having the entry hairline. Entry hairline is again divided into defined and transition zone. Transition zone is again divided into micro and macro irregularities. Let's now view all the points. Let's brush up. So midfrontal point, frontotemporal point, then this is anterior hairline. This is we divided mid-scalp, frontal area. This is superior parietal fringe, occipital fringe, vertex area. That's how we are. Now the concept is forefinger. Many times when the patient come to the OPD, he asks you how many graft I need. How much is the raw bald area? Very simple concept. I come out with the forefinger concept. Your scalp entirely is five-fold. Four, 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 and four. Forehead is forefinger. This is three, four, and then this. So frontal area is forefinger. You just keep a hand over the or his head and show him this is your frontal area. Then a hand behind it, you put it, then it is your mid scalp area. Then a hand behind this is your occipital area, and you see the baldness. For all these three area has got the this is a beautiful picture. You can take this picture, balding area of scalp here. You can print it on your OPD paper. 10,000 graft, 10,000 graft, and 10,000 grafts are there. This is important to explain that normally in this front area, my dear friend, you have 10,000 graft and you are asking me to put me just 1,000 because the another surgeon has told me just 1,000 से काम हो जाएगा आप 3,000 बोल रहे हैं. So how you are going to convince? You have to convince him by the mathematics. It's all about the mathematics. So 100 square cent and this is 100 square centimeter, roughly it is 100 square. So your balding area is the 300 square centimeter, okay, and your this is 200 square this area. So crown, mid scalp and the frontal area, these all are, and front usually we put the 3,000 gram, mid scalp usually put the 2,000, and the crown area we put 2 to 3,000 gram depending upon the level. So you tell him and then you again explain him, he still they are much less than the 50% of the 30,000. So scalp show is bound to be there. So आपको ट्रीटमेंट लेना है क्योंकि जो एग्जिस्टिंग हेयर है वो यदि चले जाएंगे तो वॉट एवर नंबर ऑफ हेयर आई एम गोइंग टू ट्रांसप्लांट आवर ट्रांसप्लांट इज नॉट सफिशिएंट recently I just saw a person, a doctor explaining that my hair transplant got failed. No, all hair transplant hair were growing but they were just 2,000 out of 30,000 grafts. So how the scalp is going to be covered? This mathematic right at the time of OPD, initial consultation, you must explain him, let him run away if he doesn't understand this mathematics. Recipient area planning, the success of hair transplant depends upon this. You divide whatever number is systematically because this is an illusion. मैं मरीज को बोलता हूं हेयर ट्रांसप्लांट एक धोखा है, एक बाल को 4 बाल दिखाने का. हम 4 बाल की जगह एक ही बाल लगा रहे हैं. तो आप बालों को लंबा रखोगे, अच्छे से बना के रखोगे, स्टाइल करके रखोगे तो आपका एरिया कवर होगा. यदि वो खड़े हो जाएंगे तो कवर नहीं होने वाला. Angle and the direction of the slits are very important. These are the different zones of this. You can see in the books. So scalp is a round structure. It's not a box. So anteriorly lowest to highest and then again go to the lower. So because we need to make a contour of it. And another important role of the hair is the contour, which has never been discussed before. Orientation of slits, sagittal slit, coronal slit. Coronal slits are perpendicular to the growth of the hair. Every coronal slit, if you are using a square blade, when you go it, then it makes the same incision size. See this. Same incision size of the width of this. But if you make sagittal slit, then it is going to become the slit size will be bigger than the width of the slit. Another important point is when you make a coronal slit, you are both end of the blade remain at the same level. But if you make a sagittal, the lowermost end will be deeper, so it will cause more trauma to it. That's the difference between sagittal and the coronal slit. And once you put multifollicular unit in this, when the one near another, this hair remains like this, so it gives more visual density. But in the sagittal, they are one behind another, they give you less cosmetic value. The instrument for creation, these are Dr. Khanna has already spoken on it. Needles are there, yes, they are good, but we do not use the bigger needle. We use the 19, 20, or 21 number of the needle, but you should start with 18 number because it is very important. You don't just push the graft in the slit. It should slide, as Dr. Khanna has said, that it should go slightly. बिल्कुल उसको उसके साइज का ही रूम मिलना चाहिए, बड़ा भी नहीं छोटा भी नहीं. And these are the square blade, this is the angle blade, and cut to size is the best blade. If you want to go for the higher density, cut to size is the best way to making the slits. Methylene blue, yes, you need to stain. What I do is I order for the powder. I think I have explained you before. Slit creation, then I think I explained you this before. Best graft. This video I shown you. So now why do we need hair transplant? Hair transplant, the purpose of hair, for which it has been given, has been lost, as explained beautifully by first speaker on anatomy, that all the purpose, now the God, the nature is removing them, but you like them, you love them. Why? The reason understand. When the anterior hairline recedes, during the AGA, the anterior hairline recedes, forehead widens, alters the facial proportion. It is very commonly said that beauty lies in the eyes of beholder. सब बेवकूफ बना रही है. Beauty lies in the mathematics. Absolute mathematics. We all are the plastic surgeon. We know it. One part of the body has got a fixed ratio with the another part. If they are there, then and then they will be beautiful. So face is one third, one third, and one third. So when the hairline recede, why cosmetic is compromise? Why ऐसा? भाई वही तो उतना ही बड़ा नाक है, उतना ही बड़ा फोरहेड, सब कुछ तो वैसा है, फिर ये अच्छा क्यों नहीं लग रहा, गंजा गंजा क्यों लग रहा है? Because the proportion got disturbed. So what you are going to do? What is your role? You to need to maintain the proportion, and to maintain the facial proportion, you do the transplant. Not is equal, so you are maintaining. So it is the facial framing. The purpose of hair transplant is framing. Vertical framing is done by the anterior line. Horizontal framing is by the temporal area. So both are important to frame the face. The location of hairline, junction of horizontal and vertical, 7 to 10 centimeter, forefinger or superior frown line, as Dr. Khanna explained. Then at what length you should keep. If you have advanced grade of binders, limited supply, then try to keep more than 8 centimeter, or it looks good. If a younger one, moderate supply, then you can afford to keep 7.5 here. Both case looking good. So individual thing, what is AJ? AGA, this get the receded anterior line and deep frontotemporal region. Your purpose is you need to maintain it back. So that's how it looks great, like this. Now the frontotemporal point, please understand this very important point because I took lot of year to understand this. There are the three criteria to put frontotemporal point. First criteria, frontotemporal point shall be at the level or just above the mid-frontal point. Mid-frontal point and frontotemporal, it should be at the level or above it. If you keep it below, then this line will become round and this becomes a female hairline, and for which the patient comes to you. Always say, मैं when 16 साल का था मेरी hairline ऐसी थी. जब भी patient आएगा मेरे को ऐसी hairline चाहिए, मेरे को ऐसी. Then show the figure, a photo of a female face. The female hairline is round, male hairline is thin, so you want to look like a male or a female. That's how you need to convince him. Then another is frontotemporal point lies in the lateral canthus line. I'll explain you further how it becomes. Third criteria. Now for third criteria, you understand few landmark: frontotemporal point, lateral canthus point, angle of mandible, sideburn, anterior border of sideburn, posterior border of sideburn, and the tragus, and the superior border of the temporal fringe. These all points are needed to know it. So as I said, the frontotemporal point should lie in the lateral canthus line. Okay. This, and one point, frontotemporal point or any point is in the 3 dimension. Okay. And if you are putting a point anywhere, then you need 3 planes. Okay. So now one plane, second plane I've already spoken, horizontal above this, one second. Now the third line is you need one more line to intersect. It depends upon, it has got 3 variations. If you have mild grade of baldness and good donor supply, this vertical line passes from angle of mandible to your entry border of the sideburn, and where the transect is a frontotemporal point. If you have moderate grade of baldness and average donor supply, then this line passes posterior to the posterior border of the sideburn. But if you have advanced grade of baldness and limited supply, then the line should pass anterior to the tragus. These are the 3 important variation. This has been again given in the book, and in my many of the tutorials video you will find it. So that's how it. So make it slightly round, but not like this. Not like this. Very common demand, they want the low hairline. So you have to create a illusion. This is the Widows Peak UK, Dr. Khanna mentioned about it, and slightly advance the temporal fringe to give the illusion of low hairline. These are the deep tuft area, defined area, transition zone, random equality. Dr. Khanna beautifully explained on this. This is the classification of temporal. This is the normal. This is the thinning. This is the peep, means the parallel to the sideburn. This need medical treatment. This doesn't need anything. This needs surgical restoration. And C, reverse C-shaped, R we call it, and it needs surgical restoration. Then how do you place the frontotemporal point? These are the criteria: the ear lobule, mid-frontal point, a lining joining. Then you again need one more line. You need this to pupil point, and then the transection is the temporal peak point, and this area is your temporal fringe. Then this is important. This has been noticed, and I published this also. The angle of hair, it varies. This man has all hair pointing posteriorly, and all goes to the external meatus. It is very simple. This angle goes to the facing to the external meatus. Then in this gentleman, upper zone is downward forward, lower zone is also again downward and forward. In this downward forward, then downward backward. So it depends how your patient is having. Similarly, you recreate them. Then the distance between the temporal point and the mid-frontal point should be less than 3 centimeters. If you don't do, then it will look aesthetic. Like if you put hairline here and temporal point here, it should be less. If it is more, what will happen? It goes here, then it will more. Or if you drop it down, then the distance will increase. So it will look unaesthetic. So this is again important point in making this. Was a very typical case, I tell you. Temporal peak point was the right place, but something was missing. I took a time to understand कि यार इसमें है क्या? Temporal point is okay, this is okay. Then I understood, yes, this fringe is receded. peak point was okay. So I filled up this gap and look, see how beautiful it looks now. And it depends upon how many donor you have. So three cases I'm showing you. The has the limited supply, only 3000 gram. So I did the conservative reconstruction of temple. In this moderate, I little put more, but it's still thin. He will need more later on. In this case, I put little more. So it depends upon how many supply you have, accordingly you will create. Then there's a mid-skull reconstruction in this temporal fringe, then the parietal hump creation, covering of this crown I did later on. Now, again, put a attention on this parietal hump creation. Why do we need to create the parietal hump? Again, remember 3 point which I told you. Supposedly, if you don't create like this frontotemporal point, if you don't create this parietal hump, what is going to happen? Let's understand. If you put it on the, if this is frontotemporal point, if you put it over the receded fringe, then frontotemporal point be lower than the midfrontal point, that this line becomes round, obtuse, and become a female hairline and is going to be anesthetic. So you need to uplift it to make it either at the same level or at the higher. That's why this parietal hump creation is needed. See, everything is mathematics. This is now. Let's see. As I told you, three planes are needed to put a point in the air. Three planes. So I want to put it. Caution is go back, front, up, and down. How? No, it doesn't depend on my choice. So as I told, again remember one point. This should be either at the same level or this above level. So one plane is final. Now second plane is, as I said, advanced grade of baldness, limited supply, then a line passing to the tragus, anterior to the tragus, crosses this line will make. But another, one more point is needed. If you remember, it should line in the lateral canthus line. So when these three lines are meeting in the space, then they decide one point, three planes, three dimension. That's why the three planes are needed to decide your frontotemporal point. Please read it. Sometimes it's really not easy to understand how this plane functions. That's how I created it. Was this like this. Now crown. Crown is usually called as a black hole, but no, I don't say it's a black hole. Black hole was in the hand of the surgeon, not over the scalp. So that the pattern, it can be a single wall, it can be double wall, it can be Z and S pattern. The convex. Now, why it is called as black hole or it's a challenge? Let's understand again the physics. The convex surface of the area in comparison the flat surfaces here is more. Understood well? Then, if the light reflects earlier from the convex surface rather than a flat surface, when light goes, come back from the convex surface, they come fast. So it is visible, it becomes more visible and difficult to cover the apex of the cone as it diversify the hair. If it is flat, they will remain here like this. When there is a convex surface, they diversify. So in the center, so apex is always visible. That is the reason this crown has a challenge. So let's see. What are the existing concept? I'm sorry, doctor, I'm covering your area. I'm sorry that. But as you said, most advanced part. So avoid or do not cover the concept, do conservatively depending on available donor area, implantation at the lower angle, non-wall pattern. As wall consumes more hair than the implanting at the periphery, implanting upside and down and styling hair in the linear fashion. These have been the concept for the coverage of crown, but I challenge all these concepts. The zones of the vertex have been divided upper, middle, lower, then the wall. That's how you create, that's how you put the graphs, center, middle, and the periphery. Dr. Suresh will explain you this point. And I use thigh massage chair for making the slit and the implant. It is very easy. Now, you saw the result and you said they are good results, but they are not. How? Let's analyze. You can see the apex. Of course, you have filled it. They are much better than, but I'm a surgeon. I can't stop myself here. Again, the patient is, sir, बाकी जो करा वो तो ठीक है sir, ये तो दिखता है ना. He wants full. So don't say I can't do it. No, it's your duty to do it. That's why you are a surgeon here. So let's accept the challenge and find out what mistake I did. Here it is visible. Why it is visible? Let's go on. You are implanted in downward direction and upward direction will always make a part line. Then parieto-occipital triangle. It was never taken care. I wrote a paper on this when it's my usual habit of, I look at all my cases. जब मैंने प्लास्टिक सर्जरी ज्वाइन किया काम धाम तो कुछ होता नहीं था कभी कभी कोई पेशेंट घुस जाता था तो व्हाट आई यूज टू मेक ए रजिस्टर ऑफ कॉम्प्लिकेशन द रिकॉर्ड ऑफ कॉम्प्लिकेशन उसमें मैं एक एक चीज लिखता था व्हाट वाज द प्रॉब्लम व्हाई इट वाज हैपेंड व्हाट इज द सॉल्यूशन व्हाट लेसन यू लर्न ये चार कॉलम में मैं रजिस्टर में लिख इवन इफ यू आर पुट इंट्राकैथ ऑन द रॉन्ग साइड ऑन द रॉन्ग हैंड आई विल राइट इट if I put wrong light direction, I'll write it. आज ऐसा हुआ ये problem हुई. Even the assistant was on the wrong side, I'll write it. This. Even the drapes were wrong. So if you write all these things, then and you repeat them, because there are only few mistakes in your life, my dear friend. 10 mistakes in your life which you repeat again and again. And the great persons they solve over one problem, another problem, 10 problems. Since you are over, then you become the best surgeon. So this was, I was noticing every patient of my one having the thinning ear. So modified approach, the limitations of exit approach is now what? Implantation at the lower angle will compromise the contour of the crown. Contour is equally important. Non-wall pattern will give the poor illusion. I'll explain you how. Implanting at the periphery leaves a bare area in the island, and implanting upside down and styling linear fashion will create a part line. So that's how. So contribution of crown in the aesthetics of the face is reducing the scalp show and the contour, which was not taken care. Contour, nobody talked before that. The hair has got great importance in maintaining the contour of the scalp. So this is how you need to create. It looks flat. So aesthetics of the scalp is this. That's how look. If you don't do this parietal, that's the flat. You have done this good, looking great. You can be happy about this, but I'm not happy because I'm not able to mimic the contour on the opposite side. It's flat here. This is bothering me because this I did not taken care of the parietal eminence posterior front triangle. So that I need to take care. So aesthetic divisions of the crown. Then I have made my own classification of this central zone means having the wall area superiorly limited by the vertex transition point, inferiorly by the superior border of the occipital fringe, laterally bounded by the occipitopara. I'll show you. This is the central vertex. This is the lateral vertex. I divided into two. Now, another my modified classification is this now. All were same, but except the central area and the lateral area. That's how it goes. So restoring the peripheral vertex. Now let's do it in two stages because vertex are divided into two zones. Now the peripheral zone. So modified approach. I have the limited hair, but I want to cover this. So how to do it? कुछ चोरी करनी पड़ेगी यहीं पर कुछ जादूगरी करनी पड़ेगी क्या करूं कैसे करूं ये कवर तो करना है लेकिन लिमिटेड हेयर है तो लेट्स डू सम स्टीलिंग फ्रॉम समवेयर jugularly. So what I did, this is this central crown, lateral crown. I need to cover this. So what I did was this. I pushed this center area anteriorly and still taken some graft from here and I extended laterally to cover the parietal eminence. So whatever the number of grafts I decided for the mid scalp area, I did this jugularly, pushed anteriorly, extended laterally, means making the two horn. What is the advantage of one thing is you are covering the parietal eminence, which was bothering and which was compromising the contour of the scalp. Because when you look here, there are the two most important points of the scalp. One is this point, and these are the two front. I did a lot of work, models, this, how it looks, then skull. I mean, Took me long time to understand ki what was the problem, why it is pronouncing, then skull pe, then mathematics, then all work were done. Then what is the another advantage? It is becoming a curtain. You see, when we look from here, this parietal eminence is covering the central vortex. So it's an indirect way of covering the central vortex. That was the another big advantage of this lateral extension. This paper has been published again. Now you understand this here. He has undergone transplant before. Then we did it. See the contour. Now restoring the central vortex. Again, this was a big thing when how I learned on this. Aesthetic importance of the world. I read a lot. Then I contacted some person who does these digital things and who are in the art. What is the importance of the world? Because I know भगवान ने या प्रकृति ने कोई भी चीज ऐसे ही नहीं बनाई है. उसके पीछे उसकी कोई इच्छा नहीं थी. They had some science, the reason, the logic. If you are not able to understand, that's the problem. He created world because this point was going to my mind. No, world was created such a beautiful thing. It has some importance. It has some importance. When I contacted all these artist people, then I could understand. World gives better coverage of a convex surface like spokes of wheel radiating outside and covering the periphery. The wall maintains the contour and the wall pattern covers the apex of the cone. How? I'll show you. The dynamics of the wall maintains the golden ratio of the nature of the beauty. We all know about golden ratio. Wall is dynamic entity. There's another concept of aesthetic, that is Gestalt principle. I read that also. Wall follow the Gestalt principle of design of these are the similarity, continuation and the proximity, because they are in the continuity. Wall maintains the continuity. When your eyes travel, if they are in continuity, you follow it, your eyelid. But if there is a break, then you identify the gaps in between. So that is the importance of continuity, proximity and the similarity. But how I noticed it, I was just walking on my terrace garden and I saw these beautiful rose. देखते तो हर दिन ही थे. न्यूटन भी हर दिन ही देख रहा था कि एप्पल नीचे देख रहा है. मेरे को भी उसी दिन दिमाग में आया कि यार ये हो क्या रहा है. Why this whirl is there? Why I'm not able to see the apex? Why they have given the leaves like this? Why there is a one central cone? So there is something, some hidden fact is there in this mathematics. So then I worked on this. The nature creates wall which increases the illusion of the coverage, and the center higher angle of lowers it covers the apex of the crown. That was where I was searching the problem. Why I am not able to cover? Why in all cases the apex is visible? How? Because whatever hair I'll put, they will depart. So how it will, and it has been put them at lower angle, put them lower angle for the better coverage. अरे भैया contour भी तो है. So then let's see now. So creating a wall and styling them in a wall. But if you don't create a wall, then it looks like this. Again, I learned from a patient. I did very good vertex, and he comes to me in OPD and shows, "Sir, ये दिखता है." I was just scratching my head. What I did good here. I realized I did here in the wall pattern, but it is not styling in wall pattern. I put my palm over his crown, put it, and just I moved it. Just I moved it and created the wall, and that's how I got the wall. You put your palm here, twist them. Once they are twisted, then the wall is created, and such minimal density will give you the better coverage. That's the importance of the wall. That is the mathematics of the illusion. Then another thing is, if you examine the wall in the center, you will see this beauty. See how beautiful the nature is. So the center of the wall, the hair are implanted in crisscross manner to prevent the visibility of the wax. That's why that was the matter. They were crisscross manner. So apex is here, they are crisscross, so they are shadowing it. That is important. It's not only the importance of the wall, but in the center you have to crisscross the hair then and then, and that's what the nature was doing here. Then again, see it, how it was done. Then I modified this concept. Now see here. Can see exactly same which was there in the tree. You can see here. That is the contour. You understood this? That's the importance of the contour. Showing up now, same length. I did again one study here. Same length, same number of hair. I put at the started from the center. I put in the periphery. Periphery is bald, but this is covered. This is the most common concept. Cover at the periphery. They have if and but. We'll explain sometime. Now the wall pattern without center in the crisscross manner. Still, you can see then creating a wall, but crisscross manner not created in the center, parting them up and down. They are in very low density, very less number of graft has been put into that. Typical wall creation and the high styled in wall pattern. Just around 1,300 or 400 grafts were put in this area. Conclusion means the hair restoration is significance. Hair restoration vertex is important. Now you cannot say no. Because आज क्या सब जगह सीसीटीवी लगे हुए हैं सब आपके फ्रेंड्स फोटो लेते हैं आपके घर में सीसीटीवी इट बॉदर्स दिस व्हेन आई स्टार्टेड प्रैक्टिस एवरीवन वाज कमिंग फॉर द फ्रंट बट नाउ एवरीवन इज कमिंग फॉर द वर्ड बोले ये सब तो ठीक है सर वो फोटो लेते हैं तब ये दिखता है so now you cannot say no for the vertex because they have the camera. They take 10 times photo. They have multiple camera in the office and other colleague sees वो काम कर रहा साला गंजा पीछे से दिख रहा है. He sees the vertex. Front इतना नहीं दिखता है क्योंकि उसको देखने की आदत पड़ गई है. But vertex, so you cannot say no now when you are not covering the vertex. So strategy of the hair transplant, I have explained all. Thank you. Exit करा के टाइम फिर टाइम एक्सिट कर
Thank you. Don't look back.
ये रिमेनिंग है या ओवर है
Any questions? Sir, I would request you to continue and your talk on PRP, GFT, exosomes, and stem cells in hair restoration. We'll take it in this session.
ओके बॉडी हेयर को नहीं करना अभी पहले ओके ओके रिकंस्ट्रक्शन बियर्ड अच्छा अच्छा एक मिनट रीजनरेटिव मेडिसिन ना हाँ दिस इज अगेन आई एम गोइंग टू टेक लॉट ऑफ टाइम इन दिस ये भी मेरा बहुत दिल के करीब है ये
Take your time, sir. Don't look at the clock.
ये अच्छा कर आपने क्लॉक पीछे लगाई नाउ रीजनरेटिव मेडिसिन regenerative means the regenerating or utilizing which is already there अच्छा 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 इसका वो व्यू नहीं आ रहा है भैया वो नहीं आ रहा वो नहीं है मेरी रिंग नहीं हो रही there's a lot of things to do in regenerative medicine now means I right from beginning my thinking is that this body this machine has been made the auto treatment. Every problem of the answer is inside the body. It doesn't need anything. It doesn't need food from outside. It doesn't need any treatment from outside. Everything is inside our body. Only thing is that you have to find out. So regenerative means the regenerating you're utilizing, which is already there, the diseased hair factory. The disease hair factory can be regenerated by nutrition, microbiomes, stem cell, platelet, positive formation, stress management. Sometime I'll talk how important this positive formation works on it, how beautiful your thinking process makes the changes in the brain. Epigenetics, growth factors, and the exosomes. We'll talk. Now we need to understand how there is a change of information in the body takes place. It is the two cells are there. How they talk through the exchange of the molecules. This one cell wants to give message to another cell. It doesn't have the mobile or a phone. It will make the message in the form of the chemicals. These are they may be neurotransmitter or complex protein molecules. Then they are put in a vesicle that is called as the exosomes in an envelope. Then that envelope goes out, then that goes to the target organ, and that goes inside and releases the message. This is the entire basic understanding of the regenerative medicine, how two cells talk to each other. So, pathogenesis of hair loss at the molecular genes and the hormonal level, the genetic factors are it is polygenic. AR gene is the most important. Mainly, other genes has also been identified. Another is the hormonal influence. Androgens means the testosterone converted into DST, dihydrotestosterone, and DHT binds to the androgen receptor at the dermal papillae. And by combining this, it alters the gene expression. Understand, because this I'll come talk. This means if something joins to your genes, it can alter the genetic behavior, it can alter the gene expression. That's what the DST is doing, and leading to shortening of the anagen, means the miniaturization. Finally, this is the basic mechanism of the androgenetic alopecia. What are the molecular pathways which work? One is the WNT and the beta catenin. DST suppresses the WNT signaling, and which is necessary pathway for the regeneration and the initiation of the division of the follicle. PGB, transferring growth factor beta signaling, promotes the catagen. It initiates the catagen, means the regression, and it has been found that higher level of TGB is there in the balding scalp. Prostaglandin PG2 is again elevated in the balding scalp, while the PGE2 and PGF2A promotes the hair growth. Now they are coming in the treatment of androgenetic alopecia, and the oxidative stress and inflammation, ROS reactive oxygen species, inflammation, infrared, microinflammation. This is again when I came to this hair loss mechanism, how it works, then I realized whatever is happening, whatever the disease start with the inflammation. If you can check the inflammation, then you can control the disease or you can prevent the initiation of the disease. So everything is the inflammation. Additional factors are microbiome imbalance. Very soon now, every time you'll be listening soon that the microbiome, and the microbiome the imbalance means dysbiosis of the skull may trigger the immune response. Another is the senescence of the dermal papilla cell reduces their ability to support the follicle generation. Senescence means the sickness of the hair follicle, means the hair follicle was working, now it is sick, so it is sitting, it's not dividing. That is the meaning of the senescence. Microbiome, go in the detail, take the picture of this is a beautiful article on the microbiome. I wish you everyone should read, because this treatment is going to be a treatment of the future for many of the things and answer to many problems which we are facing today. The microbiome is a diverse community of the microorganism, including the bacteria, fungi, viruses, which interact with the physiology of the host and in turn contribute to the health and the disease. Disruption or the imbalance in the composition of the microbiome, also referred to dysbiosis, has been associated with hair loss. I read all these histopathological study, culture, everything has been done. There's so many meta-analysis and research paper has been written on the microbiomes. There's a change in the scalp flora, on the scalp and in the hair follicle, in the dermal papilla, but that initiates your alopecia, endogenetic alopecia, because they increases the inflammation. So that further trigger the hair loss and alopecia areata. So, senescence of dermal papilla refers to the process where the dermal papilla cells, which are essential for the hair follicle growth and cycling, lose their ability to divide. They are there. Understand, there's a difference. They are there, but they lose their ability to divide and function properly. That is the senescence of dermal papillae. So, what causes DP become senescence, become sensitive? Either aging, oxidative stress, chronic inflammation, and the DNA damage. How this takes place, well, let's understand. Epigenetic, lifestyle, and I hope I could talk on this. I could a bit talk on the epigenetics. Epigenetics means changing phenotypic expression without changing the genotype. It acts through the DNA methylation, histone acetylation, and At this epigenetics, we will listen very commonly in the coming medical field, epigenetics, epigenetic, because things can be changed. We are not the we don't have to be dependent on the DNA. जैसे कृष्ण ने कहा है ना कि आप अपने भाग्य को भी बदल सकते हो, कर्म करोगे, कर्म से ही आपका भाग्य बनता है। ऐसे ही एपिजेनेटिक्स है, बिकॉज यदि आप कर्म करते हो तो आपके डीएनए में चेंजेस होते हैं, आपके वो चेंज करता है एपिजेनेटिक बिहेवियर, जीन्स का एक्सप्रेशन चेंज होता है। तो दैट इज द इंपॉर्टेंस ऑफ द कर्मा विच हैज बीन गिवन बाय द लॉर्ड कृष्णा, एंड नाउ द वर्ड इज टॉकिंग ऑन द एपिजेनेटिक्स, द सेम थिंग. So concepts of marginal, it is again a thing. I've been working on the supplements and they are the wonderful results of the food supplements. That is gave the concept of marginal micronutrient deficiency proposed in 85. Subclinical deficiency prevents and progress in incremental stop before it manifests clinically. हम लोग क्या करते हैं, जांच लिखते हैं, जांच करके आता, विटामिन B12 की रिपोर्ट लेके आता तो उसकी रेंज क्या है, 200 to 900. मेरे को आज तक समझ में नहीं आया, आज भैया ये कौन सी है यार, 200 to 900, this all is going to be normal. The broadest range of this is the vitamin B12, and if you see anybody who comes at the 300 level, he shows clinical symptoms of B12 deficiency, and the hair follicle always need at the higher level of the normal. For my patient, normal B12 is 500, 600. My ferritin is 70, 80, 90. Because things will be supplied to the hair follicle in the last. Because this is the vestigial part of the body. This machine doesn't need hair. So if extra is there, then they will be supplied to the hair follicle. Cantor's threshold hypothesis states that low iron level decreases the threshold for the development of various. This is one of the most common cause of hair loss in the young female. There is a menses blood loss. Every month there is a blood loss, chronic blood loss, but we hardly have any diet which gives iron. So they have the low ferritin, and that is the biggest cause of the hair loss in the female. Nutritionists term the consumption of food without meeting the nutrition requirement, that is called as the hunger. These three things are very important when you are dealing with the hair follicle. Hair follicles are last priority to the body to be supplied nutrients. Rather, in case of initial phase of iron deficiency, iron is taken out from the hair follicle. When the body needs, hair follicle also work as a reservoir of the iron. So first it takes out from the follicle. So these are the non-hormonal causes. These all things are there. They are very important. When the stress is there, it downregulates. It causes the apoptosis and the death. That's why you see how most of the guru has got a thick hair, long hair. मैं कई बार देखता हूँ हमारे पुराणों को, तो कोई भगवान, कोई ऋषि गंजा नजर नहीं आया मेरे को आज तक, कोई भिखारी गंजा नजर नहीं आया आज तक. और जितने इंटेलिजेंट लोग हैं वो गंजे हैं, जितने अमीर लोग हैं वो गंजे हैं. So there has to be some. Then I did a study. I did a street survey of 1,000 person. 5 volunteers मेरे ऑफिस से जाते थे. They went to the mall, railway station, and see all the patient. Then they asked them what job they are working, and that was there. That was beautiful. That highest hair loss incidence was in the professional CA doctors and the IITians. This is the patient very fussy. He was not ready to take medicine, and this is the result of food supplement only. No minoxidil, no finasteride. And now this is the food supplement with minoxidil, with minoxidil I give once a day, finasteride I give twice a week, 1 milligram. Now you see the result. This is not hair transplant, just food supplement. I got the big study, 2020 patient of 3 groups. So food supplement has got a stems. Now we come to the stem cell for which you are waiting to listen. Stem cells are the class of cell-replicating multipotential undifferentiated cell. We all know about the stem cell. These are the many types of the stem cell: totipotent, pluripotent, multipotent, undifferentiated. And these all are the potent. When this body has got huge source of stem cell, as I said in my initial talk, the answer of the all disease will be inside the body. Platelet and these adipocytes are the main thing, main boss of the treatment of your all disease. Stem cells are there in your body. You take them out and use them. So adipose tissue, bone marrow, hair follicle, umbilical cord are the sources of regenerative pluripotent stem cell. These cells can be used directly injection of stem cell or their suspension or stem cell conditioned media, means somebody takes a stem cell, then he takes out all the growth factors and then supply you. That is called as the conditioned media. And stem cell derived exosomes, I'll talk on that, PRP and PRF, everything I'll talk later on. Role of regenerative medicine: adipose derived stem cell, rich source of mesenchymal stem cells, promote angiogenesis, secrete these various growth factors. Then the hair follicle derived growth factor, they are mesenchymal and epidermal derived growth factor. When the bone marrow derived growth factor, then umbilical cord, strong paracrine signaling are there. When the platelet rich plasma PRP or PRF, in which WNT signaling enhances the WNT signaling, inhibits the TGB, reduces the inflammation, and transition of follicle into the anagen. I'll go on it how they are working. Now the platelet growth factor. Now I'm talking on the platelet. The objective, what the PRP, conventional use of the PRP for the hair loss treatment, then the advancements in the PRP, how advanced stage of PRP you can get, and what are the other indication to use the PRP beyond the hair loss. PRP is very effective, no doubt it. From since 2014 I have been working on this, and we found, I tell you, wonderful result of PRP alone. But the best result you get when you do as an adjuvant treatment. Now listen, this very important. In the scalp suffering from hair loss, hair follicle stem cell remains same, unaltered. Hair follicle stem cell remains right there, though the number of more actively proliferating progenitor cell particularly diminishes. Progenitor cells means when the stem cell becomes active, means part of the stem cell is progenitor cell. So they are there, but there is something that either someone is there which is preventing it from being to be active, or something is there which is not able to activate. The two things are there, some inhibitor or activator. यदि आपके पास इनहिबिटर आपका पता लग गया तो आप इनहिबिटर को इनहिबिट कर दो, और एक्टिवेटर का पता लग गया तो एक्टिवेटर दे दो, तो आपकी स्टेम सेल तो है वहां, एक आदमी है, मरा नहीं है वो, आपको उसको एक्टिवेट करना है, या उससे पूछो भैया तू काम क्यों नहीं कर रहा है. So you know the cause, why there is a disease. That's how you work with the stem cell. So there is a need to activate these molecules. You need an activator. The logic of why do we need PRP? What is the logic behind it? The dermal papilla cells of the hair follicle produces the growth factors. They are responsible for the maintaining of hair follicle in the regeneration phase of hair cycle. Similarly, platelet gives those granules. As I said, cell is there, but dermal papilla is not able to produce. Why? Because dermal papilla पे वो DHT आगे चिपक गया, और DHT ने उसको मना कर दिया, भैया तू ग्रोथ फैक्टर रिलीज नहीं करेगी. तो अपन उसको तो कुछ नहीं कर सकते. So let's give those factor from outside. So let's inject the PRP. That's the PRP. That's how the PRP is working. So PRP and platelets. So the PRP treats AGA via hair growth promoting actions or the growth factors. These are the signals, cytokinin. That's the PRP. Alpha granules of the platelet releases when they get activated. And these are the same growth factor which the dermal papilla releases to activate the cells. So this is a microscopic examination of the tissue. Here the baseline PRP treated activation, vascularization, thickening, all has taken place. That histologically it proves that PRP works. The result showed that PRP combined with minoxidil significantly improved hair growth compared to the minoxidil and the PRP alone. As I said, patient receiving PRP combined with minoxidil reported high satisfactory rate. Steroids. Now, it's not just like do it. There is some protocol. So what are that standardization? That was the biggest question has been discussed. So we need so many points. Listen now. Use of the needle number, amount of blood, anticoagulant, method of preparation, number of spin, centrifuge machine, brushless, or which one? Then platelet concentrate, activation of platelet, treatment interval, and fact about. These all are the points on which the studies has been done for the PRP. We'll discuss one by one. Use for the needle. It has been stated by the LEPI that if you use lower bore of the needle, it produces a high D-dimer level, more platelet aggregation. So it produces the less platelet growth factors as compared to when you use the broader wide bore of the needle, 20 G or more, it gives more platelet growth factor. Then the anticoagulant. Which anticoagulant should be used? TCA is there and ACD is there. Again, ACD has a lower pH and a lower extracellular calcium concentrate than the TSC. This environment allow and prevent the platelet aggregation and release of more growth factor. Then amount of blood. Yes, this is the most jugglery is going on about the amount of blood. 23 cc of blood I use, 2 cc of ACD I use. To get 1 cc of PRP, you need 6 to 7 ml. PRP का कॉन्सेप्ट क्या है? 5 to 7 टाइम प्लेटलेट कंसंट्रेट होना चाहिए. तो 5 to 7 प्लेटलेट कंसंट्रेशन होना चाहिए. तो हमको 1 ml PRP बनाने के लिए इट इज अंडरस्टूड दैट 6 to या 5, 6, 7 टाइम्स चाहिए. बट the process cannot be effective. Most effective method is you are able to only separate 80% of the PRP. So you need much more. So if and to cover the entire scalp, 300 square centimeter area, you need 3 to 3.5 cc of PRP. For that, you need at least 20 cc of blood. So it's the mathematics. A blood less than 20 cc is not going to give you enough number of platelets. So method of preparation, open method versus closed method, it doesn't make the difference because again there is a study that shows that PRP itself is sufficient enough to help with an infection. Number of spin is a common question asked. It depends upon the machine which you are using. I use machine which is which is a factory made. They have made for the PRP. So they have done it. If you want to do it, then you do the multiple centrifuge, send all these samples, means first blood for the platelet, then do first centrifuge, then you send supernatant and the bottom, how many platelets, then again you do second centrifuge, again supernatant. That's how you will know how many platelets has been left with the RBC, how many has left in the poor plasma, and how many platelet has come, and accordingly you manage your uh, centrifuge speed. Very common query, what shall be the, don't you think this is what? The platelet concentrate, again, that's many studies has been done. Normal is 1 to 1.5. The study shows that 1.3 million platelet in the PRP is ideal concentration for the dermal papilla for the cell proliferation because you need enough number of growth factor. That much amount of growth factor is needed to activate your dermal papillae. So it has been found that 10 to 12 lakhs of concentration of PRP platelets are needed If higher, then it is going to give you the negative effect because it has a activator and deactivator both. Activation, this again a common caution whether I shall activate or not. But if you activate, you have to use it immediately, and the sudden gush of all the growth factors are released in one go. But if you don't activate, then there is a collision. Dermal collagen tissue is there. They activate the platelet, then there will be slow activation of the platelet, and there is a constant release of the platelet growth factor will be there to your dermal papillae. So the study has shown that without activation, the results are better as compared to platelet activation. Then how much dose? 0.1 ml per square centimeter in subcutaneous or subdermal dose should be given where they are. Now there is ultrasound sonography has again come because there is a variable thickness of the skin. Deliver the PRP precisely right near the bulge area. They take the thickness of the skin and measuring the thickness, they put their needle at that depth to be delivered directly and precisely to the dermal papillae to a better effect. Then the interval, again, the studies are there. Treatment interval should be at the 1 month interval, first for the 3 month, then every month or every second month they can do it, repeat it. So 3 to 6 cycle of PRP is needed to boost up your growth. Our approach of PRP, this is what I have made it. And when I was starting 2013 PRP, it had a very expensive, and when you are not sure whether the PRP is working or not, and it's not FDA approved, how you can ask the patient to pay you such an amount? Then I started of making my own kit. I went to the glass factory. I made almost 13 models of it. Made lot of mathematics. कितना ब्लड होता है, कितना आरबीसी में आता है, फर्स्ट ट्रांसफ्यूज पे कितना आता है, लेवल कितने पे कनेक्ट होता है, बल्ब को कितना बनाओ. So if you made broader than this, then there will be junction of your blood and the plasma. If it is bigger, then the lot of plasma you have to leave. If it is narrower, then a small amount you will have to leave. So I narrowed it down. But how much? Then I calculated by multiple, and that is the reason I made many models for it. Again, it should be effective. So every sample of blood has got different weight. So have the effective centrifuge. Every sample of blood we take the weight, and to neutralize same amount of saline is kept on the opposite side of it, so that inside the machine they do not hit to each other. If they do it, you will not get the perfect PRP and the good amount of platelet. That's what where I was discussing. This junction this junction is very important. If it is broader than this much amount I'll have to leave. So that's why I designed this way. Now you see how beautifully you can see the platelet Buffy code is there. In my or all platelets, you can beautifully see the platelets, almost no RPC. That's the beauty of this my kit which I made. Glass kit. Method, and the glass is better than the plastic. You can click this my whole method of the PRP. This is already there on my channel also. This is how the vibrator should be close to this, as close as possible. So the gate block theory it works, and it significantly also the cooling is a, these are the local anesthesia. I don't give local anesthesia. There is an importance of collective underlying nutrition deficiencies again important. Session 4 month. I'm not interested in showing the result. PRP beyond AGA. Now hair transplant, immunomodulatory alopecia like the alopecia areata, chronic ankylosing effluvium, cicatricial alopecia. It works, and we have been using all these. This the paper has been published in our journal. I got SAMCBO Research Award probably in 14 where it was for this plasma as a graft holding solution. This is the study I did, scientific study. And then the alopecia areata, it is very effective in alopecia areata. It is cicatricial alopecia. We have been treating scarring alopecia along with the PRP and the stem cells, and the results are great with this. Then the conclusion, systemic reviews support many meta-analyses that PRP works in AGA, better result as an adjuvant rather than a solitary treatment. Now, telogen yes, it has a role, but there is a debate on it. Paucity of literature exists on the role of PRP in telogen but certainly minoxidil plays some role. And there are papers by some surgeon who says that It works in telogen effluvium, and we are also using PRP in telogen effluvium. Conclusion: PRP is a promising adjuvant treatment of AGA. PRP can also be used for the hair transplant. PRP is good alternative for immunomodulatory secretory alopecia. It is not US FDA approved treatment. But now there are enough meta-analysis which support that PRP work to control your hair loss. Now, do you want to see? It is already there with you, so I don't want to show you, but I can run it fast. इसके से रन होगा ये. Oh, yeah. Collecting the blood, transferring the transferring the blood to those tube, putting them in centrifuge machine. First centrifuge is for the 16 minutes separation. Then plasma is taken out. Then second centrifuge. Then see the buffy coat is sitting at the bottom. Then again, I develop a technique to mix it, local anesthesia, injection. Then you can put this. I use this vibrator after this also, doing this. This is GFC. GFC, a lot of noise about the GFC. I honestly tell you, I don't believe in it, but the patient wants to come and go for the GFC. But clinically, we are getting the result. If they are superior, I don't know. They say they put some activator into it that releases all the platelets, activate immediately, and you get more growth factor than as compared to PRP. There are few studies, but they are biased study, I am sure, because they do not disclose what anticoagulant and what activator they are putting it. And there have been reports that few of them got infection because these tubes were infected. So I don't like it, but it can be done because our PRP quality is already much good quality. But those who are not able to do the good PRP, they do not have facility of it. For them, it's a ready-made kit of GFC is good. PRF now, yes. Platelet rich fibrin. This is the advancement in the PRP, advancement in the PRP second generation platelet concentrate. Why there is a need? One of the limitation of PRP was the presence of external anticoagulant. Now, what is the disadvantage? The final release of growth factor is intricately linked with the clotting mechanism, and anticoagulant inhibits the mechanism. Means because of the presence of anticoagulant, the release of growth factors are inhibited. Partially they are inhibited. That is the reason anticoagulant, without using the anticoagulant, if you can prepare PRP, that which is called as PRF, will give you higher growth factor. That's the study, and that is the logic of using the PRF. Now, how the PRF? There are a lot of protocols, variations, various types of PRF. I'm not going to the detail, but just tell you the name. Platelet rich fibrin, L fibrin is also there, where the more 700 G force and 12 minute, but less force glass tube. Then for less time you get a advanced PRP, and further you want injectable PRP, then they further studies 2 minutes के लिए they use 60 G less force, then it remains for 10 to 15 minutes as a liquid, so then it becomes an injectable PRF. So what do? You collect the blood, do not put anticoagulant, do not put a activator into it, do the centrifuge with a low speed of 1300 RPM, and just for 2 minutes the coagulation takes place, and the supernet is your PRF, but not, it doesn't become the gel which you will be able to inject. That remains for 10 minutes, then it coagulate also, so you need to inject immediately. That is the PRF. PRF shows to produce higher cumulative yield of growth factors, solid PRP in this. Now the cell therapy. Logic of cell therapy. one thing we should understand. कुछ गलत हो गया क्या? We should understand that the stem cell doesn't work by itself. Stem cell doesn't grow new hair follicle. The stem cell does not divide and make a new organ so far till today. Stem cell, then what does the stem cell work? Stem cell releases the growth factor. They are called as the paracrine factors. So paracrine factors are the signaling molecules secreted by the cells that affects the nearby cell in their local environment. Unlike endocrine, like the hormone, they go through the blood and they go to the target organ. While the paracrine factors, they work in the nearby area. कुछ हो गया भाई? So adipose drive mesenchymal stem cells, multipotent stem cell within the adipose tissue existing in adipose drive stromal vascular cells are the one of the most promising stem cell population identified. We as a plastic surgeon know very well this is a very easy procedure. You can harvest the adipocytes from the abdomen, from the buttock, and you can separate the stem cell, and they are wonderfully working because they are mesenchymal derived stem cells, and with some practice, they can be used in the secretarial alopecia, alopecia areata, androgenetic alopecia. So separating the adipocytes, mesenchymal cell, isolating these cells from this can be mechanical and this can be the enzymatic collagenase. And for this, I refer everyone. I think plastic surgeon may be having this Coleman book. This is a beautiful book, beautiful illustration. They explain. So if you are interested, anybody, they should read this book to do the mechanical isolation of this stem cell derived condition media. But if someone doesn't want to do to separate the stem cell, so it's a good way that you can commercially condition stem cell derived condition media is available. They will provide you the growth factors. This is how you create the stem cell, grow them, culture them, separate them, filter them, centrifuge them, and finally you get these growth factors which has come from the stem cell. So they are marketed, they are available various from the various company. They do work and they are effective. Now come the exosomes. What is exosome? Exosome. So much of the noise going across the world. Some comes with the plant, some comes from the apple, some come from the grasses, some come from the bovine and all that. What is exosomes? Is basically envelope. हमारा जो पोस्ट एनवलप होता था, एक एनवलप होता था, उसके अंदर एक लेटर होता था, वो प्रेम पत्र भी हो सकता था और दूसरा पत्र भी हो सकता था, वो आपकी गर्लफ्रेंड को जाता था, वो पढ़ती थी और वो खुश होती थी. तो दैट्स द एक्सोसोम इज. Because as I said in initial talk, one cell talk to another cell by sending the messages, the message in the form of complex protein molecules, mRNA, they put in an envelope. That extravascular vesicle goes outside the cell, then they deliver. So if you catch those all envelopes, if you catch those all happy messages, they were delivered for someone else. But if you catch them, and you can be happy also. So those messages, those the complex molecules, they are the growth factors, they are the paracrine factors. You can take from those extravesical vesicles, extracellular vesicles, and use them for your own use. That is that. So, and these can be separated from the keratinocyte, endothelial cell, immune cell body, adipose derived mesenchymal cell, umbilical cord derived cell. From wherever you are getting this, every cell has got exosome. Though that cell is connected with another cell. It's not like just an amoeba. It has multiple cell. All cells are interconnected. So they have those messages. So you can separate those from, you can derive from the platelets also. You can derive from the mesenchymal, means adipocytes also. The best quality of exosomes can be taken from the mesenchymal, means the adipocyte stem cells, and the platelets. These are the various from where, as I explained, so many sources, you can drive the exosomes and they work on this. So how to make this is one thing where I want to work on it. I'm working if I can make a centrifuge machine which can make 1 lakh RPM Probably I may not. So then we can really surely we can create platelet derived exosomes. This is the whole method. If someone is interested, they can read this paper and they can take picture. You can work on it of making a centrifuge machine having the India. It is not available. Now Yamanaka factor. This is a real game changing thing which is going to come in the future. In 2006, Yamanaka came out with one thing. So far, our teaching has been that once the stem cell converted, transformed, or programmed into a somatic cell, it cannot be reprogrammed to a stem cell. But he proved, he found out 21 complex molecules which can program your somatic cell to a pluripotent cell again. And finally, shortlisted four these complex molecules. If you inject in a somatic cell, these somatic cells can be converted into pluripotent cell. Its name is the induced pluripotent cell. And with this induced pluripotent cell, you can program these cells to make in various type of somatic cells. This is going to be a game changer in the future. So as I said, everything is inside your body. You don't have to go outside. You have to just explore. Any bloody cell, you take it, inject this, convert them in stem cell. If you don't have stem cell, okay, you have a cell in the body, come with the cell. I'll make a stem cell. I'll give you stem cell. And then stem cell, you make whatever you wish to make it. It's just like that. What the future we are imagining is this. So those factors are introduced in the adult somatic cells. For example, is the skin fibroblasts using the viral vector. They reset the gene expression. They reset the gene expression again and again. Everything is the resetting of the gene expression, and resetting of the gene expression can be done. इसलिए आपका पास्ट क्या था उसके गुलाम नहीं हो. आज आप जो कर्म करोगे उससे आप अपने भाग्य को और आज के पास्ट को बना सकते. ये लॉर्ड कृष्णा ने कहा था, ये साइंटिस्ट अब कह रहे हैं, जो हो गया उसे भूल जाओ, आज करो. You can reset your genetic expression and change the behavior. That's the science. They are induced pluripotent cell. Yes. So Yamanaka factors and the hair loss treatment, potential use, reprogramming patient's skin or the blood cell into induced pluripotent cell using the Yamanaka factor, differentiating these into dermal papillary cells, and then they will give you the paracrine factors. That's how the Yamanaka. So far, they are not enough study which shows that Yamanaka factor is being used clinically. Now the hair follicle derived stem cell elixir suspension on which I have been working for so many years. Hair follicle stem cell can be dissociated using the mechanical method or the enzymatic method. And this is surprise. Hair follicle cell has got so many types of stem cells. Stem cell coming from mesenchyma, from epidermal, melanocyte, adipose derived stem cell, and sebaceous. So many cells, and it has got many other cells into it. Another surprising part is that, notably, the dermis contains a larger reservoir of the adult stem cell compared to combined total of the hair follicle and the epidermis. This is another important thing, that your dermis will give you lot many stem cells than your hair follicle. So everywhere is a stem cell. So this is the mechanical method. This enzyme. See, so many years I've been going to ISHRS. Every year those people will come, blah blah, will talk. This works, this works. If you ask them, they will not tell you anything. They will not show you how it works. But I go every year. I listen. These people pay so much. No, I will do it now. Then how to do it? Number one. Second, how to prove it? Number two. Then how to use it clinically? All these were the challenges in front of me. I live in a small city, that is Indore, where not much of the facilities are there, and that too in the private practice. So I had to work a lot to find out how I can do it and how I can do the CD marker study. Then I came out the laboratory which do the lymphoma marker. They have the CD marker. They have flow cytometer. So just by sending the sample, they will do CD marker study and you will confirm this these stem cells are there. Then the mechanical is a very, all dermatologists know about this. They trypsinize it, they separate the mechanical stem cell. Then you send this sample for the CD marker study, tryphon blue cells for the cell viability. That's how I've been doing it. You'll get the QR code of this also. I'll show you. This is the method of enzymatic I got the research grant for it, and recently I got the best research paper award in the by the ISHRS. So our studies are getting good level at the international level. It's not that. So this is the trypsin. Just shake it, put it in incubator for 90 minutes. Every 20 minutes you take it out. Do the mechanical enhancement of dissociation. Very economical things. These are doesn't cost much. So you can see these cells have started coming into it. Now you filter it. Now in that filter you can see here shafts are there. Means all cells has been released, dissociated. You do the separation, then you see so beautiful stem cells are sitting at the bottom. But trypsin is there. You need to neutralize it. Either you can do it with uh, uh, the buffer, or you can put again plasma, platelet poor plasma, or PRP, or do it 2 times with the using the saline, dilute them so that we can be neutralized, and then you mix these. Again, I developed a method how to mix it because they are difficult to mix it. So use the 18 number, 19 number needle, cut it in from the front, and then crush it, and then that's how they are mixed. And then inject in non-transplanted area. This is the QR code of the video. You can take it. You can get this matter, and you can do it at your own level. Then now send these for the examination. Your laboratory, F and blues for the viability, CD marker for the count, for the viability and everything. And how I did, this was area for transplant, non-transplant area, because and I use all those follicle will transected fully, partially. What transected follicle were used to dissociate, and to my utter surprise, this was the result. This was my first case. I tell you, I was shocked to see. I told my mother, nahi, nahi, possibly nahi hai. This we have done the transplant. They go and see that we have done the transplant. He came, no sir, these are the picture. We did only the stem cell. That boosted me. Then I applied for the ISHRS research grant because nobody is going to believe you unless or until someone really puts your hand on you. So then I did a scientific study, came out with this, then I presented, and that has been published. This study has been published. These all are the 20% density, 20 cases. These are the results of this stem cell. Results interpretation 20% was the more thickness and the more density in this. The 96% cells were viable. They were significant because p value was 0.001 less than that. The result interpretation, these are already token that this paper has been published. You can find out this paper in Forum International. Then now I was working on mechanical. The moment I came out with this enzymatic, there were a lot of queries. Some country do not allow this enzymatic dissociation. They allow only the mechanical. And the Regenera is there. Regenera costs more than 22 lakh, and every procedure is costing it using disposable, and it's very expensive. So how to make it? And for this, I worked for many years. Ordered many mixer from the Amazon, did some jugglery in the house, taken out the blend of my kitchen. I spoiled many of our this mixer, but I failed. So this is of the mechanical isolation. This is a different mechanism in which they uses the crushing technique. जो चक्की के दो पार्टों के बीच में जब गेहूं डालते हैं, तो similarly they did with the stem cell, but my technique was different. One day I was working and I was entering in the kitchen, and I saw this bottle lying in my kitchen. मैंने कहा, oh yes, this can probably work. Before that, I went to market and purchased few choti choti steel ki dabbiyan. They all got failed. I couldn't get. But this period when I was entering in the kitchen, I saw this glass bottle. Immediately, I jumped down in our my hair transplant and did this work, and it got success. These are the surgical blades I use, cut them, You can make 3 blade, 4 blade, 2 blade cutter, mixer blade. Then this is the dental, which we have. This you can get from the dental supplier. They have this. So I fix these blades over these two. Then it becomes a cutter now. Now see this now. This was the device I built. This is the final picture of my device. You have this machine with you. This is just 100 rupees. These 4 blades cost you 100 rupees. Almost in 200 rupees, you get this mixer with you. But story doesn't stop here. Then I started doing it, but it didn't work. I was so much upset. I literally threw it out. Then my assistant took it away from me. Then I was sitting like this and bring it back. लेकिन अब एक बार फिर मैं कुछ करता हूँ. Then I made a change. I'll show you. I just little bit moved up and down, up and down. What was happening when I was keeping at one level, all the follicles were going away because of the force, and they were sitting at the bottom, and they were not coming in the contact of the blade. So when I did this up and down movement, they came up and down and they started cutting. The blade started cutting, and I got the success in that. This is how the mechanism started. Take out follicles, hair follicles, transected, fully transected. Then now you know your dermis has got the growth factor. So whatever fully transected, partially transected, they use all these follicles and clean them. And then now you see the video of it. I applied for the patent, but you yourself can use it. The name I kept it, use it and make it and use it, but do not produce commercially. I applied for the patent already. Now you see this method. All jugglery. Follicles, clean them. Saline, 6-7 ml of saline. Further, I'm working on it to reduce the volume so I don't have to centrifuge for it. Just directly because there are exosomes in it also. Then this cutting. This movement was the most crucial movement. Up and down, slightly up and down. Now you can see the color is changing. And giving some stop and then again. Exactly what we do in our kitchen. Now you see the hair shafts are there. The color has changed. Now you filter it. Lots of exosomes are there in it also. I'm working with the cat to have the electron microscope to find out the exosome because they are of very small size, 50 to 150 nanoem. Now, centrifuge for 16 minutes. And now you cut it. I cut the filtrate to see what's left. Only hair shafts are left. Means hair shaft has not gone into the filtrate. They are there, and naked hair shaft shows that all cells got dissociated from this. Centrifuge it. $16. And at the end, when you see so much, so beautiful cells are sitting, waiting for you to be used. That's how you can work. And then mix it. You can mix them in PRP or in the saline. There's no need to neutralize them. And they come under the category of minimal manipulation. You don't need ethical clearance. But I know if I send paper, it will be rejected many times, while the Regenerative paper was not rejected. That's the agony of us. But this will be washed off. That's how I inject here. So the difference is if you are making for USL, it will cost you less than $10, means 200-300 रुपए में बन जाता है. Or Regenera machine is very expensive every time it uses it. And when it is, and another thing, it is not US FDA approved treatment. So I advocate you use your in transplant cases. Do not charge extra. You do your you make your own study. Don't follow me. Don't believe on me. You make your own study. Do everything by your own and then publish the paper and come out with the scientific research. Hair follicle cell suspension has that stem cell. Various studies has been done. There's been published on it. It proves that stem cell works. Scan for the tutorial. You have. क्या 25 मिनट तो एक टॉक नहीं देंगे फिर आज ऐसा करेंगे बॉडी हेयर वी कैन बट इट्स ऑल डिपेंड ऑन यू
Thank you so much, Dr. Garg. Any questions? We can take it during lunch.
मैं आप सबको एक मैसेज दे के जाना चाहता हूँ आज हम जो कुछ हमारा घर चला रहे हैं आज जो कुछ हम प्रैक्टिस कर रहे हैं किसके कारण कर रहे हैं ये सारी टेक्निक किसने दी आपको किसी ने दी अपना पूरा जीवन खपाया और आज हमारा घर हमारी जिंदगी चल रही है तो ये हमारी ड्यूटी भी है कि हम भी कुछ कंट्रीब्यूट करके जाएं everyone has the innovative brain only you have to activate it thinking that it's my responsibility when I leave this earth I must contribute from my side also so that my future progeny will be able to maintain it sustain it and they get more few things that sense of responsibility we all must carry thank you
Thank you so much for the wonderful message. We end this session here.
May I now request Dr. Suresh Chaure sir to felicitate our chairpersons for this session. Please come on the dais, Dr. Sudhanshu Kote sir and Dr. Jitendra Mehta sir. We have two journalists with us, Mr. Chetan Pandey and Sumed Wadhware. So may I now request them to please come on the dais. I request Dr. Suresh Chaure sir to felicitate them. Now we will break for lunch, but before going for lunch, Chaure sir requested everyone to please come on the dais for a group photo. All delegates. कुछ नीचे बैठ जाते हैं सब सारे डेलीगेट्स आने प्लीज सब इधर भी विष्णु बोस सर वीडियो गेम एक मिनट एक प्रणाम अरे जल्दी आना
Kind attention, everyone. We'll be starting the sessions in 2 minutes, so please take your seats. Thank you.
Excuse me, kind attention. We will be starting our next session. So may I now request Dr. Samir Jagirdar sir and Dr. Darshan Devanwar sir to chair this session. Samir Jagirdar sir.
Requesting everyone to kindly take their seats as we'll be starting with the session. Thank you. So everyone could please come and take their seats as we'll be starting with the session. Thank you. Session 4 now. We would like to welcome Dr. Surendra Patil sir and Dr. Samir Jagirdar sir to chair this session. Sorry, Dr. Darshan Devanwar sir to chair this session.
Uh, there is a slight change in the sequence of talks. So may I now request Dr. Anil Garg sir to please.
Welcome back, everyone. We begin session 4 um, by calling Dr. Anil Garg sir speaking on body hair transplant.
इसको नहीं दे वो करेगा कमेंट yes. Good afternoon. I hope we all have the energy to go with my remaining talks. The body hair, human bodies have the 5 millions of hair. To start, they are the villus. And at puberty, with the effect of androgen, they become terminal hair and they can be used for the hair transplantation. Why do we need to increase the total number of donor hair follicle to cover higher grade of baldness? For the better density and to enhance the result of hair restoration, poor scalp donor area, exhausted scalp donor area, and to camouflage the scar of FUT, recharging, or which also called as sealing and forming. You understand this is a new word, donor forming, in which you extract or harvest the more number of hair follicle from the scalp and you replace using the body hair. They can be beard and they can be from the chest or other parts of the body, because if you need much more hair, more physiological symmetrical hair, and you want to harvest more from the scalp, then you replace by the another source, that is called as donor forming. Significant scalp donor scarring and scalp show secondary to over harvesting. So donor area assessment. Now it is important to assess the body donor. Now the question is that why do we need body hair? Because as I said, there is a great gap between the demand and the supply, and we are not replacing the same number of hair which has been lost. So you replace 20% or 25%, and scalp supplies is just 5,000 to 6,000 hair graft. And to cover this, you minimum need 9 to 10,000 graft from where you can bring it. Then the best way to extract maximum exploitation of the scalp you can do be using the combination technique, which Dr. Khanna has shown you beautifully, and he has shown the great result. So that is the reason when I was shifting from FUT to FUE, there the challenge was that how to bring more hair. So that's how the idea of going to the body hair and doing much more and expertise in the body hair came to my mind, and then we started developing expertise into it. The beard is a very sensitive area, difficult position. So examine for any neck problem, cervical neck, some nerve compression or limited extension, big neck, more fatty, lax skin too much, thick skin. These all may give you some trouble. Low density of torso and the extremity needs the larger volume of anesthesia and the medication, but smaller number of the graft you will get. So tendency of hypertrophic keloid scar should be taken. White hair, yes, you can harvest, color them. Thickness less than 50 micron, they will give you low cosmetic value. High transaction if they have the curl, but advanced FUE machine and the punches, you can, with the experience, you can reduce. Density if less than the 15 or 20 graft, then you will not get much number of graft as compared to the anesthesia given. Multi-hair follicular newt, yes, if body hair are multifollicular, then it's good to have them. Exit angle is the biggest problem in this. They have got the very acute angle. So with the experience, you can manage that. That's not difficult. Variation in direction, that again is challenge. And telogen hair is another thing. That is why pre-harvesting shaving is needed, because in the body hair, like the chest and torso, they have the 30%, only 30% are in anagen, 70% are in telogen. This is the hair follicle, different anagen, telogen. Now, every candidate is not a candidate from where you can harvest the graft. The Dr. True has given a torso index, TDI, based on density, texture, presence of multifollicular unit, surface area, and the hairline. If TDI score is less than 4, then it's not a good donor area. If it is more than 7, like this has a 9 score. Roughly how you can, if someone enters in your room at the distance of 2 meter and the hairs are visible, then roughly you can say that they are of the good quality hair. Then the body hair characteristic, hair growth is nearly half than the scalp hair growth. Thickness, they are mostly thinner, except the beard has got the biggest advantage of curl and the thickness. Recipient side influence, they can be longer. This is a common question your patient will ask. They look different. So how you are, so I have developed a technique for that. That is a combination that has been published also. How to combine them so to camouflage the different characteristic of your body hair. Hair follicle unit, they are mostly the single follicular unit. This is how this hair looks beautiful, but this beauty gives a challenge to the surgeon as well. That's how you should examine the body hair. Laxity, you see the angle, direction, and you can manipulate as well as by moving the skin, gliding it over the mandible. If low angle, this can be again managed with the experience. And as I told you in my previous, that you pull it up and glide it over the mandible, then the angle will open up, and then you can do it with using this. This is the beard we are doing it. This is a poor donor area. This is the excellent donor area. Very poor, not good, and a very good area depending on the TDI scoring. Now the challenge is it's not so easy to do it, but it's not difficult as well. The acute exit angle, they have more superficially sitting follicle in the collagenous dermis like scalp hair, absent bony support in the bulky soft tissue. Some body hair are thin, hence do not have the strong shaft to facilitate the easy extraction. Greatly variable direction and the pattern, difficult position, anesthesia, and more telogen. Anesthesia is very important. Giving the anesthesia is a challenge as well as Then most commonly what I use the beard, then chest, abdomen, and rarely I do from the extremities and the pubic also. And I have never done the axil. I don't like that. The key points are patient and surgeon position should be most comfortable position. Try anesthesia to reduce the pain of while doing infiltration of anesthesia. That is the key point to get the cooperation from the patient. Then reduce ischemia time means either you do the small session of excision and do the implantation, or you do simultaneous excision and implantation. I'll show you. Ultra sharp punch. I use ultra sharp punch, very high quality punch. I use the coal punch. They are 0.75 mm, 2.9 mm. Remove dissected graft gently. This is another important point because they are very delicate. They are delicate hair shaft. If you give a slight jerk, that is going to cause a fracture or there will be avulsion or the desheathing. Now, these are the various position which I have planned for it. This is one of the comfortable position. You do extension. This is another position. And the most suitable position for everyone is this is on the surgeon's table. You can give many changes. Otherwise, these are available on online also. They are very cheap. You can give this position using these for the beard. For the chest, I have devised this. Means you make a bed sheet roll and just put below the spine of the chest, and the skin will become more tense and more prominent. And same for the abdomen also. Put a roll of bed sheet below the abdomen. Abdomen become more prominent. That's how. Now, and please see this every point important here. When you are harvesting mandible, you see my two fingers here. What I'm doing again, the same thing, stretching and gliding. This I'm doing it. Then stabilizing by this. Then what I'm doing, the glide, the skin over the mandible, because this is a pliable skin, so you can glide it to have the bony support. Then stretch, as I told, and you can get help from the assistant to have the more stretching. The advantage of this is 0.75 mm hole becomes 0.65 or zero point 0.6 mm. As much as you stretch, your hole is going to become smaller and smaller, and less trauma to the skin around that. That is the cause of hyperpigmentation if you give more trauma to the surrounding skin. Here also you glide skin over the ribs. For chest I use 0.9 mm, for 0.85 or 0.8 mm. For abdomen I use 0.9 mm. Pre-harvesting shaving is most important because they have the high telogen number. For beard 2 to 3 days, for chest 10 to 14 days, and for extremities 20 to 25 days before they should go. And if they are poor, then the minoxidil 6 weeks before can be applied. The beard donor area, oral area is for the male characteristic. Sideburn also is to be avoided, but I harvest from there. From the cheek, avoid this area, but I harvest from there also. I don't leave any part. I harvest from everywhere. And then the submandibular area and from the neck, these are the most preferred. So those who are starting, please do not harvest from the cheek and these area, harvest only submandibular area, because unless or until you have got very high quality of punch, ultra sharp, they are going to give the fractional injury, hypopigmentation or hyperpigmentation, and the scarring, and which will be more dangerous. Then obviously do not start from the sternum. This is how from the abdomen, there are from the chest, point 0.8, 0.9 mm. You see how bulky they are, how fat is there, and implant them immediately. Then the proper centering, I said previously, this epidermal blush. That's how we are doing it. The full team here, me, my wife, Dr. Seema from Beard, 2 persons are doing excision. They pop up, they jump out, just pop out outside. You don't have to go in deeper, just 2 mm is good enough, and they comes out automatically. Again, two forceps technique, keep another forceps ready to help the first forceps. They are very delicate, and desheathing is the commonest complication. This is the chest which I have shown you this video. Stabilize the skin, stretch the skin, glide the skin over the rib. Delicately remove them using the two forceps. Do not catch the shaft of the hair, otherwise that will cause break, and immediately do the grafting. Then from the thigh, lateral femoral, this can be done. This is, I have shown you this video already. but you can see it is a beautiful video. So many points to learn in this. How parallel I am going at a very low angle. I am stretching it, opening the angle of the hair, tensing the skin, removing of them are very gently, softly, parallel to the skin surface. These all things are very, very important, especially in the body hair, because most of the time I listen that my body hair do not grow. They are true, because this is so delicate that it needs a separate mind mental state, for which you have to take all care so that you produces the ischemia, you reduces the microtrauma. Planning of combination, this has been published in paper. This can be used as an adjuvant, means previously hair transplant has been done, now you enhance the result or increase the density, then or during the primary hair transplant. We as a protocol started doing the use of beard hair in the primary hair transplant, especially in grade 4, even grade 3. For entry hairline and temporal region as an adjuvant, prefer the scalp hair. If not, then the chest and abdomen hair, forelock and mid scalp area, beard and chest, abdomen hair are implanted. Vertex, listen, if not covered previously, scalp plus chest or abdomen plus beard, never put beard alone, otherwise they will stand alone and they will look absolutely anesthetic. If previously done the scalp, yes, you can do beard with or without chest and abdomen. This is also important point. The scalp show, this the significant scalp show. 4 time hair transplant has been done. No scalp donor area. I had abdomen and chest and the beard. So we did in the 2 days. I never do more than 2 area in one day. If I am doing chest or abdomen, I'll do all alone, because this is a large area requiring you a large amount of anesthesia. If you join with the scalp and beard, large amount of anesthetic you will inject and you will cross the safe donor safe donor dose. So we did plan for the beard, scalp, chest, all we took it, implanted in the temporal area, entry hairline, then the forelock area, and some graft in the crown area, and this is the final show. Still, there is a scalp show, but it is much better than what he had before. Significant improvement. This is all the result of the body hair. Combination grafting scalp hair can be harvested either by FUT and FUE or why body hair in initial stage, because nowadays the youngsters do not want to take the medicine and they just want the hair transplant, although you shouldn't do it, but in some time you have to do it in such cases to preserve the scalp hair follicle for aesthetically more important area. Like you have plant 3000 hair for the front area, you harvest 2000 2500 from the scalp, 500 from the beard, so you have saved 500 graft on the back side. Then body hair follicle growth is androgen dependent. Very often youngsters do not want to take the finasteride. Beard hair are thick and curly, so they increases the visual density. This is the advantage of beard hair. I put one beard hair in between two thin scalp hair, so he's a boss. It's curly, so he holds all these two hair together with this, so it becomes like a mask. So it gives you a bounce and a good appearance to your scalp. Thickness of the chest and abdomen here are poor, but certainly they are better than micropigmentation. This is the various planning. They are there already in the paper and they are in my book as well as. So in grade 4, roughly you think that 20 to 30% of total calculated grafts I take from the body hair, rest from the scalp. Entry hairline 2 centimeter or inch area only with the scalp hair, remaining with the combination. I'll show you the master plan of it. This is the master plan. How do it? You plant it here, entry hairline, only this. But nowadays I put a row of the beard hair just behind the entry hairline. They give a back support. They don't allow them to fly in the air. They are just supporting. Thick curly hair are supporting your relatively thinner scalp hair. So that makes a good hairline for you. This is Norwood grade 4 and 5. This is grade 4. This is grade 5. This is your payment. From this to this, you make person's face a smile. Now he's protective for our nation and the society. For any success of your work, it depends on how big is your objective. चूहा के पीछे बिल्ली दौड़ती है, अक्सर चूहा जीतता है, क्यों? बिकॉज द रैट इज रनिंग फॉर द लाइफ एंड कैट इज रनिंग फॉर द फूड. The bigger objective is life. So if you make anything of doing it's a bigger, you do any hair transplant not in terms of getting the money, in terms of my society will get a more happy, productive person. You will really push more adrenaline inside you and will you put with all your competence, and you will certainly give your better result. Now the complication, yes, they are there. This, as I've shown already, hyperpigmentation. I've seen in few of my cases. I don't know why. Probably dermatologists can put light on it, but this disappear later on. Maybe part of trauma. This the light. This is not my case also. So I took it from our book. Bob True has put this chapter on this. So these are the different in summary. As I said, 20 to 30% hair. These all are from the different areas of the body. It's my book. Next is beard and facial reconstruction. Huh? Facial hair restoration, beard and mustache. As per the practice senses, I won't go in it. Absence of hair may be low density, atrachea, hypotrachea, or post burn or post trauma may give the scarring, secondary alopecia. Facial scarring and the beard loss leads to severe aesthetic. This the boy, he went in severe depression and he came to us, no money, but he has dream in his eyes. He wanted that this should be done. That's why we did. I'll just tell you, hypotrachea is there in the mustache, the cleft lip is scar, post-burn is scar, atrachea, hypotrachea. And this is not done by me. This is from the Kinder Kapadia, my friend, plastic surgeon. Somebody did the ALT over this, and then he did the hair transplant. You can see such a great result with the free flaps and with. This is not my case. Done by the Kinder Kapadia from the Ahmedabad. This is cleft lip scar. This is again done here in the hypotrachea. Then this is probably the eyebrow. Yes, eyebrow. This is the eyebrow here. From here to here, eyebrow. It's a very tricky surgery. Now the hair bearing zone of the face and the neck, mustache, sideburn, cheek, goatee, some mental area, some mandible area, neck, and lower bed. These all are the, again, you need to know the topical zone of the face and the priorities where you need to implant them, and the submandibular area and the neck. These are the areas where various type of beards are there. You'll understand this some way. Some may have wall somewhere in the beard area and some may not have. Usually the upper border of the beard on the cheek is a line joining the angle of mouth from here to the tragus. That's the most commonly this is the superior border. Inferior border is your mandible. The step-by-step guideline assessment of the recipient area to know the condition of the scar, mark the priority area, assessment of the donor area, calculate and distribute the number of graft in individual area, discuss with the patient, take the pics, calculate local anesthesia, graft harvesting combination, and implantation. This is assessment. You know how much area, how many grafts you need. Then this is a post-burn scarring. This was a beautiful case. We did it 3 times. This is the pre-op picture. This is another case. This is the planning. Calculate the distribution. This is angle of hair, number of graft calculation, how many should go to which area. 300 to 400 for the mustache, for the goatee 400 to 600, 500 to 700 for the main body. Submandibular area is 100 to 200 graft. This is the distribution. This is the upper line zone. This is a multifollicular unit. All it's like a hairline. All single follicular unit here in a random pattern like you do in the anterior line, and multifollicular unit here. These are the in multifollicular unit in here. Then patient is ready now for the surgery. Then the option for anesthesia, we all know all these anesthesia, nerve block, then interstitial anesthesia, ring block, infiltration anesthesia, tumescence. Then EMLA cream is also means this local anesthetic it hardly works. We have used it, but now we stop. We give good unnecessary. You increase the dose and it works or not. How much has been absorbed? You can't measure how much local anesthesia has been given. So I think it's a fancy thing. Nothing doesn't work. These are the slit creation, the direction of follicular unit downward, mostly downward. If whorl is there in this area, downward and backward. If whorl is there, then you create a whorl. If it is not there, don't try to create a new whorl. Angle should be less than 10 degree. You bend your needle as Dr. Manoj Khanna has shown you. And the best thing is the implantation. Implanter, graft harvesting and implantation can be done. Post-op instructions are very important. They should not brush for a week or 5 days. They should not smile too much. They should not laugh loudly. They shouldn't talk loudly because the facial movement changes the angle and the direction of the hair. And the eating, yes, Dr. Khan. The eating is also important. Semi-solid or semi-liquid diet for the 48 hours because chewing makes use all the your muscle, chewing muscle that will uh, uh, make changes in your angle and the direction of the hair. The results are this is the hypotrichia was there. This was the atrichia almost when we did the reconstruction, the beard area here. This from this to this scar. Now, a lot of cases come for the beard reconstruction. Straightforward, I do not jump. I always give the minoxidil for 3 to 6 months if he is young, of around 20 to 25 years. Many of them grow hair with the minoxidil. If do not, then you go for the hair transplant and do a conservative because if he has alopecia, endogenetic alopecia, then you need for the scalp. So don't put all the hair follicle for the beard. Do conservative as minimum as possible because in the future he will need. This case you have shown you already. This is what the finally we did this case. Did not transplant in the neck. Then he again comes. He went for the pigmentation. He didn't like it. Then he again came for this. We did in the neck also. Means he was so much obsessive about it. And this was life transforming for him. I'll show you that also. Final two-stage reconstruction of the post-burn face and the neck. See, he was here and then you get these here. There's a lot of change in this life. And he was here. Now he is here. I tell you, this case was so much satisfying to me. He was in so much depression. He he refused to sit over this shop also because he think that if I sit here, they will see my face and run away. And after this, he joined the company. He took the training. And you know what statement was? Sir, जब मैं यहाँ था मैं ग्राहकों का इंतजार करता था। अब मैं टीवी लगाने जाता हूँ तो लोग मेरा इंतजार करते हैं। ये इसके जीवन का चेंज था। बोले दैट इज इट। अब उसके बाद अब मैं लड़की ढूंढूंगा और शादी करूंगा। दैट इज द मोस्ट इम्पोर्टेंट पार्ट ऑफ हिज लाइफ एज वेल। So take home message is no procedure is small. Every procedure is going to make contribute in the happiness his every confidence, and that confidence and happiness is needed for your society to spread happiness all around you. Thank you very much. Sorry, I was little fast in this, but I had to go for the flight to catch. Someday we'll share more. Sometime I would like to share my talk on epigenetics. The wonderful results with the you will forget everything. Just give food supplement and all that. That makes a lot of change in your life. And someday I'll talk on Garbh Sanskar in your city. One day I'll come for that also.
Thank you very much, sir. Very wonderful presentation.
Thank you.
Sir, one question.
Yes.
Most of the young ladies who have very sparse eyebrows, they insist for the total reconstruction of the eyebrows. So, what is your take on this?
Yes, the eyebrow, many ladies they come for this reconstruction. You must do it when you take most thin air from this post auricular area. If they are multifollicle unit under high magnification, divide them, make them, trim them, and using the implanter or bending the needle like Dr. Khanna has shown, you implant them. You make a beautiful drawing of it. They are all techniques are there. They are described in the book. This has been written. This chapter has been written by the most renowned surgeon. He does mainly eyebrows and eyelash reconstruction. You read that chapter. It's a beautiful and all the designing, hair direction, body, tail, head, all parts of the body, lower, upper direction of upper are like this, and the tail, all these directions are important, and you can do it, and a plastic surgeon can do it very well. No problem with that. Any more questions, sir?
Hello. Sir, what is the outcome in post-burn scars? If you suppose 1,000 grafts you did the transplantation, how much it survived?
I tell you, or the face and the other part other than the scalp, they are going to survive almost all. But few things are important. Do not put them in high density. Do not put them at acute angle. Do put them little deeper to have the more vascularity. Put the scalp because plastic surgeon gets the scalp, bald, scar because avulsion injury. Whole scalp is gone. Then we do it with the graft. So they are very thin. Even sometimes some fat was left before grafting, then they were little thicker, and over that the graft will take. Otherwise, in the scalp, too thin, then there can be the problem. So in that cases, you can do the adipocyte, means fat injection. When you build up the scalp, then you do, but they will survive. If you do it carefully, put in right plane, then they grow it, and do not put in high density, do not give the tumescence in this case, these cases, when they will grow it. They grow usually.
Sir, I do have a question. How different it is to put hairs on a scarred area than the normal? What precautions and what special tips you would like to
Yes,
give?
the most important thing is that if they are, as I said, other than the scalp, they have the soft tissue below it. And the skin, dermis, epidermis is scarred, and also subcutaneous, they have the muscle. If you put parallel to the skin at the low angle or obtuse angle, they will just be underneath the skin, so they won't be the good vascularization because skin has been replaced by the fibrous tissue. So put them at the obtuse angle more deeper to it. That is one thing. Do not give tumescence. Third thing is do not do in high density. If you are following this, then they will survive. Dr. Khanna, do you want to add any point into it? So these are the things only they works.
No adrenaline.
No adrenaline, I said. Then no tumescence, no adrenaline. Yeah, no adrenaline. Yes.
Thank you, sir. Any more question, please?
Most welcome. You can ask. For question, I can leave my flight. Don't worry. I'm here to answer.
So nice of you, sir.
Thank you.
Thank you.
Sorry for cutting my talk short. Thank you very much. बहुत अच्छा लगा. वक्ता को जब मजा आता है, जब श्रोता अच्छे होते हैं और वो कुछ दे के जाता है, तो उसको परम आनंद होता है. ऐसा ही मुझे फील हो रहा है. थैंक यू सो मच.
May I now request Dr. Manoj Khanna sir to give next talk. He will be talking on implantation techniques, recent advances.
Let's cancel the call number talk.
So I request Dr. Suresh Chaure sir to give a next talk. He will be talking on combination of FUE, FUT and body hair for type 6 and 7 and alopecia control.
Correct. Hi, friends. I'm very much thankful to Dr. Anil Garg sir and Manoj Khanna sir for taking out his valuable time and coming here and to enlighten about us the hair transplantations, tricks, and techniques. We are very much thankful to you, sir. Now I'm going to talk about combination of the FUT, FUV body hairs transplant for the coverage of the type 6 and 7 male pattern baldness. Grade 6 and 7 male pattern baldness is most challenging baldness to do the reconstruction or to do the hair transplantation because there is a lot of requirement of the follicles, that is about more than 6,000 to 8,000 follicle units for giving the meaningful coverage. Why we need to do the full coverage for the baldness? Because nowadays so many people are aware about the procedure of the, they want excellent cosmetic results, and most of the people do not have the time to go through two different stages of the hair transplantation or to do different two sittings apart from few days from the first sitting. So it is a increasing in demand. Most of the people demanding it more and more, so that we have to do the reconstruction of the type 6-7 baldness in single sitting, that is in 1 or 2 days. That's why we have to do the combination of the this. The most preferred area in plastic surgery, we always see that when we want to do reconstruction, we have to replace the tissue for tissue. That's why our first preference is the scalp donor area. And in type 6 and 7, always you will see that the donor area is very limited. And with this limited area, it is always challenging to do the complete reconstruction or to harvest more than 6,000 to 8,000 follicles. That's why we have to do the combination of the different techniques, that is FUT, FEV, and body hairs. In Norwood classification, you have seen the type 6 and 7. There is a extensive hair loss with a limited donor area. There is only prints there. And from this chart, you can see that requirement is about 6 to 8,000 follicles, depending upon the surface area of the bald area. As I have told, the preferred area is a scalp area. And when we want to optimally utilize the scalp area, then we have to combine the body techniques. In this slide, you can see that the in donor area also there is a surface donor area, and that surface donor area is yes sir, yes sir. There is a vehicle arranged at 3:30. That vehicle will come. So there is a limited separate donor area, and it is observed that if we harvest from this separate donor area, they have the longest longevity after the post transplant. And you can see there is a high risk area of the thinning, and it is very risky sometime to harvest from this area. That's why we have to do the complete thorough examinations, and we have to look for the future hair loss. In this, I will say that the family history is very important, and if you examine the family members, his father or his maternal uncle, then you can get clear idea about the availability of the donor area, and you can skip that particular area where in future there may be the hair loss, and this is especially true in younger patients. That's we do the combinations of the FUT and FUE. So what are the limitations of the both the techniques? In FUT, you will get the linear scar there, but in FUE there are multiple circular small scars. In FUT, you can harvest 4,000 to 6,000 units. In FUE, 3,000 to 3,500 max to max. And in FUT, there is no decrease in density, and in FUE, there is a decrease in density. So we can come to midpoint of all the both the techniques, so that we can optimize the use of the donor area, and we can maintain the integrity of the donor area. Why I do FUT, FUE and body hairs combination? Because with FUT technique, we can harvest the bulk number of the grafts. FUE provide additional grafts from the peripheral zone. Body hair supplements to these numbers of the grafts. Together, we can harvest 6,000 to 8,000 grafts. Surgical planning in the frontal area and hairline zone, we can put FUT and FU grafts in mid scalp. I do the combination of scalp and body hairs. My body hairs, my preferred is beard, and in crown area again we have to put FUT or FU grafts because these are the more sturdy grafts. Maximum density we can achieve in this combination is about 35 to 40 follicular units, but we have to do gradient placement. How I do on day one, I do the FU extraction from the peripheral zone with the body hair extraction, and I mix them, and I do the mid zone transplantation on day one. On day two, I harvest the APT strip and do the implantation in the frontal and vertex zone. The advantage of the both the technique is maximizing the graft availability, complete coverage possible in advanced baldness. Beard grafts add thickness and density. Natural cosmetic results with proper planning helps in preserving integrity of the donor area. The challenges are longer surgical time, variable body hair characteristic and survival. Body hair survival is about 70-80%. Require a highly skilled surgical team, and patient counseling is critical for realistic density expectation. These are the few cases. This is grade 6 baldness, 26-year male patients. These are the intraoperative combination of the FUT, FUE, and complete coverage. These are the post-operative results after 3 years. This is another patient, grade 6, with a grade 6 hair loss. Again, combination of both the techniques, and these are the results after 2.5 years. Another young patient, he very large surface area, almost grade 6, grade 7 baldness with the limited donor area. These are the intraoperative pictures, and post-operatively there is a complete coverage with a nicely reconstructed vertex area. Another case with grade 6 baldness, intraoperative, post-operative results. Another case, young patient, 22-year male patient with the complete coverage, and these are the post-operative results. Another patient, very thin hairs and a limited donor area with sparse hairs. This is a combination of the body hairs and this, and these are the results. Another patient, grade 6, with these are the intraoperative pictures, and this is the post-operative results. Here, in all pictures, you can see that how beautifully the vertex area is reconstructed with the nicely wall formation there. Another patient, young patient. These are the results. So this is the last case I am showing, and this is the coverage with the FUT and FUE, almost 8,000. These are the post-operative results. So since 2007 to 2025, I have performed more than 4,000 hair transplant. In 1098 cases, I have done a combination. Scalp survival is 85 to 95%, beard survival is 80 to 90%, and body graft survival is 70 to 80%. And it gives highest satisfaction in advanced male pattern baldness using combination approach. And the main advantage is that we can avoid the recovery, post-operative recovery, which is completed in a single sitting. Otherwise, they have to go into through same regime into different settings. So that is the biggest advantage. In conclusion, combination of the FUT, FU, and body hairs is a gold standard for grade 6 and 7. We can achieve about 8,000 grafts, provide complete coverage with natural results, and require careful planning, donor management, and patient counseling. Thank you. Thank you very much. My special thanks to my guru, Dr. Manoj Khanna sir and Rajput sir. And sir, I want to categorical state here that I am the plastic surgeon who also do the hair transplantation since last year, 18 years. Since coming from to you and learning from you, I am doing consistently here, and I give all my credits. Whatever I am today is because of you and Dr. Pravayado madam. She is the lady who had taught me the microvascular surgery, and you have taught me hair transplantation, and I am doing the only two things since last 18 years, sir. Thank you very much, sir. Thank you very much.
Thanks, Suresh. A very wonderful presentation. And he's the first pioneered plastic surgeon in Nagpur who had started the hair transplant surgery in a methodical and scientific way. And he make the Nagpurians free from baldness. And also, he's. I'm thankful to you for giving the exemplary, what you call, arrangement of this CME, because hair transplantation is the very neglected area in Nagpur. Thank you. Thank you.
Any
Yeah, no,
questions, please? I think there are no questions. We can move on to the next.
may I now request Dr. Nitin Balde, sir? He will be talking on post-operative management.
Good afternoon once again. So once we are done with the surgery, no surgery is complete with the post-operative care. So it is also one of the important part, and we should take care of it. So first and important part is to do the dressing. So once the donor area is harvested, so first we use to apply antibiotic, and the dressing should be so much comfortable that once we apply the dressing, he should be very comfortable while sleeping also, and it should be absorbent enough to absorb all the exudate, and also it should not soak or wet. Otherwise, what will happen? Patient will feel ki something is coming out of it or bleeding is there. They will confuse the bleeding as the exudate as bleeding, resulting into the more panicky situation and calling you back. So dressing should be comfortable and thick. Now, once we do the hair transplant, there are chances of having a edema over a forehead, which can trickle down and cause periocular edema also. So for that, what we can do is we can just apply a micropore in the forehead area, encircling it so as to prevent the edema. And this can be left over for another 24 hours, or in fact, 36 hours. Now, once we encircle, sometimes the patient might complain of a headache post dressing, because there is a venous congestion because of tightness of this thing, micropore. So we can tell them ki if you feel pain, you can just loosen up the dressing. And also we can use dynaplast if required. Now, why it is essential to inform, why it's essential to go for a post operative care? Because it impacts final result or outcome, and patient education is must regarding the post operative course, so as to make patient feel comfortable that everything is on time. So we can divide this into first 7 days and post 7 days. For first 7 days, I prefer to bandage that area for at least 36 hours, and then we can open it and just apply antibiotic cream again twice a day. But we should inform patient also not to apply antibiotic cream over the same area. So we should ask them to clean it up. Otherwise, what they usually do is they will keep on putting the antibiotic cream on the cream, and it can cause caking, resulting in secondary infection. Also, I usually ask them to put means recipient area is always open, and for preventing the curse formation and to promote wound healing, we usually ask them to spray normal saline 1 or 2 early when they are awake for next 2 or 3 days. So in this video, what we can see is just we are making a this is normal saline bottle. We can ask them to keep it in a refrigerator door, and we can just make hole with the hypodermic needle. And once the hole is made, we can ask patient to bend your head. So what we usually ask them, ki you can just go to the basin, look in the mirror, bend your head and just invert the bottle on that. Here we are doing at the clinic to just show them, to demonstrate. And now bending the head is very essential, because if you try to do this without bending, it might soak your back dressing. So it should, the whatever saline you are putting, it should fall on it, fall in the basin. This they can do for another 2 or 3 days. And now, sleeping position. Usually, patient should be sleeping comfortably depending upon the area, which area we're operating. So, if you're operating the frontal area, we can ask them to sleep on the back. Stomach should be avoided. We can also use travel pillow, which is U pillow, just below the neck to support it when they are sleeping. And side sleeping can also be done when usually it is said to be avoided. But if the vertex area is done, then it's not possible for them to lie down by. So, we can just ask them to do lateral position. Post-operatively, we can ask them to wear a surgical cap for another 3-4 days, and then they can wear a normal loose cap for 3-4 days. The idea of you wearing cap is to protect it from sunlight and the dirt, and it should be breathable. Also, certain instruction like the person who are smokers, can ask them to avoid smoking for at least 2 weeks, and stop consuming the alcohol, and even bending from the waist level, avoid heavy lifting of any weight. And another important point is to take care, ask them to enter wherever they are having a low height areas. They should be very careful, because few of my patients, they were accidentally hit to the door area when they are entering into the sedan, because that is very low lying area place. Or in fact, sometimes going to the washroom and then bending and then tap accidentally hit their head area. Now, the another next part is the post 7 days. This is a important part, and we should ask them. We should educate them about the natural course of the graft growth. Following hair transplant, graft will be shed off, and they will grow after 3 to 4 months. And this is the hardest part for the patient. Instead of telling them, they will keep asking ki when the graft will grow. Some graft may enter quiescent phase, and they may not grow or they not shed. The period of inactivity usually from 2 to 3 weeks to 3 to 4 months. Then we can also see pole pincus mark, which is a focal shaft constriction, and that is a reason. The reason for it is how the grafts are handled at the time of intraoperate or postoperatively. And once after shading stops, the hair. Sometimes we can observe mild folliculitis, because whenever the shaded graft means the shaft goes off and then new shaft coming up, it might irritate the epidermis, leading to the epidermal folliculitis. Initially, the grafts may be fine and short, and usually they become terminal over a period of 8 to 12 months. Now, one more thing which we should understand is the whatever graft we are implanting, they have a synchronization of the phase. So, usually, scalp has a asynchronous phase. Every follicle is in different phase of anagen, catagen, telogen. But when you are doing the transplant, there is a sync in the cycle. So, whatever graft we are implanted, so they will enter anagen phase, catagen phase simultaneously, and also shade off like that. So that's why some people may observe after a period of 3 to 4 years sudden thinning of the hair. But that is a temporary telogen phase which is happening and which can easily restored after some time. Now this is a patient just before the surgery after markings. You can see on the left side the immediate post-op. Then after on the day 3rd, day 8th, and eventually, usually I show this slide so make them aware that this is how it's going to be done. After 3 months, 4 months, and this is the final picture after 8 months. Now coming to the head wash, some surgeons prefer to do first head wash at their own clinic, but I usually ask them to do it at home only. What I'll advise is just lather out the foam, keep it in the crusted area for around 10 minutes, and then that so as to moisten the crust and loosen it up, and gradually with the pulp of finger they can massage, and uh, the crust will get dislodged over a period of next 2 to 3 days. Return to the work, patient, if they are doing office work, they can immediately start their work. But if they are having some field work or office, the work where you require strenuous job, then we'll ask them to take a leave for around 4 to 5 days. Exercise, patient can resume mild exercise after 10 days. Swimming can be resumed after 7 days, as early as 7 days, but we ask them to avoid for at least 3 to 4 weeks. Heavy exercise like gymming and all can be started after 4 weeks. Minoxidil use, it can be start as early as 7 days, but sometimes minoxidil can cause irritation, so we can postpone it till complete healing is there for at least 2 weeks. And if the irritation is there, we can use topical steroid to counter that. Now, post-operative complaints, these are the complaints which patient usually comes like complaints of the pain, which can easily be taken care with the mild NSAIDs, diclofenac, aceclofenac, whatever you prefer, along with serrapeptidase to reduce the edema. Then the post-operative edema, this is only because of the infiltration of tumescent. If you are using more tumescent, there is a chances that you can have a edema, and this can descend from the forehead to the periorbital areas. And to prevent this, what we use is we can use the micropore, or we can ask, and once if it occurs, then we can ask the patient to position properly, like while sleeping. We can give a massage gently from the middle of the forehead, just pushing with both the thumbs to lateral areas. Then sometimes cold packs, steroids, or NSAIDs. Most of the surgeons usually use steroids in the tumescent injection to prevent this post-operative edema. Then bleeding is very minimal with the FU techniques, and both in the donor and the recipient areas. Bandage will offer both pressure and the absorption of the mild bleeding if there. And if any times we can inform the patient that if there is a bleeding, just give a firm pressure for about 10 minutes, it will stop. Crusting, this usually forms after 24 to 48 hours. Crusting neither influence the graft survival nor healing unless they persist for extended period of time. So for at least 7 days, if it is there, it's not a problem for us, but we should remove the crust after 7 days. Some patients are very hesitant to apply the pressure also, and they can carry the crust for at least 2 weeks, 3 weeks. But for them, then we'll have to counsel and do it at the clinic. Graft dislodgement for the FU graft, they are very delicate, and if they are once dried or desiccated, they are not at all viable. So once that is done, then we cannot do anything, and that area is lost. Hiccups. This is very uncommon, but usually I have seen few of the cases wherein the patient start complaining of the hiccups on day 2 or day 3, and the cause is not very certain. It's only because of the irritation of sensory branches of the phrenic nerve, which innervate the post-auricular area. The treatment is mostly symptomatic. We can go for metoclopramide or chlorpromazine with a BD or TDS dose. Post-operative effluent, this usually occurs in the area where we are doing means if the area is recipient area is having a little bit of own hairs and we are implanting in that area, then it's very common. But this can be taken care of means by informing the patient. Usually it persists for 2 to 4 weeks, and hair regrowth starts after 2 to 4 months. And also it is more common in female, and it is advisable not to go for using the adrenaline. And when we are making the slit in the recipient area where if there are pre-existing hair, it is always advisable to go for higher magnification, because with that we can easily make the slit without harming the existing follicles. Pruritus, mild pruritus is very common and can be managed with the topical steroid in a solution. And topical minoxidil can be also a cause in when we are starting it very early. Hypoesthesia, which is more common with FUT surgery, normally it resolved within 3 to 6 months, but occasionally can last up to 1.5 years also. And some patient may have a persistent focal sensory loss. To conclude, post-operative period of hair restoration is usually well tolerated and uncomplicated, but the key to avoid the problem is to educate the patient about the normal recovery and to remain vigilant for the signs of abnormal healing. Now coming to the long-term maintenance, when you are looking at the post-hair transplant surgery, then we have to educate the patient regarding the long-term management with minoxidil, finasteride, and also with newer regenerative therapies like PRP, GFC, and stem cells. We can maintain the result for a prolonged period of time. Thank you.
Very beautiful presentation. Actually, we thought there will be a single slide for post-operative care, but you elaborated so well and very practical tips for post-operative management. And now, any questions from the audience? I think there are no questions.
Can I make a couple of comments, right? I think you can start shampooing earlier. Waiting for 7 days, not necessarily. You can even shampoo on the third day. That's good enough. Because things get clean, patient gets more happier with himself rather than bandage moving on 7 days. A couple of things are there, but otherwise very good, very nice.
Thank you, sir.
And one more thing, immediately after surgery, I've been doing this last 7, 8 years. I take a picture where I have transplanted the hair.
Yes, sir. I do
Because
that.
many people will come back and tell you, आपने जो बाल लगाया तो आए नहीं. Then you can show them that this is the area of transplant, this I did not transplant, those hair have fallen off, this have come. So that at least you are more comfortable and the patient understands what you've done is worked and they will not complain about it later.
True, sir. Thank you.
Sir, may I ask one question regarding photography? Is there any special, what you say, hints for taking photographs for hair transplant patient?
So very important is never use a flash when you take a photograph. When you take a photograph, ideally, the ear and the upper lip, the lobule of the ear and the upper lip should be in the same plane, parallel to the ground, which makes it a standard view. Take a photograph from the front, from the top. You can take from the back in case it's vertex, from the side, left lateral, right lateral. And the lighting is good important. See, many times when you take a photograph, especially post-op, the light on top will reflect and that zone will not be visible. So avoid that light and there should be clearly visible. Whatever you're taking should be very clearly visible. Light can be a big trick. Thin area of hair loss, if you don't have lights, will look very thick. A lot of hair also with bright hair on top will look thin. The patients click their own pictures on their mobile with a flash at times. So those things you have to avoid.
Sir, likewise, just different than what topic was presented here, but is there any special mention in the informed consent?
It's a small trick. You see, in my consent form, which I got from the US when I was getting trained in cosmetic surgery, there's a line that I can use the photographs of the patient pre and post operatively for clinical presentations, patient information, etc. Patients usually don't read deep into the line. Some celebrities might say, "Yaar mat lena, kuch kuch karke." Otherwise, that is there which can allow you to at least use their photographs and have a good result. But if patient says, "Don't use my photograph," please don't use it because there have been cases where patient has been sued, doctor has been sued, and your defense can be difficult.
Patient will strike off that line.
Yes, sir. Who have read very well, बोले क्यों लिखा है डॉक्टर साहब उसको हटा दो हटा दे भाई.
Thank you, sir. Thank you. Cool.
So may I now request Dr. Suresh Chaure sir to felicitate the chairpersons for this session. Please, Darshan Devanwar sir and Samir Jageda sir. Now we will proceed for panel discussion. So I request all the speakers to please come on the dais. And moderator for this panel discussion is Dr. Gaurav Jannawar sir, Dr. Snehajit Wag sir, and Dr. Alkan Fidvi sir. May I request all the speakers to come on the dais? Nitin Birde sir.
Good afternoon, everyone. After the marathon discussions and such enlightening talks and so much of theory, so obviously we have a lot of knowledge to implement. So now, the point of having this panel discussion was to have the tips and SOPs from the masters how to tackle the cases in the real life. So we are having a list of few cases and we would like answers from the masters that how do we start evaluating, how do we stepwise start managing such cases. Uh, so we are going case wise, yeah, Parikshit sir, please. Darshan sir, please join. Sir, if we can break the management in terms of how to start evaluating, is there any pre-operative medical management part? How to break the surgery in the different wings? Like, does it require all three hair kind of varieties for the transplant? And then any special mention about the specific post-operative management? So we would like to have some stepwise idea about the cases. So this being 18-year-old boy with a strong family history of baldness, developing thinning of hair and wants hair transplant. So a very common scenario. So how do we proceed with the pre-op thing?
For our surgeons here, you must have read Bailey and Love. There was a line there in Bailey and Love. For a female who comes for an appendectomy, make her earn the operation. Similarly, for a young guy who's 18, wants a hair transplant right away, you've got to make him to earn the operation. The first line of management definitely for this case will be medicine. Explain, convince him. Nowadays, many youngsters are so obsessed they will not go to school, they won't go to college, they won't meet friends. I don't look handsome, I look bad, blah, blah, blah. So you have to spend some time counseling them, which is usually much more the time you to treat a patient. And what I do is I write it down the prescription. I promise I'll never let you grow bald. I promise I will never to grow bald, and sign that and tell them you have baldness. I will correct your problem, but you use medicine for 6 months or so, you will definitely improve. You'll be better. And once they start using the medicine, there's a different improvement. Of course, certain areas, say frontotemporal baldness, etc., will not go away with medication, and you'll have to do surgery. But you must try and use medicines, especially for these younger patients. And with this thinning in the crown and in the central area, they will definitely improve by medication.
Thank you so much, sir. As they rightly say, it takes around 6 or 10 years to learn a surgery, and it takes lifetime to learn when not to operate. So, absolutely great advice from sir. Coming to our second case, this type 6 male pattern baldness who has undergone a hair transplant with not satisfactory results. So, what can be the reasons to rule out, and how do we proceed now after he has already undergone a failed, in terms of his version, failed transplant?
नहीं सब बोलूंगा. This is a panel, Baba. I'm not the only guy on the panel. Okay. Why it failed? It's very difficult to say. How was the surgeon? What did the surgeon do? How did it go about it? But etc. etc. Very difficult to say why it failed. And I think it's always advisable. Never speak derogatory about the previous surgeon. Whenever you have a patient who's been coming to you who's not happy, never ever. I learned it from my boss, Dr. Arumugam, way back. Never say bad. You say he must have tried his best. There must have been a problem, etc. I don't know how he was before, but no doctor wants to do a bad surgery. Very, very few doctors who just money-minded might just do something. So try and defend your previous surgeon. Um, you have to bring down the patient to a realistic expectation. Another common word I use is I can make a change. I can give some hair in the front. I can do this, but I cannot make you Shah Rukh Khan. I cannot make you Shah Rukh Khan. I cannot make you a head full of hair. And I say even more strongly to women, because women have an expectation which is very difficult to satisfy. So you tell them, I cannot make you as good as Madhuri Dixit or somebody else. You will have little thinning. You will be better than what you are, but you cannot be a head full of lot of hair, which is, if that's the expectation, not be happy. And don't operate on the first shot. Call him for 2 or 3 sessions, counsel him well, talk to him well, think of medicines, tell him the other hair will become better. Let's take a course of vitamins. And when you're sure that he deserves a head transplant, he's ready for a head transplant, he's understood his expectation, then go on. You have to do a head transplant for this guy. You have to maybe combine scalp hair. You can use some from the beard hair. I think he's got a decent beard, looks like that. And tone it down, expectations down. He will definitely improve. There's no reason saying no to him, because where will he go? What will he do? But get him to be realistic to what you can do for him, and then I'm sure you will be able to get a good result, decent result.
What is your ideal choice for such cases in donor area choice?
My ideal case, everybody knows what's my ideal choice. I always combine for a large area. I'll do a strip. The strip gets me the best quality hair. Another thing I want to clarify, I never tell my patient to do a strip or a FUE. I never tell my patient. Fellows who come and train with me will tell you, I say I'll do what you want. You want FUE, I'll do FUE. You want FUT, I'll do FUT. And when they discuss and I tell them their details and about people, blah, 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 then they say, okay, sir, you do what is best. This is FUT, I'll do it. Combine FUT with FUE, as Suresh very rightly said, don't do it in one day. One hour is difficult. I usually do it a little different. I do an FUT on the first day and do an FUE on the next day in the saves area and the beard extensively. Body hair, I've done a few cases, but I think it's something where somebody is desperate that they want to do body hair because the anagen phase is much shorter than the catagen phase. The hair are much thinner. Unless the patient is obsessed and he wants body hair, it will be difficult to make him happy. But combine in 2 days, get as much possible and a graded density in the front, give good density in the frontal tuft, from the hairline, in the frontal zone, and then bring it down gradually. Use more amount of your beard hair in the center and the vertex, which have, because of the thicker quality of the hair, which is thicker, coarser, wirier, and curly, it gives an idea of more hair. Increase the density, increase the diameter of hair by only 10%, has a show better of 30%. That's the difference it makes the diameter. So do this. Be realistic. Put the patient also on medication for a year at least. There's other hair which are small might become better. I also give them routinely a vitamin course of 3 months of multiple vitamins, which I have got a regime, which also is helpful. And that's the way you go about it.
Thanks. So as this
There are
patient,
more panelists, huh?
so as this patient is all about failures, and if we evaluate, if we find him donor area cripple, um, do you advise him hair patch, or in other words, in what percentage of the patients do you actually advise hair patch, or you don't?
See, when the donor hair is limited, then and he wants a head full of hair, the only way is a hair patch. But the problem with the hair patch is once you look at a patch, you know it's a patch. Even the best of patches you see, Amitabh Bachchan, you say, oh, too big lagaya. So a good way of settling the problem or getting away from the problem is what a number of people have done. Like even Arun Lal. Arun Lal did a couple of hits on the front, very good. Then he got bald here. He says, "मैं क्या इतने बाल मिलेंगे नहीं." He said, "ठीक है boss." He got a patch. So nobody knows what's happened. Or the patient I showed you. So make a good, nice, strong hairline which blends with your patch. And the patch behind will have a head full of hair. The hair transplant in the front looks natural. They move around. Nobody knows really what's happened. And that way you can get decent result. But you cannot get him a head full of hair, very thick hair, not really possible. And would tell him right away before you do anything.
Right.
Sir, any difference in management of patients who have only hair transplant and they have a patch and a hair transplant? How do they
No,
take care of both
the
separately?
patch has its own this thing. You have to go, maybe if they stick it on, then you have to go once a month or so and get it shaved off, cleaned, and this thing. Or if you're in clips, you just take it off in the night, put it in the morning. And the hair transplant area, you'll have the normal regime. If some hair are there, then I might even continue minoxidil for a while, or maybe continue as long as required and have finasteride if the patient's age group is okay. That's it. The patch, the management will be like a patch, and the other hair will be like transplant hair. I won't leave the mic now.
About the vitamins, which one is the best, A, E, or all?
See, there is no one vitamin which is best, and hair basically only falls with the shortage of some vitamins. Vitamins will not prop up the hair. Like some people give biotin for years. Well, 1 month of biotin is good enough to get back to whatever if there's a deficiency. But certain vitamins, especially vitamin A, B, B12, C, D3, E, iron, calcium, amino acids, all have a role to play. And there are some commercial packs available also, which are very they influence the doctors a lot. You get so much of money if you pay sales. So I don't do that, but I have made a group of the best doses available in different drugs, and I give it to the patient. And many patients who are having a hair loss, especially women, females who are having hair loss, stress or telogen effluvium, etc., improve a lot with this medication only along with minoxidil.
So next is also a post-operative case. In this patient who has undergone hair transplant, the hairline is reconstructed in little bad way. He has too low of a hairline on the forehead. How how does the expert panel suggest on managing this case?
See, once you have a very bad hairline reconstructed, then the option remains with us to consider a good hairline, draw it, explain the patient that hairline should be at this level, And then once you get the approval and everything from the patient, then we can remove this extra graft with the FU punch so as to you should be done with a minimal small punch so as to leave a very minimal thin scar, and then we can add on the density to improve the hairline. This hairline is not having a proper transition zone also, and it has been wavy. The what are the micro and micro irregularities we are talking about, they are too thinned out, and there is no transition. And even on the temporal area, if you're looking at, it is more of a female hairline rather than a male hairline. So we have to remove that graft and plan a proper hairline. This will manage.
Sir, will you ever combine hair removal with a setting of hair transplant, or you will
No, we
stay
can
here?
utilize the same graft elsewhere. So there is no point in doing the laser hair reduction because laser will destroy the hair. But we can utilize, remove those grafts, and we can either put it behind. And also the grafts which are put in the front area are not a single graft. For a hairline, initiation should always be with a single hair follicle graft and followed by multiple, like 2 and 3 eventually.
My personal experience is I have done one such case where I had to uh, remove certain part of the hairline, and I found that with the FU punch it is very difficult to remove these hair because probably this newly growing hair will have their follicles in a very spiral way now attached. But with all your attempts, they never grow back in that particular area. That's what I felt. And mostly those follicles will not be utilizable. So probably you'll have to go for some other donor site for achieving a different density in different area.
So when I have done this such kind of cases, I have found those follicles were viable and I have triple implanted with a few.
Actually, if the follicular units are 2, 3 hair follicular units, then when you take them out, you can recycle them. You can maybe put them at the backs, depending on how coarse or thick they are, which is the quality of the hair. But if you do a good proper FUE, you will be able to use them, hopefully.
But there's a more transaction rate was there.
Yes. Right.
So next case is a partial hair sideburn reconstruction done. How can this case be managed? Because the sideburn has been completely done. So can the panel guide us about
My
sideburn reconstruction?
my take on this sideband reconstruction is that the first priority should not be given to the sideband reconstruction because sideburn hair loss is a progressive hair loss, and we don't know how much it will progress. So if partial reconstruction is given, then it gives this island effect. And if we really want to do the sideburn reconstruction, then it should be done as a total aesthetic units, and each site requires around more than 700 grafts. 600 to 700 grafts, then and then we can give the good reconstruction of the sideburns. So it will utilize a maximum grafts on this area only. So our first priority should be frontal area, hairline area, and this should be secondary priority. And depending upon the availability of the donor area, then we can think about it. Don't do straightforward, or don't jump to do this primarily as a reconstruction of this area. This is my take.
Thank you, sir. Another common presentation in the post-op period, many of the patients do get a severe periorbital edema in the post-op. So, any standard steps we can take to prevent it?
Uh, while doing dressing, I have shown how to like put a micropore in the forehead area, which will prevent the trickling of the tumescent down below the forehead lines. And we can keep it for 2 to 3 days to so as to whatever tumescent we have put in there, they will get absorbed then and there only. Moreover, we can add topical steroid triamcinolone acetonide into the tumescent solution if possible to avoid this postoperative edema. And there is a practice of giving oral steroid also so as to reduce the inflammation, which can also help us to
Do we
minimize the.
give it routinely, or you add it according to the needs, the oral steroids?
I use it routinely. I use it for a short course, maybe around 6 7 days. That helps a lot.
Manoj sir, you was using that tennis forehead band. Still do you use?
This is a common problem, especially in patients who have a long surgery or you're having a 2 day surgery. Second day, it's off, although you put a micropore that sometimes comes down. I give a headband. It's from, I think, last 20 odd years, 25 years, which is much more sporty. You can wear a cap on top the next day. You see, if you have micro, etc., still public know what something is there. So, and I get a headband which I buy with a particular brand because if it's too tight, then the patient gets a headache. If it's too loose, it still trickles down. So wear a headband for third day, do a shampoo on the third day. In case you still a lot of swelling, maybe put the headband on again for another day and do a shampoo again. Fourth day, take it off. I routinely give steroids orally, 20 milligram prednisolone thrice a day for 3 days. And the triamcinolone in the last part when I'm going to do my implantation, just before that, I will give triamcinolone injection in the tumor site in the area in the front, which is the main area, which is the defaulter, which gets CDMA to come down. So we give it routinely, which minimizes the swelling, but swelling does happen at times. You have to counsel the patient, you teach them how to massage their scalp, and you tell them that if it does happen, don't worry, they will be very worried. It's normal, it'll go away, it'll take a couple of days' time. It'll come from the forehead to the upper eyelid, then the lower eyelid, then the cheek and go away. It is normal, don't worry, it can happen. Counsel them well.
So the next case is about how to yield to the, I mean, how not to yield to the unrealistic expectations from the patient side. This patient with male pattern baldness has a function at back at home and wants results in 2 months of time. Obviously, we cannot deliver, but how to retain such patients, how to counsel them in a first go.
So in such patients, what I'll usually tell them ki you have to know the science. Within 2 months, nothing is possible. No one can make a difference and grow you hair back because you can explain them the baldness has happened over a period of years. So it is not like a magic we can do magic wand. We can just make you regrow back your whole hairs because such patients are usually maybe problematic to you later on also. So you have to consult them. If they agree, that's fine. Otherwise, it's better let go.
My best approach is not to do the hair transplantation. I always advise the patients if you have any important event coming, then don't go for the any kind of surgery because there are the 90% chances that he may get some kind of a complications.
Absolutely, sir.
Yeah, that's why I discourage them and advise them after having your functions, you just come and I will do the for that. That is my approach.
You have to tell him that
There's long hair transplant, and I have an interesting story to tell you. I don't know why people do long hair transplant, but somebody was getting married and did a long hair transplant 3 weeks before the marriage. So he looked very good in the marriage. Everything was okay. But the shedding happened on fourth and fifth week. And he got divorced by his wife because he said, "You fooled me. You have no hair." So one option is long hair transplant, but 2 months is a little away. But better not do something other than put yourself in trouble. You saying something? Sorry.
I think we have to tell him that I have 4 months waiting and you come back after 2 months, I'll give you early appointment.
That was nice. Um, Sir, something about the counseling, like we said, the patient should earn the surgery, and he might need one or two counselings to tone down his expectation, make him optimized medically. So this is again a routine scenario. A patient with a male pattern baldness with a low self-esteem and confidence. How to start him on medical management and when to plan the actual transplant.
See, this kind of patients who have low esteem and low confidence. Sometimes these patients might be suffering from the dysmorphic body syndrome, and in this kind of patients, counseling is very important. By some time, by giving them some medications, pre-medications to these patients, and assess his mental status. If you are still in doubt, then you can refer to him psychologist and get his psychological counseling. And with all these precautions and continuous counseling and giving these some medications, you can buy some time. And if he is agree with your terms and conditions, then you can go for the hair transplantation in these patients after completely judging his mental status.
As this patient relates to my topic, so these patients could be on antidepressants, tricyclic, and using local anesthesia drugs in these could be a problem. So read all the drug interactions before you take this. This could be a red flag.
Absolutely.
So, for post burns or post scar alopecia, sir, this is a 28 years old female with post burn alopecia since 20 years, and she is desiring of hair restoration in her right frontotemporal region. So what is the take of the panel on hair transplant in such cases versus tissue expander? Because both are an option. So how to go ahead between these two options?
I think hair transplantation is the best option for these patients because it is proven well and beyond doubt that we can grow hairs in the scarred area, post-burn scar area, any scarred area. Only a few precautions we have to observe. Manoj Khanna sir already emphasized on those precautions. That is, do not do high density transplantation here. Don't use adrenaline. Don't use too much tumescent here. Only simple hair transplant. This is because see this is not a too vascular area. So doing hair transplantation is not that much bloody here. So without using the adrenaline and without tumescent, we can do the hair transplantation here, and we can do in 2 sittings, 3 sittings, 4 sittings, depending upon the area and availability of the grafts. And what I do, I usually use the FUT grafts. My first preparation is the FUT graft. I never go for the FU graft in this scarred area because Manoj sir always say that after 2 to 3 years, always there is a thinning in FU grafts, and I still believe that because he is my guru, and I have to follow him. So I think we can give the best result with the hair transplantations, and there is no need to do the expansion. Expansion is a very invasive surgery, takes a lot of time, and it is associated with so many complications. So many times there is a extrusion of the expanders and so many things. So better go for the hair transplantation, best option.
Sir, in such
So whenever like I take up such scarring cases, I always usually tell the patient that it's not possible to give the desired density in one go, because since the area is scarred and we have to be like whenever we are implanting, it should be vascular. So if you try to put in more graft, the graft may lose. So better to do it in 1 or 2 sessions, 2 or 3 sessions, depending upon the requirement. And I'll tell the patient, if you're not happy, we can put in more graft later on rather than going in one go. And I have done scarring patients, and I have found that a few grafts do survive. I till now.
uh, just one more point I want clarity from the panel. Do we need to optimize the recipient site in any ways in scarred, post scarred areas?
So usually the whenever like Garg sir also told, the vascular part is little so we can have a more depth in the slit, so that's to have a to penetrate beyond the fibrous tissue and less density. These are the two things which are very important, and the angle should be like more. If you are using a more acute angle, you are still into the scar. So angle should be more obtuse so that we could enter the area below the scar.
Anything for the thinned out skin or subcute layer? Do we address it with some pre-operative fat grafts or something?
Yes, you can do that. You can do some fat grafting, and you can even put some nano fat in the dermal layer, to make it a little better. And there's some massage with the patient, and some fat grafting, deeper layer, and nano graft in this skin layer, the dermal layer. A couple, 2, 3 sessions maybe, in case it's too fibrous or too firm, to improve the condition of the recipient area. That definitely will be beneficial.
So after how many days of fat graft do we take her for a transplant?
At least 3 months, maybe 6 months, even better, but at least 3 months.
Sir, in cases of large area of scalp avulsion, how can we actually proceed? I mean, 40 to 60% of the scalp has been lost to avulsion injuries in women who work in some factories, and their hair get accidentally caught in the spinning machine. So about 70 to 80% of the scalp is lost. So in that cases also we can go ahead with a
We can do the combination of expansion, flap surgery, and hair transplantation.
And we can plan the hairline such a way that it should cover the area, because female have like advantage, they can just part the hairline on the side and they just can pull up the hair on the opposite side, so it might cover and give you a cosmetic feel.
The young lady with complete degrowing of scar. I had managed it with tissue expander plus graft and plus turnover.
Scalp micropigmentation. Yeah.
So sometimes with a bad handling or maybe uncalled patient responses, we might have some complications. How to detect at an earlier stage the impending necrosis, and if at all it happens, how do we manage it?
See, such case do happen, and there is no cause for it. In fact, one of the case happened, and I messaged sir also ki this is my first case. I mean, one of the first cases, and this happened. So what in literature says is it's all because of a high pack in density, which you are putting more number of graft, and there are certain factors which are not in your hand. Also, this is patient dependent factors, and this necrosis can happen. But the treatment is to wait for it, let the HR form. Then there is no need for debridement. It should come out on its own, and after a period of time this scar contracts and we can reimplant those area with a fewer density.
Please don't do skin grafting. I mentioned of skin grafting. No, 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 no. Just debride, give it, moisten it, be conservative, counsel the patient, be with the patient, move along with the patient, be in regular touch. This will fall off. There will be a scar which will shrink. Later on, after maybe 6 months or a year, you can do something, put some hair, do whatever. But never do skin grafting. There'll be bigger trouble unless it's very, very big. Sir.
Sometimes excessive use of adrenaline in your tumescence or what you call local anesthesia can it might happen.
It is also one of the causes. And let me tell you this: people don't believe me, but they have come and seen me, and almost everybody's given up. You do not need adrenaline in the recipient or donor area. You do not need adrenaline. You need adrenaline with the local will prolong the effect of the local anesthesia and the donor area below the donor area, in front of the recipient area below the recipient area. But you do not need adrenaline. And remember, you don't need adrenaline when you're doing something in burns. Why? Because the vascularity will be compromised. So if you are not, if it is compromising there, it can compromise everywhere. You don't need adrenaline. And in a female, please never use adrenaline in the recipient area. The chance of effluent becomes much more, and she will pull your hair out when she loses the hair she's had.
Sir, something about the bro transplant and bro reconstruction, pointers to avoid, and how can we make such results look better?
The very important point, my point is that if it is not too much necessary, it is not must, do not do the eyebrow hair transplantation. Don't do the total eyebrow hair transplantation, because whatever may be the donor area there, the hair quality never matches with the eyebrow hairs. So please leave eyebrow without hair transplant. That is a not option at all. I will discourage everybody and all my patients not to do the hair transplantation in the eyebrow area until unless it is partial hair loss, or just like the post-burn scar or post-traumatic scar. In that cases, definitely we can do the hair transplantation to camouflage whatever eyebrows are there. But it is not option for the total eyebrow. For cosmetic purpose, it is not option to do the eyebrow reconstruction.
I agree with sir. Like eyebrow transplant is little difficult, and the advanced hair transplant procedure, wherein the angle should be oriented very properly. And I also recently came across a case which was operated by dentist, result into such kind of witch hair, and the patient was so depressed, she was not leaving home also. And in that case, even if we try to do it, we have to take out such graft properly and then reorient it accordingly. So it's very difficult.
I think this is for all the students. You're going to get this eyebrow some or other time, and it is very tempting because you'll feel that okay, I'm going to need hardly 500 grafts, and yeah, I'll be able to do it. Trust me, you're going to burn your hands in that. So don't attempt, bro. It's not for the beginners.
Actually, eyebrow transplant is the most difficult transplant of all the areas, you see, because mustache, beard, etc., you can get away and there's not much of a problem, or even the problem, you can look after it. Scalp, you can add density, do whatever, but eyebrow needs certain quality of hair. The direction of the hair keeps changing, from being upwards and inwards to upwards and outwards, and the upper row going down, the lower row going up. And you need much finer hair, thinner hair from the nape of the neck, preferably possible. And the patient has to be told that you have to cut your hair every 4 weeks because the rate of growth of scalp hair is more than eyebrow hair. So they are all very correct. You better stay away unless you're very sure. I've done about 40 eyebrow hair transplants, but been very conservative and good follow up, explain to the patient, all the very important. I saw a very good case of an eyebrow transplant done in Delhi by Dr. A's clinic, where what he did was the patient had big eyebrows on one side and very thin on the other side, and he removed some of the eyebrows on the upper part and the side, which was very good, and put those here. The patient was very worried, and she came and saw me after 3 weeks when there were a lot of scars in this area, but all settled down. And that is one of the best eyebrow transplants I've seen. But again, it is a very, very difficult and tricky area. And unless you're a master, stay away from it.
Sir, how to go ahead with immediate post-transplant folliculitis? What is the protocol regarding management of it?
So such kind of folliculitis do happen when the hair after shading try to poke the dermis. So in that case, like we can go for a topical steroids, and we can use a oral steroid like minocycline for 10 days period of time. But sometimes we need to be very sure about this because sometimes this can be heterogenic anaerobic atypical mycobacterial infection also. So sometimes if your high sterility is not good, so we have to take care of, means we have to think on that lines also if it is not resolving. Otherwise, it will go within like 3-4 weeks.
The post-op period for as a prophylaxis, would you be just adding a single antibiotic or would you like to cover both the positive and the negative spectrums?
The most important thing is that follow all aseptic precautions, and that is the most important thing. Prevention is better than the treatment. And if you feel that there is a any kind of chances of like this because of the some iatrogenic factors are, then we just given the antibiotics and the proper treatment and applying local steroids sometime, that helps subside all these things. And I would like ask Manoj sir how to prevent the cobblestone appearance. That is the most difficult part because in some patients it is not avoidable. I mean that it's not a surgeon's fault, but sometimes it occurs. So, what are the possible causes of this, and how can we prevent this?
Let me finish off with this. Many people also have this problem of folliculitis using minoxidil. They have a lot of problem, and after the post-op period, so switch them off minoxidil. Stop minoxidil for maybe 2 weeks or 3 weeks, and start maybe once a day after that if they are okay. And if they are very fussy, then you can even put them on tablet minoxidil at the time when you have stopped this minoxidil. You can use a steroid like diprobate, plus lotion, etc. Drops, which help them to settle down faster. I do not know how much antibiotics help actually in this because there's no real infection. It's sterile folliculitis. So cleanliness is, I think, one of the important keys. About cobblestoning, that will happen when the grafts are above the surface, which will happen when the slit has not been deep enough for you to put place the this thing in properly. So that has to be looked at when you're doing the surgery. If they're not going in fully, then probably go back and make the slits a little deeper. Also, some surgeons they like removing most of the epidermis from the grafts which they're putting in, so that there's not much of epidermis, not much of crusting, and not much of cobblestoning possibilities there. But the depth of the slit is the key factor. If it's too deep, then there might be venting. You see, of that going inside, pitting, that's called. And if it is not deep enough, then they may be floating on top, causing cobblestoning. So the depth of the slit is very important here.
Thank you, masters, for clearing our doubts and giving us the practical tips to manage our cases. Thank you so much. We would like to conclude this panel discussion.
Thank you.
Thank you to all the panelists and moderators. As we come to the close of today's CME, I request Dr. Parishit Janai sir to kindly deliver the vote of thanks.
So, at the conclusion, let me express my gratitude to our patrons, Dr. Kale sir and Dr. Mishram sir, for blessing this occasion. Um, um, just saying thanks is not enough. To our eminent speakers, Dr. Manoj Khanna sir and Dr. Anil Garg sir. Sir, it was not just a learning experience, but it was an eye opener for all of us to learn so many things from you. Thanks to the audience, offline as well as online, who are so much active to keep the session very interesting. On behalf of CIPS, let me thank all other faculties, especially Dr. Burde sir, for finding some time and staying here for a long time. The event is not possible without our sponsors, so let me acknowledge their contribution to it, the IPCA members. Our venue partners, that is Tuli Imperial, for their food and beverages and rest of the arrangements. Thank you so much. AMS has extended their support, and President was here to grace this occasion. Thank you so much, AMS. Um, 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 we have our audiovisual partner, Yash. Thank you so much for making the CME available across the globe. I have to thank our MOCs for making this a very interesting session. Finally, last but not the least, let me thank our president, Dr. Suresh Savre sir, for single-handedly conducting this entire process. Thank you so much.
On behalf of CIAPS, we thank you all for your participation in today's CME. May the learning and insight shared today continue to inspire us in our practice. Wishing you all the very best. Thank you.